Talk here. It's okay. Hello. Yeah. Morning, guys. This is Dr. Vijay Kumar. I'm the chair. It's my privilege to chair this session. And this is about Dr. Parthiban Ramasamy. Dr. Parthiban Ramasamy is a community-based physiotherapist with 20 plus years of diverse experience spanning education, research, community-based rehabilitation. And is also an expert in ergonomics and corporate social responsibility. He currently serves as a faculty member at the Oxford College of Physiotherapy and is also associated with Movementology Clinics. He currently worked as a research officer for the WHO and the AIFO Joint Action Research on the impact of CBR. His primary areas of interest includes disability and CBR research. And also his other research areas include entrepreneurships, economics, and AI-driven innovation in rehabilitation. Please join me in giving a warm welcome to our distinguished speaker, Dr. Parthiban Ramasamy. Thank you, sir.
Good morning to all. Good morning to all. Thank you. Please proceed. Okay. Please, can you please play the presentation? Good morning to all. My topic will be technology in physiotherapy and rehabilitation, intervention in a community-based rehabilitation. Before going, let me understand what is community-based rehabilitation. Every time people feel like doing physiotherapy at the community as a community-based rehabilitation, which is not actually true. Community physiotherapy is different. Community-based physiotherapy is different and community-based rehabilitation is different. These are all the three distinct areas which I wanted to introduce in the beginning. Community physiotherapy is where the treatment takes place. If you provide a physiotherapy services at a community, it is called community physiotherapy. Just a home care. So community physiotherapy is where the physiotherapy takes place. When it is coming for a community-based physiotherapy, how the physiotherapy takes place? If you are addressing the physical, psychological, social, emotional component, then it becomes a community-based physiotherapy. When it is coming for a community-based rehabilitation, it is beyond a physical rehabilitation. As per the WHO, as per the International Labour Organization, UNICEF and International Disability Developmental Consortium, the community-based rehabilitation defined as a strategy within a general community, So whatever you wanted to do in the community, you had to do in a general, not only for a person with a disability. For the rehabilitation, equalization of opportunities. So whenever we are discussing about a community-based rehabilitation, we have to look the community-based rehabilitation in a human rights framework, not from the medical aspect. For the equalization of opportunity and social inclusion. So whenever we are doing a community-based rehabilitation, we have to consider the social inclusion and mainstreaming the person with a disability. So it is not the person with the disability as a participant, we have to include the person with the disability as a decision taker in the entire program. For all people with the disability, the word of all people with the disability is, you should not plan the community-based rehabilitation only for cerebral palsy or only for spinal cord injury. You have to consider all disability. Again, all disability in India is defined by Right of Person with the Disability Act, which is a 21 kind of disabilities. So whenever you wanted to do the community-based rehabilitation, you have to plan the program for all the 21 kind of disabilities, including their parents and all the decision taker in the community as a general community project for the development and equalization of opportunity in a human rights framework. That is much more important. It is not just doing the physiotherapy at the community. So whenever we feel physiotherapy at the community, that is a community physiotherapy. If you use physical, psychological, social element, that become community-based physiotherapy. Until and unless if you are looking the problem in the human rights framework, until and unless you are including all kind of people with disability, until and unless you are including the stakeholders of the community, it is not a community-based rehabilitation project. That is the first and foremost information. Artificial intelligence. From yesterday morning, we are hearing so much about an artificial intelligence. Again, coming to Warrior sir's quote again, artificial intelligence is new? No, it is very, very old. It is a technology of 1951. The first artificial intelligence program has been written in 1951. So 75 years old. So whenever we think artificial intelligence is new, it is definitely not a new. And 1970, 1956, the word of artificial intelligence has been coined by John McCarthy. Today he is considered as a father of artificial intelligence. The rule-based program, whatever we call it as an algorithm-based program, was the initial rule-based program considered as an artificial intelligence. In 1980s to 1990s, the actual machine learning process started. In 2000, the artificial intelligence has gone for natural language processing method, where the voice recognition and text recognition and image recognition and computer vision has started in 2000. Today where we are? Today artificial intelligence is not just ChatGPT. ChatGPT, whatever we are using today, is a technology of 1950s. So in ChatGPT, artificial intelligence has gone for generative AI. Generative AI in artificial intelligence, in OpenAI, there is a ChatGPT program called Sora. In Sora, if you give it prompt, that create an image. Creating an image for your prompt is considered as generative artificial intelligence. From generative artificial intelligence, we have gone for supercomputer. From supercomputer, the artificial general intelligence has come. AGI has much more complex problem to be solved in a very shortened time. Whatever we are supposed to do for 2000 years, a calculation using quantum computers, we can do it in 6 to 7 minutes. So new invention will come, new drug delivery will come, new climate changes will come. So many changes, whatever the mathematical algorithm supposed to run with the help of supercomputer for 2000 years can be done in 6 to 7 minutes using quantum computer. From quantum computer, we have gone for autonomous AI agent. From autonomous agent, the synthetic intelligence comes. Synthetic intelligence is where the human's kind of emotional intelligence has been already incorporated in the artificial intelligence. So humanoid robots have already started to come. So now the future, what is happening right now today is called as an organic intelligence. Organic intelligence is if you take a patient with a cancer, you no need to give a random drug for a cancer. If the cancer survivor, you take a small part of the cancer and grown in a stem cell method in a lab. And whatever the drug we are supposed to test in the cancer patient, we can test the same cancer related drugs on the type of the cell what has been grown in the lab. So what is more effective, that particular drug can be given. So now the entire medical world, the 3D organ printing and treatment decision taking, everything will change with the help of organized intelligence in another 3 to 4 years. And already organized intelligence is giving a much more promising result that in another 10 years, patient will come and tell you that I have gone for organized intelligence or I have a 3D printed kidney, can you do the rehabilitation program, which you have to be prepared for it. Technology in healthcare. So basically to understand the technology for a physiotherapy or rehabilitation, we have to understand the machine learning program. Machine learning program will, all the large language module and the small language module has been inputted. The large language module is whatever is available in a healthcare, everything is stored in the computer, that is a large language model, a large language AI training. But till, if you take a large language AI training, sometime you will get a result only like a cockerel. Physiotherapy is not effective for any condition. So we have to start something called a small language module. Small language module, we have to take the large language module input. From there we have to give the lesser weightage and take the physiotherapy related specific researches that has been given as a more weightage and develop a specific module of small language module. When the small language modules has been developed, we will have much more positive result. That's where the world is going from LLM to SLM. Deep learning is a computer vision technology where the X-ray or MRI or ECG has been given. The computer has the ability to read the entire report and give what kind of interpretation you wanted to get. Natural language processing. Natural language processing is a voice has been processed as a text, writing has been processed as a text. So now the computer have a ability to recognize a human voice and convert that into the computer type ratings. Computer vision technology again help the AI to understand the images and the pictures. Predictive analysis again a big data analysis consider the large history where we are going to predict the bigger disasters like a COVID kind of another, the bigger disaster can come or not, that can be done. Some of you would have remember Microsoft owner has already told that COVID is going to come and the entire world is going to be locked down 3 years before the actual COVID. So that is a predictive analysis. Robotics are already there. So already robotics doing a decent amount of job in orthopedic surgery, but till the robotic go for much more remote based surgeries. The surgeon can be sitting in California and do the surgery in Manipal Old Airport Road. That is going to happen in another 3 to 4 years. And generative AI synthetic the images and create the drug delivery model and generate the new drug deliveries. And wearable and internet of things. Today everybody is wearing a smartwatch which will detect your heart rate algorithm, which will detect your temperature, which will detect your pulse, which will detect your oxygen saturation and everything. So today the IoT and wearables will go to the next level where the patients are wearing the IoT device, where we are detecting this patient blood pressure has increased, he may get a heart attack. This patient balance is losing, he may going to fall. And we are going to do a lot of predictive and preventative methods in the near future with the help of IoTs. So when it is coming for a physiotherapy, to tell the overview of artificial intelligence in physiotherapy, clinical diagnosis plays a very, very important role where we are going to do a lot of symptom checkers. I have a separate slide on symptom checkers. So how the symptom checker can use. There is, whenever a person who have the problem go on Google, Googling is the disease. Basically it is called as a cyberchondria. When you go on Google, I have a throat pain, it will tell you, you probably have a throat cancer. So if you go for a prompt engineering, if you don't know how to give a prompt, again it will give that it is a throat cancer. If you go for a symptom checkers will consider your age, gender, other symptom and other factors and multiple factors will be considered. It will tell probable diagnosis can start from here. So symptom checkers are going to make much more changes in the world. Treatment algorithm, artificial intelligence based treatment programs are already started to come, and today if a patient who have a ACL injury go and given a very clear prompt, a 26 years old football player who had a ACL injury and undergone LED reconstruction with meniscal repair, please write a program for return to play 3 months to 6 months. The artificial intelligence give week wise program with a very, very clear thing. Okay, today all your patient know the prompt engineering. So they will give a very appropriate prompt and come with a program. If you have to accept it, you should have very strong knowledge to nullify it. Treatment delivery, today exoskeleton process is gone for next level and robotic driven treatment are already gone for a next level. Assessment and monitoring system, there is a wearable sensor, there is a computer vision technology, there is a virtual reality. Yesterday there is a long discussion happened about virtual reality and artificial intelligence, but today I will also show some of the another commercially available wearable sensor and computer visions. Remote monitoring and home exercise program apps. Today there is a lot of exercise prescription apps. Exercise prescription apps are even gone for a computer vision technology where you can do the exercise in front of the computer, where the computer will monitor and guide you, are you doing right or wrong. So it has gone to the different level already. So when it is coming for a community based rehabilitation, my topic is a community based rehabilitation. I wanted to put how the artificial intelligence can work for a community based rehabilitation in a WHO's ILO, UNICEF, UNESCO and IDDC CBR matrix. So there is a community based rehabilitation have 5 components. In 5 components, the first component is a health matrix. When it is a health matrix, there are 5 different kind of activities that has been taken up at the community level. One is health promotion, disease prevention, medical care, rehabilitation and assisted devices. So whatever we discuss as a rehabilitation, physiotherapy is a part of the rehabilitation, but we are also supposed to think about health promotion, disease prevention, medical care, rehabilitation and assisted technology. When it is coming for a health promotion, wearables and fitness apps are going to impact very large. Today everybody will have a smartphone. Everybody's smartphone, there is an app called Google Fit. In a Google Fit, you just activate a Google Fit, it will count the number of steps you walk. And already the Harvard University and WHO come up with guidelines. If you want to have a healthy life, you should have 150 heart point in a week. It means you have to have minimum 6,000 steps and submaximal exercise every day. So when you do this kind of exercise, your sleep will be better. You will not go for a metabolic related disease or lifestyle diseases. So already the health promotion apps are commercial apps are freely available in everybody's smartphone. You have to just install Google Fit, and you have to check for your daily footstep and also daily check for your heart point. If you are doing 150 heart point in a week, you are having an active physical activity at a WHO recommended level. When it is coming for a preventative, the preventative analysis and remote monitoring system with IoT devices are going to be a next thing. But today, if the person wearing a smartphone, smartwatch also monitoring the pulse rate. When there is a pulse rate has gone beyond a particular limit, it trigger a number whatever you are activating. So you can predict this person may have a heart attack, and you can think about rushing to the hospital before even he get a heart attack. So that's what we are going today. Telemedicine and telerehabilitation with the AI triage and medical imaging, artificial intelligence are widely used in medical care. Triage system. So whenever you are supposed to have a patient, if every patient today, most of you might be knowing that in North Karnataka, Hassan district, there are a large number of cardiac deaths has happened. Today everybody wanted to go for cardiac screening. All the Jayadeva hospital has gone 30% overload for last 3 months. So now the triaging system is not established properly. If there is a AI based triage system established, who is supposed to go for a general physician, who is supposed to go for a cardiologist, who is supposed to go for intervention cardiologist? If the triage system is established, the workload with the healthcare system can be reduced. So today there is no much amount of triage system, but in future more amount of triage system will come. And rehabilitation, there is a detailed discussion about the rehabilitation done yesterday. So I am not going for a gamification and VR. Assisted devices, today I am not thinking about a physical assisted devices. There are also assisted devices available for all kind of disability. So WHO has something called GATE, WHO GATE, Global Assistive Technology list. So there are 36 items has been identified as a basic aided appliances which you are supposed to recommend in every country. So one of the common aids and appliances what we use is a spectacle. Like that we are supposed to have the assisted device for all kind of disability. If it is a person with visual impairment, there is a screen reading softwares are available. Today every smartphone available with a screen reading option. If you have a difficulty, you can activate your screen reading system, where your screen reading system will tell about what is happening in your mobile phone without even looking into it. So when it is coming for an education component, again in the education component, childhood education and newborn education, primary education, secondary education, non-formal education, lifelong learning. Childhood education is birth to 6 years. Primary education 7 to 15 years. Then 15 years plus is higher education, and non-formal education is an adult who don't have a formal education, but till considering the age, they can apply for a university qualification. That's a lifelong learning. Non-formal education is an open education system. The lifelong learning is, even today I have to learn to upgrade myself. Whether I am a graduated or educated or uneducated, I should learn something to keep myself always on the top of the field. So that's a lifelong learning. So there is an applications available in every area, and there are a lot of things are already in developmental mode. Parent guidance app. Today there are a lot of parent support groups are available. There are parent specific clinical applications apps are coming up. Today, for example, if the child having a oromotor problem, usually they don't know whom to approach or how to go for it. If there are applications are available, there is a Beckman Oromotor Institution, materials are available, the people started to share it, then people are getting more idea about how you are supposed to address the oromotor problem of child with cerebral palsy. There are a lot of IoT things are happening. When it is coming for a primary education is more about text to speech. Today, screen reading softwares are playing in a crucial role of education of visual impaired. I am associated with a school called Sri Ramana Maharishi Academy for the Blind. We have given around 85 computers for all the students from 6th standard to 10th standard, and all the students write an examination in computer, on their own computer, without anybody's support. So that's what happening today. The 6th student, 7th standard student apply for a common examination with their laptop. So text to speech softwares are really doing a drastic changes in the industry. When it is coming for a higher education, there is a AI curriculums are coming up, the case-based learnings are coming up, and virtual labs and simulation labs are coming up in a drastic level. Non-formal education, micro learning became very, very popular. Most of the people may not be knowing. There is a website called Swayam. The Indian Institute of Technology offer a wide range of courses for everybody, where the courses are free, or sometimes you have to pay 1,000 rupees and write an examination, you can get a degree. Today, if you want to become an ergonomics, Madras University and West Bengal University given a diploma in certificate course in ergonomics, the Swayam portal, where we are supposed to get in 1,000 rupees, you can get an IIT qualification on ergonomics. So micro learning became a very popular concept today. And lifelong learning, integration of assistive technology and AI books and all happening. When it is coming for livelihood, livelihood is about formal job and non-formal job. So workplace accessibility has become very, very crucial in this area. So every workplace supposed to have accessible for all kind of people with a disability. If it is not, it become a legal mandatory now. Okay, I'll go for the next slide. Basically, social component. When it is a social component, everybody have a right to carry their personal assistants. Today there are a lot of AI caregiving chatbots are there, smart home AI monitoring systems are available, AI communication tools are available, teleconsultations are available with the AI chatbot, digital platforms are available. So basically, every component there is a applications are in use or applications are started. When it is coming for empowerment, empowerment is the last component of community-based rehabilitation, where the advocacy and communication, there is a AI tools are available to prepare a lot of communication material easily, and community mobilization, there is a community mapping can be done easily with the help of artificial intelligence. Political participation, today e-governance system has become very popular. All the government websites have accessibility today, and access audit has been done for almost all the websites. So any government website is supposed to be size and font increasable and color changeable. If it is not, usually every government website will undergo that change shortly. Digital learning apps are going drastic changes in a micro financing system in the country. Disabled people organization, the disabled people organizations where the disabled people are coming together and promoting and protecting their rights. There is no much AI, but there are a lot of networking happening across the country. I work with the grassroots level, the district level disabled people organization linked with the state level, and state level organization linked with the national level, and national level organization linked with the DPI. DPI is located in Italy. Okay, so this is about a community-based rehabilitation. So what the AI can do? So one of the common problem of community-based rehabilitation is accessibility and healthcare for all. So what is doing right now? The NHS has already implemented a AI-run physiotherapy. The artificial intelligence run physiotherapy can reduce the waiting list more than 50%, and most of the back pain patient can get an appointment on a same day. In previous scenario, if somebody have a back pain, they have to wait for appointment for a month. Today, with the help of artificial intelligence doing triage as well as the management. So now the patient will get a back pain appointment on the same day in NHS. That is a drastic changes. It is an accessibility for all. There are already AI-based robotics are delivering treatment delivery. This is basically a massage delivered by an artificial intelligence robot. That is going to change. It is going to create a lot of impact in the industry. So when it is coming for a symptom checker, which I told you, I wanted to give a little more introduction about it. So when anybody has a problem, any problem, instead of Googling, instead of going for a chat GPT, today please go for any of the symptom checker. And in symptom checker, you feed all the questions. When you give all the information into your symptom checker, that give much more correct diagnosis compared to all the symptom checker, all the artificial intelligence based software or the another thing. Today there is one more WhatsApp based chatbot has started from Bangalore, where you upload a X-ray, it will tell the interpretation of the X-ray. You upload the MRI, it will tell the interpretation of MRI. That's in the pilot mode. It is happening already in the WhatsApp. You don't need to have any app. You have to just save the number and upload the X-ray, it will give the interpretation. So things are changing drastically. So robotics already started to give a treatment. Robotics is used as a companion, robotics is used as a listener, robotics is as a supporter, robotics as a caregiver, robotics as a exercise therapist also today. Wearable sensor has really changed the way the physiotherapy can do today. There is a lot of wearable sensors where you are supposed to paste the wearable sticker and you started to move around, it will detect all the motion data and convert into the predictive outcome where we are supposed to focus. It can be an objective tool to record your patient outcome. It can be also useful for deciding the treatment. Computer vision. So computer vision again going to act as an alternative therapist where we are supposed to do the remote monitoring. Whenever we are considering about the telehealth, whenever we are thinking about remote monitoring system, we are supposed to understand about the computer vision. The computer vision will detect the human body and it will start to map the joints. The face it will detect around 54 sensor, in the spine it detect only 6 sensor. But till it can give a decent outcome about how your body moves, whether it is moving inline or outline. So in this, okay, there are 3% differences in the knee where we are supposed to go for a deep knee flexion which is not going. So like that there are multiple applications are available. The extra AI vision is much better, Kimati is better, Get Active is working on, AI Physio also doing great. There are multiple applications already available commercially. So when it is coming for fitness industry, artificial intelligence is drastically changing the fitness industry. Today cult and gold gyms are adapting the AI trainer like this. And this is a startup from Bangalore where the life-size cameras are put in front of you. If you are supposed to do in front of the computer, and computer will detect your motion and it will tell how many degree of deviation you are doing from actual workout. So today you no need to go for anywhere. So many softwares are already available for that. So computer vision gamification is already discussed a lot yesterday. Home-based exercise prescription app. Today exercise prescription app started to count your repetition. It will tell 1, 2, 3. After completing the exercise program, it also monitor how is your symptom. It take the feedback. So when I am telling about an advocacy, I wanted to show 2 more slides. This is about advocacy. This is a project called X to Assess. So Google, you all giving a Google review. Like a Google review, how this place is accessible. Now you can give a review and rating about accessibility. I have put an impact of Mangalore Town Hall, have 24% of score, basically 1-star review in terms of accessibility. So you have to just go to the S to accessibility. In future, if any of the patient asking about, I have a plan to go to Ahmedabad, I have a plan to go to Mumbai, where I can stay. You can suggest this website, you install this app and check for the hotel, which hotel have a 100% accessibility. You go there, that place will be accessible for a wheelchair user or visual impairment. Today, this is going much better than the Google rating. So the future is going towards an advocacy using AI and technology. So this is one kind of advocacy which is promoted from Bangalore. Okay, last but not least, any technology try to replace the humans will fail. So any technology try to optimize the physiotherapist or healthcare professional will be successful. To tell the IBM company have a legal firm in the industry where it is have 97% of predictability, which is doing very good. At the same time, $4 billion has been invested in IBM Watson. IBM Healthcare has failed. Okay, IBM Healthcare has failed in terms of cancer rehab. It has expected to change the industry of cancer, but unfortunately, the IBM has, as an artificial intelligence tool, it has failed. Again, Google started a healthcare vertical, which is supposed to be shut down in a very shortened duration. So any technology which is going to replace the physiotherapist will not really sustainable. Any technology which will optimize your efficacy will go for a next level. So you don't need to think too much about artificial intelligence will replace the physiotherapist. It is last slide. Thank you. Before thank you, this is a message from the president of Australian Physiotherapy Association. The last sentence tell about by 2050, the physiotherapist will be working inside the patient body as well as outside the patient body. So be prepared for unexpected things in the near future. That is the impact what you are supposed to learn about an artificial intelligence in healthcare. Thank you for opportunity. Thank you for the organizers and patient audience. Thank you.
Guys, truly it's eye-opener speech, and seriously, he has covered the entire spectrum of advancements we're going to face in the near future. Seriously, every single physio has to embrace technology, and to start with, AI is going to replace, I mean, that's the last thing he said. AI will, our technology should replace, or it should, the question was raised whether it should replace or it should complement physiotherapy. I think the way things going on, we should equip ourselves to say that, yeah, technology should complement. Otherwise, technology will replace. That's what I can see. And I was so impressive with that CBI matrix, which clearly talks about all the cyborg. I think that's the word cyborg. Remember, like 20 years back, cyborg is the word. Now, AI is the word which can replace every single thing you do in your life. I think the CBI matrix was clearly a spectrum of things available to do a comprehensive CBR rehabilitation just on your mobile apps. So I think I would advise our students to, if you guys be an entrepreneur in future, you got to adapt AI, and our speaker is truly resourceful on that aspect. He covered every aspect of CBR matrix, and with a clear examples of how this will be utilized in. And the last thing but not least, I think talking about the accessibility review, that was truly amazing. I think that will help you to, that will help you to, whenever you opening a clinic, ensure that our accessibility will be also reviewed sooner or later. So ensure if you're building a private clinic, ensure that accessibility stays to the standards of or the norms. But thank you, sir. Thank you for the wonderful, talk, and I truly, it was impressive. And ask my moderator to have a few words.
Good morning, everyone. Thank you, sir, for sharing such insightful perspective on evolving role of technology in community rehabilitation. Sir has covered various in-depth conversation regarding AI, how it was actually generated, and how we have incorporated that into the CBR matrix. And he has covered and given good information regarding how these AI tools can be incorporated into the educational system as well. Okay. We will now open the floor for discussion. I'll begin with a question. Usually, sir, we can compare institutional-based rehabilitation and community-based rehabilitation. But in community, when we are talking in community, it's an in-depth conversation. So, based on resource-based, okay, when we are speaking on the base of resource, how can we incorporate this in the urban and the rural population, and how can we bridge the gap?
Hello. Good. Thank you for the question, madam. First and foremost important discussion is about institutional-based rehabilitation is a healthcare model. Community-based rehabilitation is human rights framework. So I should not be discriminated because I am a person with a disability. That's a community-based rehabilitation concept. So whenever we wanted to incorporate the technology in a community, the costing, availability, accessibility, affordability is a major concept. Whenever it is coming for affordability, today there is a possibility called corporate social responsibility. Every corporate is supposed to spend 2% of their profit for a social responsibility. I wanted to give you a very small example of Neo Motion wheelchair. Most of you have seen the Neo Motion wheelchair. Most of the people in Bangalore are all using the Neo Motion wheelchair for Swiggy and Zomato delivery. So it has reached for a larger audience only because of a corporate social responsibility. The actual cost of the wheelchair was 1,08,000 rupees. Today in Association of People with Disability, it is available for 5,000 rupees. It is possible because of the corporate social responsibility partner. Any technology can be taken down to the industry. There is only a language barrier. We have to overcome the language barrier. It is a technology based, and acceptance is fairly enough. If you are underestimating the technology acceptance, we will become a Nokia. Nokia is a pioneer in the industry, failed because they are not predicted. The industry go for massive revolution in a smartphone. So they failed it. The another competitors could think, predict, they could react. So today the community is willing to adopt and accept. There is affordability is a problem. The policy makers as well as the funders and mentors are supposed to change their mentality and promote the appropriate ecosystem. Today if you go to any HDFC ATM, you can see in the right side or left side, inconvenience, regretted, this place is not suitable to build a ramp. I am not worried about they are not building a ramp. At least they are understanding that it is their responsibility to build a ramp. So the change is already begun. We are supposed to be the catalyst to bring the change. We are supposed to advocate for the voiceless people. I continue to do. I request everyone to continue to raise the voice for the people with the disability, because anything you do for person with disability is not only for a person with disability, it is for kids, it is for old age, it is for us in the future.
Thank you, sir. Now I would like to invite questions and thoughts from our audience. Please feel free to share your perspectives.
Thank you. So you have a question? John, so you have a question? Okay. Thank you. Students, anyone has any questions? Okay, so we will wind up. Thank you, sir, for your insightful and thought-provoking session. May I now request our chairperson, Dr. Vijay Kumar, to kindly present a token of appreciation to the speaker. I now request Dr. Vivek to kindly present the mementos to the chairperson and moderator of this session. Thank you all. We will now move to our next distinguished speaker. It is welcome Dr. M.S. Satish, Chief Physiotherapist and Scientist, Department of Physiotherapy, Cancer Institute, Chennai. Sir is a clinician, researcher and educator committed to bridging the gap and advancing evidence-based physiotherapy. It is our privilege to welcome the chairperson for today's session, Dr. Gladson, Principal and Professor, Dr. M.V. Shetty College of Physiotherapy, Mangalore. And this session will be moderated by Dr. Shyam Sundar, Principal, Thiraviyum College of Physiotherapy, Theni, Tamil Nadu. We are sorry for the delay. The moderator was judging the PG presentation. We will start your session, sir. We are so sorry about that. Sir will join in the meantime. I now request Dr. Vijay Kumar, Professor, to kindly welcome sir with the bouquet. Dr. Satish will be giving a talk on cancer rehabilitation updates in oncophysiotherapy and evidence-based approach. Over to Dr. Gladson.
Very good morning to one and all over here. It's my pleasure to welcome the Almighty to be with you today and open your ears and eyes to listen these wonderful sessions. I thank Dr. Ajay, alumni of MVCT College of Physiotherapy and the Registrar of Srinivas University, the Dean, Dr. Trishala, then the whole Tamil Nadu principals are here. I welcome all the delegates. Today, we have a wonderful person here. He is none other than Dr. M.S. Sadish. He is a friend of mine. We are associated with so many programs and all. He has completed his MBT in neurosciences, then PhD in oncophysiotherapy. Since 2004, he is working in Adayar Cancer Institute as the chief physiotherapist and now presently as the scientist D. He is the founder president of Indian Society of Onco Rehabilitation and served as oncology SIG coordinator for WCPT in 2014 to 2020 and has leadership roles in Indian Association of Physiotherapists. He was the treasurer while IAP conference was held in Mahabalipuram. Then he contributed as a chairperson, editorial board member, organizing secretary in many national and international conferences and published many papers. His research focus on cancer-related fatigue, breast cancer-related lymphedema, preventive oncology and rehabilitation following limb salvage surgery. He has been recognized with several honors, including Best Physiotherapist Award. That time I got Best Teacher Award from Dr. MGR Medical University, Tamil Nadu, Distinguished Service Award and Service of Excellence Award in 2019. Oncophysiotherapy is new for some of you. It is there in the syllabus of BPT as well as MPT. And clinical practice, it is very much needed. Only few people are available. In Tata Memorial Hospital, they are doing the research. The Adayar is very famous for the cancer rehabilitation. As he is there for more than 2 decades, you can get his expertise. It is not possible to stop this talk within 20 minutes, but he will give the nutshell of the onco rehabilitation. Let us see and take the inputs from him. Later, you can contact him for further queries and all. I welcome Dr. Sadish. The floor is yours.
Good morning. At the outset, I would like to thank the organizers for the opportunity given. The topic that I will be covering today is cancer rehabilitation, updates, evidence-based approach. Okay. When we say neuro rehabilitation, ortho rehabilitation, it is in our regular system. Whereas when we say cancer rehabilitation, we said that it took this 20, 30 years for us to focus on cancer rehabilitation now. The reason is, for many years, the medical community itself felt that investing on cancer rehabilitation is a drain. It is there in many books that investing in cancer rehabilitation is a drain. But then now as we had advances in medicine and the survival rate has improved, then slowly the shift has come, and many people, the survival rate has improved, and so this concept of cancer rehabilitation is now picking up slowly. And every year, this is about the last year, in India there are, as per the tumor registry data, 13.2 lakh cases were newly diagnosed. Whereas the overall mortality rate, that is not for 1 year, all the old surviving patients, 8.5 lakh patients, it was a mortality rate. So what happens is, every year we have around 5 to 6 lakh added post-cancer sequelae patients who needs this rehabilitation. So cancer rehabilitation is defined as helping a person with cancer to help himself or herself to obtain the maximum physical, social, psychological and vocational functioning within the limits. That is the most important thing, within the limits imposed by the disease and or its treatment. So what is this? Physiotherapy in oncology is now oriented to achieve the optimum quality of life as perceived by the patient. That is the most important thing. This quality of life is something that has to be pursued by the patient, and whatever the patient feels that they are the relatives as a family they see, that is where we plan their rehabilitation. So what are the normal challenges that has been faced by the patients during treatment? Normally, as we all know that chemotherapy and radiation therapy, the side effects are anemia, hair loss or thinning, then bleeding because of the thrombocytopenia, or skin rashes. And these are all the commonest side effects during chemotherapy. And the management of cancer, when we say cancer, it can be solid tumors or non-solid tumors, which is hematological cancers. For solid tumors, the first primary option will be surgical. The next will be a combination of medical and radiation therapy. And whereas for hematological cancers, it is only primarily medical, and to some extent radiation therapy is there. So as of all the side effects of cancer treatment, nausea, diarrhea, fertility issue, fatigue, mucositis, muscle and nerve problem, incoordination, and lung problems, pulmonary problems, those things that has been marked in the green, fatigue, mucositis, muscle and nerve problem, incoordination, and pulmonary problems can be addressed by physiotherapy. That is more because of the 7 or 8 main complications, 5 can be addressed by physiotherapy. So as a physiotherapist, we focus on cancer fatigue management, muscle and nerve problem, as I said earlier, then the pulmonary problems, then the most important thing is the lymphedema issues, then oral mucositis, that is the during chemotherapy and radiation therapy, that plays a very vital thing, where the nutrition status is altered and the completion of treatment itself can be delayed. So in that case, handling this oral mucositis, as a physiotherapist, we will be able to help them out. So this particular study in 2006 by McNally, that was the that gave the shift in paradigm, that exercise training improves the quality of life and exercise capacity and physical functioning, and reduces the fatigue in patients with exercise intolerance due to cancer. So this is about Lance Armstrong, the cyclist who had cancer. He survived cancer. So after complete therapy, Lance Armstrong had 7 times Tour de France championship and 12 years of cancer survivor he was. And then later, due to secondary new primary, he succumbed to the disease. So the main question or the main resistance comes from the patient and their attenders. So these are all the things, because when I started at Cancer Institute 20 years back, first 3 to 5 years, this is the main difficulty that I encountered when I went to the ward to see the patient. The patient attenders and the patients will say, I already have a cancer, I am already fatigued, so why should I do these exercises? But those days we never had that evidence to say that, yes, this exercise will definitely help you out. But then those days it was just only to placebo sort of thing we were doing. But then as the evidence came, now it is in a structured protocol in our institution and most of the cancer treatment protocols. So we need to know the difference between fatigue and cancer-related fatigue. When we say fatigue, the fatigue is something that after a whole day of tiredness, we go relax, immediately the fatigue goes off. Whereas when we say cancer-related fatigue, this cancer-related fatigue is not relieved by rest. This NCCN definition says that cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional and or cognitive tiredness, exhaustion related to cancer or cancer treatment that is not proportional to the recent activities and interferes with the usual functioning. It is always, cancer-related fatigue is always addressed by exercise, structured exercise protocol or activity enhancement programs. So this thing we all know that what is physical activity and exercise, and exercise intolerance is the invariable result of any disturbance in the biochemical pathway that supports this muscle contraction. So here in cancer-related fatigue, there is a, because of the chemotherapy, because of the toxic drugs, lot of axis has been disturbed, circadian rhythm is disturbed, and we have a cardiac toxicity is there. So there is a high amount of exercise intolerance, and as a physiotherapist, we will be able to help them out with structured exercise. So the benefits of exercise, as we know this, it improves the muscle strength, it improves the cardiopulmonary endurance, and the most important thing as far as oncology is concerned, this RBC count is improved. It decreases the fatigue and nausea, which is a very difficult symptom that a patient encounters. And this benefit is believed to come from the effect of hormonal levels, adiposity, and gut transport time, and an endorphins produced by our exercise protocols. So exercise schedule, how to do this exercise schedule? First we need to give a warm-up program for 2 to 3 minutes and elevate the heart rate by 10 to 20 beats per resting. That is the thing normally that we do. And the stretching exercise is for 3 to 5 minutes. And before we give exercise schedule, we need to give it based on this scale. Either in our oncology, normally the performance status, ECOG performance status is commonly followed in India right now, whereas the other scale is performance scale. Based on this performance status only, we tailor make the exercise programs. So as far as the ACSM guidelines is concerned, when the patient has got the KFS score of 70 to 100%, they begin with 15 minutes of conditioning exercise, then increase the time by 1 to 2 minutes each session until a total of 40 minutes per session is achieved, and the exercise is for 5 days per week. And the exercise intensity should be enough to elevate the heart rate between 60 to 80% by the maximum heart rate as estimated by a treadmill or by 6 minutes walk test. Whereas if the patient has got 50 to 70%, it has to be for 55% of the maximum heart rate. And the exercise, when the KFS score is only 50 to 70%, the exercise program is only for 3 days and will go up only to 5 days per week. So this aerobic training exercise, as we said, it improves the cardiac morphology, it improves the blood volume, and it improves the skeletal muscle morphology. And this exercise has a significant role in the angiogenesis. And this is coming to breast cancer rehabilitation. So post breast cancer, post mastectomy, the problem that has been encountered by our patients will be shoulder abduction will be limited. So when the shoulder abduction is limited, within 3 weeks after surgery, the patient needs to go to radiation therapy. So for radiation therapy, the position that the patient needs to be on the table is this position. This will be the position for the patient to be on the table for radiation therapy. So to reach that position within the 2 weeks or 3 weeks, by the 10th day or 13th day, the clips will be removed or the sutures will be removed. Then to attain that range is challenging. We need to have that. Here we have a computer CT thing where if you say this side of right side, a patient A with shoulder abduction more than 90 degree, so less than 90 degree, and the other side patient B has got a shoulder abduction more than 90 degree. So when the patient has got a shoulder abduction less than 90 degree, see when they irradiate, the lungs are not irradiated. Whereas when the shoulder abduction is less than 90 degree, the lungs are also irradiated. So what happens is there will be lung fibrosis, and that causes significant problem to the patient after 3 to 5 years. Same thing, AP thing. See here what happens is when the shoulder is abducted, the lung goes down and it escapes the radiation. Whereas when the shoulder is not abducted above 120 degree, the lung is irradiated. So the most common cancer among, this is the 7th topmost cancer as far as male is concerned in India. So the problems that the patients in head and neck cancer they encounter are mouth opening or trismus, shoulder range of motion dysfunction, pain, chest expansion difficulty, and because of this in head and neck cancer, most of the surgeries are commando surgeries. The overall pectoralis major muscle will be taken off, and so what happens is there will be a tightness of chest, but chest expansion is compromised. We need to work with the patient on that. So as I said earlier, this for oral mucositis, laser, photobiomodulation, that helps the patient a lot. Some 15 years back in BMT, bone marrow transplanted patients, they used to be in the BMT room for 15 to 18 days because the main problem that they will be encountering will be oral mucositis by the 3rd day or 4th day. So once they get the oral mucositis, the nutrition level goes down, so all the other plethora of problems comes in, and so the patient will have to be in BMT, which so once the patient is in the hospital for more than 8 days, the other co-infections come, and that was a problem. Whereas once when this photobiomodulation thing, some 15 years back, we had a discussion with Arunmaya sir, and we started working on this thing. Then with photobiomodulation, from 15 to 18 days hospitalization or the BMT hospital room stay, it came to 8 days. And 15 years back, 13 to 15 lakh that patient used to spend. Now it is only 7 to 8 lakhs. Because the number of stay in the hospitalization, BMT room has come down, and that is primarily because this oral mucositis is addressed. Then the other one is trismus. So we know the treatment for trismus as far as this thing is kind of the jaw stretchers, vorobite, therabite, and other things. This dysphagia normally for ages, most of the oncology centers, they never had a speech and language pathologist. So as a physiotherapist, we were handling it in most of the places. Whereas right now, with the speech and language pathologist appointed, dysphagia has been addressed by speech therapist. Now, musculoskeletal oncology. Musculoskeletal oncology, earlier the treatment was amputation. But right now the treatment is limb salvage surgery, where the limb is salvaged. When you say limb is salvaged, it is either with prosthesis or with the same patient's fibula bone or ulna bone, something has been taken off, a small portion has been taken off, and it is reconstructed. The most important thing is the difference between the normal orthopedic surgery that we see and encore surgery is in normal knee joint replacement or hip joint replacement, it is only the joint and most of the muscles are in place. When you say knee joint replacement, the muscle origin or insertion is always there. Whereas in limb salvage surgery, the muscle origin is not there, insertion is not there. The whole, it is only processes which is there inside, and so the anatomy changes and we need to work accordingly. So this is about a patient who had a total femur replacement. So what happens is when the patient has got cancer in the mid-thigh, so we need to, or the upper mid-thigh. So it covers both epiphyseal and overall bone. So what needs to do is they remove the overall femur, reconstruct it either with the prosthesis, or they nowadays what they do is with the bone cementing and plate. So here the challenges are, first we need to maintain the, understand that positioning during the first 5 to 7 days after surgery is very important, because the fibrosis, we need to give adequate time for the operated area to fibrose. Only then we need to start our exercise. We are used to this quadriceps, static quadriceps exercise for all the patients. Whereas in oncology, for tibial resections, we will not be able to do a static quadriceps for the first 2 weeks. Okay, here. Yeah, the last thing, the local transfer of muscle in order to cover the implant of, that is the most important thing, because in post surgery, because it is processes, the processes is exposed. So what they do is, we need to cover it with a muscle. So some muscle will be taken up to cover the processes, and then that same muscle will be inserted, and so there will be a change in biomechanics. Okay. As I said earlier, this proximal tibia knee joint. This is the second most common site for primary or benign or malignant bone tumors. Limb salvage surgery in the site is more difficult than in most anatomic sites. That is because when you cut the tibia, our extensor apparatus is altered, knee joint extensor apparatus is altered, so it has to be reconstructed, and post reconstruction the rehabilitation plan is first 3 weeks we will not do static quadriceps. So by the time joint will go in for stiffness, and in another 5 weeks patient needs to again go back for chemotherapy. So what happens is within that 5 weeks, 3 weeks patient is immobilized with no knee ROM or no quadriceps exercises. The next 2 weeks we need to enhance and fasten our rehabilitation program and achieve the full ROM, because after 5 weeks patient again goes back to the chemotherapy, and then during chemotherapy our exercise program is definitely challenging, because during chemotherapy patient will again have the thrombocytopenia issues and other things, so it will be challenging. Okay, as I said earlier, the main problem that as a physiotherapist we encounter will be abductor attachment of the greater trochanter is altered. And so what happens is it increases the risk of dislocation in total femur. So we need to give minimum 3 weeks time for it to fibrose, and then we need to start working on that. The other most important thing is hemipelvectomies. Internal hemipelvectomy. Earlier it was amputation. Now with internal hemipelvectomy, the rehabilitation is based upon whether it is type 1, type 2 or type 3. We structure the rehabilitation program accordingly. So this is the rehabilitation protocol that we follow at our cancer institute. As I said, static cordyceps foot, now we have enhanced it to 14th post-op day because it is difficult to wait till 3 weeks. Thank you. Sir, முடிப்பா இங்க நகர முடியும்.
Is there any questions from the audience? You can raise your hands. No questions? Whether you listen the session? Anyhow, you are not much involved in the ongoing rehabilitation. You may not be having much more questions now, but I have few questions. How the RBC will increase if you do the exercise? In my
So thank you for the question, sir. So it is, there are ample studies that says that as with exercise, the demand on the what is this thing spleen, okay, is increased. So what happens is the reduction auto cutting of the RBCs is brought down. So so what happens is, and more than that, when the patient is completely bedridden, not mobile, the demand on the system is less. So when we do exercise as a structured exercise, the demand increases, and so what happens, the overall blood volume, everything improves. So RBC is also improved.
Okay, next question. Most of us are thinking about our hair. So hair loss is the main problem over there. How you tackle the hair loss through physiotherapy?
So it is not, as of now, it is only.
Okay.
Sir, I never said for hair loss it is managed by physiotherapy. Among the thing, minus those top 3, other 5, cancer-related fatigue, nausea, vomiting, then lung condition, all those things will be combated by.
Yeah, few people may say that because of the massage therapy on the head, is it possible?
So that's not my domain, sir.
Then cancer,
Yes.
there you are getting fatigue.
Yes. That is
So how to reduce the fatigue and what are the energy conservation technique we can teach to the patient?
Yes. As I said earlier, sir, cancer-related fatigue is addressed either only by structured exercise or by activity enhancement. So it is based upon that KFS score or ECOG status. If the patient, second day after chemotherapy, if the ECOG status is 3 or KFS score is 50, around 50 KFS score, then we do only activity enhancement as a technique. Activity enhancement as a technique.
Okay, thank you.
Whereas if they have a better KFS score, then we give them structured exercise protocol, the normal exercise protocol, 3 minutes walk and other things, and with resistance band exercises that can be combated.
Thank you, thank you. So you got the idea how you have to debate with the experienced person and get the knowledge from them. If you are simply sitting, you won't get the knowledge. So you have to come forward to ask the questions. On behalf of you, I ask the questions. Thank you very much for the wonderful session We know that you cannot cover all the topics. It's a vast, huge ocean like. And anyhow, you managed to give the nutshell of it. Thank you very much. May God bless.
Thank you, sir.
Thank you, sir, for such a wonderful session. I now request the chairperson and moderator of the session to present a memento to sir. I now request Dr. Aishwarya to please present a token of memento to Gladson sir and Sham sir. Dear delegates, we will now move forward to our third session of the day. It is my esteemed privilege to introduce Dr. John Solomon M., Associate Dean at Manipal College of Health Professions, Mahe, Manipal, Karnataka, and Additional Professor in the Department of Physiotherapy, MCHP, Mahe, Manipal. Sir has vast experience in neurorehabilitation and physiotherapy education, and he continues to inspire countless budding physiotherapists. This session will be chaired by Dr. Kumareshan, Professor and Head of Physiotherapy at St. John's Medical College, Bangalore. And the moderator for this session will be Dr. Shyam Krishnan, Assistant Professor Selection Grade, Department of Physiotherapy, Kasturba Medical College, Mangalore. I now request Dr. Trishala Noronna, Organizing Chairperson of Spark 2025, to welcome John sir with a bouquet. Dr. John Sir will speak on the topic Best Practices in Vestibular Rehabilitation, Do's and Don'ts for Physiotherapists. Let us warmly welcome Dr. John Solomon. I now request Dr. Kumareshan to kindly take over the session.
It's my privilege and honor to introduce the speaker, Dr. John M. Solomon, PT, PhD. He is the Associate Dean at Medical College, Health Profession, Mahe, and Additional Professor in Department of Physiotherapy, and the Coordinator of the Center of Comprehensive Stroke Rehabilitation and Research, Mahe. He completed his BPT from Sri Ramakrishna College of Physiotherapy, Coimbatore, in MPT Neurological Physiotherapy 2003, and the PhD on Virtual Reality Training in Coordination from Mahe 2010. A certified vestibular rehabilitation therapist, he established one of the first vestibular and balance rehabilitation units in India with over 22 years of clinical experience in vertigo management. He further specialized in professional education and leadership through a Farmer Fellowship 2018. Dr. Solomon research focuses on technology-based intervention and motor recovery after stroke. He has led 10 plus funded projects, including international collaborations with McGill University, Canada, and Tel Aviv University, Israel, on virtual reality stroke rehabilitation. He has authored 80 plus Scopus indexed publication with an H-index of 22 Google Scholar. He is regularly invited to speak at global forums such as World Congress Physiotherapy, WCPT, and the World Stroke Organization, and the World Congress of Neurorehabilitation. He serves as several international working groups and committees, including the Executive Board of the International Stroke Rehabilitation and Research Alliance, the European Stroke Organization, the Stroke Guideline Group, and WHO Stroke Rehabilitation Package Review Team. He also contributes to public health policy as an expert working group member for the Government of Tamil Nadu and as a member of Lancet Commission for Neurorehabilitation. Now hand over the stage to Dr. John M. Solomon to enlighten us with this expertise, sir. I welcome you.
Thank you, sir. Thank you very much for a detailed introduction.
Very long introduction.
And I take this opportunity to thank the organizers for giving me this opportunity to talk to you all today on the topic of best practices in vestibular rehabilitation. Again, this has been a passion for me from my postgraduate days when we started seeing patients with vertigo. Because in neuro, often the problem, the thing is that you need to have a lot of patience and you do not see quick results. And when we started working with the ENT patients and when we started treating patients with vertigo, this was one thing that used to give some sort of satisfaction where we find results very quickly. And from then on, we have worked in establishing a vestibular rehabilitation clinic and has been able to support patients who have been suffering from vertigo. So this session, primarily I will be focusing on one aspect, what should be the practice, especially for patients with unilateral vestibular hypofunction. So I will cover a little bit of basic understanding about the vestibular system just to connect it to the problems, to understand what is the problem, why is it happening, and subsequently know what should be the treatment based on evidence-based guidelines that has been drafted and has been recommended for practice. So as we know, we have, all of us have a peripheral vestibular apparatus which is present in our inner ear. So this system basically consists of semicircular canals and the utricle and saccule, which are otolith organs, that basically gives information about the patient's position of head in relation to movement or in relation to gravity. So when we see, primarily these are the main functions of this apparatus. Semicircular canals will tell about angular movement of head, while otoliths tell about the relationship, position of head in relation to gravity, and also how we move, linear acceleration and decelerations. And this apparatus is connected to the brain through a vestibular nerve, which basically carries the signals from this apparatus to the brainstem, where there is a vestibular nuclei. There are nearly 11 small nuclei in this, but primarily if you look at it, there are 4 major nuclei and 7 minor nuclei, and it's easy to remember: superior, inferior, medial, lateral, 4 nuclei. What does this nuclei do is that receive all the information from the vestibular apparatus, process it, and then send the signals to different parts of the brain. That includes cerebellum, cortex. Other than that, it has 2 major output systems, which is very important for us. That is, one is related to the ocular system, that is the vestibulo-ocular reflex. Vestibulo-ocular reflex is nothing but the ability of us to stabilize the gaze when head is on the movement. For example, if you record in camera and if you hold it and walk, entire movements will be jerky. But when we walk, we see the image very clearly. The ability for that adjustment of eye position comes from the vestibulo-ocular reflex mediated by the vestibular system. And the second part is the vestibulospinal reflex. Now this is very important for your balance, and primarily these are nothing but your equilibrium reactions. When you are standing on an unstable surface or you are sitting with feet not supported, when there is a perturbation, the ability to maintain upright positions come from this. So I just spoke about vestibulo-ocular reflex. It's the compensatory eye movement in relation to the head movement. And what should normally happen is that when you move the head at the same speed, the eye should move in the opposite direction. Only then what you see will be visible and clear. This ratio between the velocity of head to the velocity of eye is called as vestibular gain. Now normally this ratio has to be 1:1, the speed in which you move your head and the speed in which you move your eye. But this thing could be affected if there is any disorders. So in patients with impaired vestibular system, vestibulo-ocular reflex as well as vestibulospinal reflex can be affected. Now vestibulospinal reflex, as I told you, is mediated through the vestibulospinal tract to maintain stability. Now there are a lot of vestibular disorders, but we usually classify it as peripheral vestibular disorders and central vestibular disorders. Anything that affects the vestibular apparatus and the nerve comes under peripheral vestibular system disorders, and anything that affects the nucleus and its connection is called central vestibular disorder. So, but if you look at peripheral vestibular system, that is the major part that we deal with. It could or the central vestibular disorder, it could get affected majorly by different reasons. Now, nearly 7.4% of adulthood prevalence is common. That means in anybody's lifetime, almost in 107 people can have any symptom of vertigo due to vestibular system, and it has a very high prevalence and incidence, and it is more likely, 3 times more likely in elderly and more likely in women compared to men. So for this talk we will be focusing primarily on some aspect related to peripheral vestibular disorder, and that too, there are 3 main things in peripheral vestibular disorder. One is BPPV, which is benign paroxysmal positional vertigo. This disorder is basically because of the affection of semicircular canal, where some otolith particles, the otoconia, which are there in the utricle, enters inside the semicircular canal. So depending upon which semicircular canal is affected, and depending upon whether it is stuck to cupula or whether it is free floating in the canal, there are different maneuvers by which it can be cured, and often it is just a single time treatment. And this is a very skill based training. You have to be trained for different maneuvers. Whereas the unilateral vestibular dysfunction, the second one, which is the next common cause for vertigo, is treated through exercises, by prescribing exercises, and there are guidelines specific to that. So again, our focus is going to be in these patients who develop unilateral vestibular hypofunction for this particular talk, because our time is limited to a few minutes or so. So what you should know, the patients with acute unilateral vestibular hypofunction during the acute stage will present with severe vertigo and will have a lot of nausea, vomiting, everything, whereas an imbalance also. And as they move to subacute phase, the symptoms of vertigo starts coming down, but they have vertigo or imbalance during when they start moving, and so affecting mainly balance issues. And in chronic cases, it appears only when you do movements very quickly. So these are some of the things that would happen in acute, subacute and chronic phases. So while assessing these patients, in the entire vestibular evaluation, there are two aspects you have to be evaluating carefully. So which were the two mechanisms that we looked at is, one is vestibulo-ocular reflex, another one is vestibulospinal reflex. So in patients with unilateral vestibular hypofunction, you need to primarily check that. That is, in patients with VOR, whether it is affected or not. So you are going to ask them to look at fix the gaze and then move the head and check for it. And there is also a test called head thrust test that is used to check the vestibular gain. A more objective method is to use a videographic head impulse test, VHIT, that is called as, but it is require a specialized equipment. Whereas in a clinical setup, you can just do using a simple observation method. And the second one is to look at the contribution of vestibular system on balance using a modified clinical test for interaction for balance, where you first make the patient stand with eyes open, then eyes closed, basically cutting down vision, cutting down proprioception by making them stand on a soggy foam, and see where they are dependent on, especially the last condition, they have to be dependent more on the vestibular system. And patients with vestibular dysfunction will sway a lot in this. You can also make them sit on a tilt board or a vestibular ball and move and check whether their vestibulospinal reflex is affected also. So these are some of the common things you would do. So for example, this is a patient in whom I am trying to check the VOR. First, initially the patient didn't get the instruction clearly, so in between I had to stop him and say, see, don't just move your eye here and there. The point is, you have to look at the finger, focus on it and move the head. And when he tries to do so, you can observe whenever he goes to the left side, he is unable to focus on the finger. So significantly, the fixation or VOR is affected when it comes to the movement towards the left side, signifying that he has a left-sided unilateral vestibular hypofunction. He also had typical balance issues also. Now that was a head impulse test that elicited a reduced gain for this. Now usually the recovery after this, it can happen naturally by a compensatory mechanism and also by internal neural plasticity. So even if you don't treat, they will kind of looks like the symptoms will come down, but they will still have difficulty in balance and they will still have difficulty in quick movements, and sometimes they will have dizziness, vertigo also. So it is important that you start treating them as early as possible. So to treat this type of disorders, so if you don't treat early, there could be a maladaptive postural control mechanism which can lead to difficulty in mobility and other things. Also, it's important that patients who are on the medication have to be tapered down so that they can practice exercises regularly. So coming to the main guidelines, how should you treat a patient who have this particular problem? So this was the clinical practice guideline given by APTA. It was given in 2016 first, and then it was later again revised in 2022. There are 10 main statements in this, basically telling what you should do, what you should not do, and basically that's what we are going to see now. So what are the main points? The first thing is about when you should start vestibular rehabilitation. This is again a very debated thing. Often physicians prefer waiting to start vestibular rehabilitation and say, let the symptoms little bit come down, let me put on medication, I'll give Vertin or Sugeron. You wait for 10 days, I'll send him after that. Now what happens is you miss that critical period that starts in the third day or so, which is important to start moving that time. Otherwise then the maladaptation will start set in early. So that's what the guidelines say, that clinicians should offer vestibular rehabilitation in all the stages. You should start from the acute stage. At the same time, if the patient has not taken any treatment and comes to you at chronic stage and very minimal problem with fixing the gaze or balance deficit and all, then it's not that you should not start the treatment. You can start treatment even in chronic stage. So you can start giving vestibular rehabilitation at any stage, but preferably as early as possible, and there is a strong clinical evidence for that, and the recommendation is also strong. So this is what I said, early initiation of movements are important, and if you delay in initiating, high velocity adaptations are going to get affected. Next question is, what type of exercises? See, if you have noticed in many ENT clinics, they will keep one pamphlet. Most of the Vertin and Sugeron company people only will give, sir, you can, along with the tablet, you can give this exercise pamphlet to your patient. They can do it, it will be all right. That is enough for them. This is another problem. Now this, if you look at the pamphlet, it is actually a set of exercises called Cawthron-Cooksey exercises. Now this was the first set of exercises that were developed way back in 1950s-60s. At that time there was not enough understanding about how the vestibular system works. So it will have many things, eye tracking will be there, shoulder shrugging will be there, so many things all together. It doesn't have a proper progression or focus on vestibular apparatus. So you should know what exercises should be given exactly in these patients. So clinicians must give targeted exercises that accomplish specific goals, which I will be explaining which are those. And there is level 2 evidence, not meta-analysis, but level 2 evidence, but again a moderately strong recommendation. What are these targeted exercises? It's primarily you are focusing on improving the vestibulo-ocular reflex and the vestibulospinal reflex. So you are going to start the patient on gaze stabilization exercises and balance exercises that challenge the vestibulospinal reflex, not functional training. It includes much more than that. So what does happen in adaptation? Basically what you are trying to do, you ask the patient to focus on a point and then move, and then when the patient is unable to fix the gaze, there is an error, there is a shift in the retinal image, and that triggers the cerebellum to moderate the firing from the vestibular nucleus, and that helps them to do a better fix. So the stimulus always is something where the patient can focus on. It can be as simple as a letter written on a card or a thumbnail of also. If we don't have the card is the best thing, because you have to write a letter small enough, very visible, and when they move you have to ensure that what you see in the letter is not blurry. That is the speed at which you should work. Or you can even use any object on the monitor, or as simple as anything on the natural environment. It can be a small switch or anything is there. Now these exercises should always incorporate both eye and head movement. Often earlier, long back even, we used to start with only eye tracking, no head movement. But that has changed over time and has said that you can't do only eye tracking. There always should have a head movement along with the gaze fixation. Now this has to be done not just one similar speed, but in different velocities and different speed. So you have to do at once in a small normal speed, sometimes a little faster, and then sometimes slower. So different frequencies in which speed you have to do. So increase the speed, and then the next is perform at the ability of the patient. Patients will start feeling slightly dizzy as you start moving the head. So you need to ensure that they are still able to, when they touch that limit, slight discomfort, you should stop. And ensure that they see it, the image clearly, and move it from slower to faster. Now what are the directions? Not just horizontal movement. For head there are 3 planar movements: pitch, yaw and roll. All 3. Basically we see flexion, extension, lateral flexion and rotation, but not in terms of neck but in terms of head. So all 3 directions you should give. You can also use diagonal neck patterns for doing the movement but fixing on a gaze, particular point. Next question is, what is the dosage? Now again there are recommended dosages. Start with 3 times per day for a total of 12 minutes for individuals with acute to chronic. That means about 3 times a day, means one time about 4 minutes of exercises only. So 3 into 4, 12 minutes of exercises in the early acute phases. So you should not push too much. Later you should increase. Then you go to 3 to 5 times a day, a total of 20 minutes daily for 4 to 6 weeks for individual with chronic vestibular hypofunction. So in the initial stages, when you start in acute, it's always short. More frequent, 3 to 4 minutes exercises only as one set. Morning once, sometime in the afternoon, and evening once. That's all. And each time you should try to ask them to increase the repetition. In chronic stages, you should put much more effort. You should make them do at least 3 to 4 as one set, but at least 4 to 5 times a day, and for 4 to 6 weeks. Now this is the same patient who has come back after 4 weeks. We are checking the vestibulo-ocular reflex. You can see his improved ability to fix the gaze even on the left side when he turns the head. So repetitive gaze stability practice improves the ability of the patient to fix, and that itself reduces vertigo a lot. Okay. Again, this is a gain, and you can see when I turn for left also, there is a good vestibular gain for the patient. Major progressions is through position, and also by challenging the gaze stabilization, by giving a background that is like with boxes and a small letter written there, makes it more focus for them to, makes it difficult for them to focus. And you can also use cognitive dual tasks and all. So these are some of the ways of progression. You should now also incorporate gait. In gait training, again gaze fixation with head movement is important. Look at a particular point and walk, or shift, or look at one point, walk, shift other side and walk. So you have to make them walk and at the same time focus on their vision. So these are some of the aspects. Sudden turns, change in position and obstacle clearance are important. To incorporate the vestibulospinal reflex, you can make the patient sit on the vestibular ball and then perturb it and ask them to maintain their balance. You can also ask them to focus on it, and then focus on a target sitting on the vestibular ball and move the head and maintain the balance. So these are some of the aspects of increased activity. Subsequently, you can, to continue at home, ask the patient to engage in activities that will involve fixation and balance, such as throwing and catching a ball, badminton and kind of activities. Now let's move on to what exercise should not be given. Don't do. As I told you, one of the main things, don't offer just saccadic or smooth pursuit movement in isolation without any head movement, which used to be practiced before. Even I used to do it in my initial PG days. Because there was a study showing even with eye movement in animals, there is some amount of improvement in gaze stability. But in humans later in clinical trials, it's proven that this does not add to anything. So don't give, just only track, follow without any head movement. No, don't do that exercises, not anymore. It has to have a head movement. And that you can see that evidence level also is 1, and it's a very strong recommendation. Usually if you incorporate these exercises, the patients will recover within 3 to 4 weeks. completely the symptoms will resolve. It also depends upon how well they do the exercises, accuracy, and how much variability you are giving in the training. Now, what can negatively impact? What should not happen? One, talk to the physician, bring down the dosage. Usually our ENT will start with 3 times a day medicine, next week twice, and third week once, and then stop. But sometimes some people will start and then continue for 1 month. Now, vestibular suppressant drugs will not only suppress the symptoms but also suppress the rehabilitation process. No adaptation will happen that easily because the vestibular system is suppressed. So it's important. It's important that other aspects are also considered, such as, not okay. Okay. So should the exercise be supervised? Now, or it should be done at home. Now, clinicians should be offer supervised vestibular therapy in unilateral and bilateral when it involves balance exercises especially. So when you put the patient on vestibular ball, walking and moving, the chances of fall is there. So usually first 1 week to 2 weeks, it is good to bring the patient to clinic and ask them to perform there in a supervised environment. Again, there is a high quality evidence and recommendation. Later you can just give it at a home based thing. Okay, this ensures promotion of adherence, lower risk of falls, and better outcomes compared to generic home programs so far. This is what the present evidence says. So 2 to 6 weeks and improve exercise adherence. Later you can move to even tele exercises after the first 2 weeks. When should the vestibular program stop? You should not keep on continuing also. Once the symptoms are resolved and normalized balance function, then you can stop the therapy, and it is a level 2 of evidence. So usually around 3 weeks or so. Other reasons, if the patient status deteriorates, prolonged increase in symptoms, or patient's choice of non-adherence, then you might have to stop. If patient deteriorates, refer back to the physician. Now the final recommendation is that all these exercises should include in a way that improves the quality of life of the patient. Involve functional training so that their quality of life improves. If such as eventually they may be restricted in driving, they may be restricted in going in certain transport. All those things has to be incorporated so that their quality of life improves. To summarize, now you should do a proper evaluation and identify the problem in VOR and VSR, and based on that you have to develop an individualized exercise program. And what we know, early initiation, patient specific progression and adherence are the key factors for optimal outcome. So with that, I hope you get a basic idea and main guidelines that you should follow while treating a patient with unilateral vestibular hyperfunction. With that, I end my talk and open for questions. Thank you.
Thank you, sir, for that enlightening lecture that you delivered. I open the floor for questions. If anybody has any questions, kindly raise your hands. We'll pass on the mic.
Anyone has any questions?
Since I'm not seeing any hands, sir, can I ask you a few questions?
Yeah.
So is there any reason to localize which side the otolith displacement is? And does it matter in terms of what we do? Or does it matter? Localize, for example, what side? Which side, if there's a peripheral vestibular dysfunction, which side is the dysfunction? Is it meaningful to localize it, or does it really not matter?
Yeah, it is very important to localize it.
How do we do that?
One of the main things, that's what there are, one is basically physical examination in VOR itself. The side to which you rotate, there is going to be reduced vestibular gain. So that way you can identify that. Other than that, there are other tests. That is, as I told you, head impulse test, the V-HIT or video head impulse test will tell that. And also you can do a video anastomography or something to identify the side affiliation. The reason for identifying the side affiliation is that you should know what are the movements that where you should focus on, because what happens is when this side is affected, the compensation is that the opposite side will depend upon an inhibitory mechanism. So there is something called inhibitory cutoff. So after a particular velocity, the unaffected side cannot compensate for the movement. So it's not about if you are training more towards one side or more towards the affected, they are more comfortable to the affected side and they may not do to the side that is causing their problem, then again the adaptation chances are coming down. So we need to focus for them to move more towards the affected side, and that is more important for us. So it could be even sometimes focusing not even full movement, but from the center to the affected side is more important, because that's where the retinal slip will also happen and will trigger the adaptation process. So that's it.
So, and the second question which I had is, if there is an otolith dispositioning and if it is not in place where it should be, it's in a canal, and essentially we are training with these exercises.
No. There it is BPPV. So there it is not exercises. It has to be treated as per the maneuver.
Yes,
so that's why in the initial intro I started. So BPPV is something very technical, and you have to diagnose which canal is affected. That is first. Whether it is posterior, anterior or horizontal canal. And in that canal, what is the mechanism? Whether it is canalithiasis or cupulolithiasis. So for each mechanism, we have a different maneuver. And it has to be practically trained, and that has to be performed on the patient. Usually a single setting treatment that will resolve it, and has to be reviewed after 2 days for checking. And there is no exercises for, you don't have to teach them exercises, but after 2 days when they come back, and if the positional vertigo has resolved, but some patients in chronic BPPV may have reduced vestibular hypofunction. They may have vestibular. Then you can start on vestibular adaptation exercises. For till that point, we don't give them any exercises at all. It is only maneuvers that we resolve, and during the review, we have to identify for any VOR or a VSR problem. Then only we will start. Otherwise, no.
Excellent brainstorming session, sir.
Thank you. Thank you,
sir. What are the precautions we must take when using the virtual reality, sir, during a vestibular rehabilitation?
See, usually the most common problems will arise in terms is that one is patients with severe neck pain. Now you want them to move, and they are already in pain and they may not move their head very well. So if you want to start, so all exercises have to include both fixation of eye as well as head. But because of the neck pain, they may not move. So you may have to often treat that first, and then deal with, and then once the pain is reduced, you have to deal with it. Otherwise, you have to come up with a mechanism where in clinic you can still train by ensuring that the patient doesn't move the neck, but using a rotating chair, use their whole body and still train. So that is one way of, so some change you may have to do. Second thing is similarly in terms of patients who have other neurological disorders, if it is there, then you may have to be careful. VBI is one, vertebrobasilar insufficiency. So neck movements again causing any problem. So you have to rule that out before starting on this exercises. These are some of the precautions that we have to take care of.
Last final question, sir.
Yeah.
In your experience, what is the duration for progression of the condition, sir?
So if we start early, so BPPV, if it is BPPV, 2 days. It gets basically resolved on the same day, but then 2 days later you are just going to check. So immediate. For vestibular hypofunction, where VOR affected, 3 weeks. 3 weeks is a standard average period, so it varies between 2 weeks to 6 weeks, but 3 weeks, good resolution will be there if we follow a proper protocol. And in case of chronic patients, 6 weeks, 4 to 6 weeks is what we expect.
Thank you, sir. Thank you for the wonderful session.
Thank you very much, sir, for such a thoughtful and enlightening session.
Thank you. One more question is there.
Yes, sir, please.
I wanted to understand the difference between vestibular hypofunction, cervicogenic dizziness, migraine dizziness.
Migrainous vestibulopathy.
Vestibular hypofunction and cervicogenic dizziness.
With the?
Cervicogenic dizziness.
With the cervicogenic disease. So usually what we do is we have to rule out both. So Cervical vertigo, often the mechanisms are usually due to impaired proprioception from the neck and impaired motor control. So usually what we do is we start treating the patients by working on the neck, stretching the suboccipitalis, increasing the control, and start with proprioceptive training. So we start with eyes closed eye, they have to look at the target close, and then move and come back to the same position and open and see whether it's in the same target. In a clinical setup, we can use certain target placements so that they know how much of error is there. You can use chrome device also. So usually we start with neck proprioceptive training, at the same time ensuring the musculoskeletal system are taken care. Then subsequently increase the exercises where both vestibular components can be treated. But we usually start with addressing the neck first. Okay.
Thank you, sir. I kindly request our chairperson and moderator to present a token of appreciation to Dr. John Solomon M. I further invite Dr. Prem Kumar, convener of SPARK 2025, to present mementos to the chairperson and to the moderator.
Thank you all. Dear participants, it gives me great pleasure to introduce the fourth speaker for today. We are honored to have with us Dr. Samana Syed, Director and Co-founder of U360 Healthcare, Honorary Professor at the National University of Medical Sciences and Senior Consultant at EG Polyclinic, Dubai, UAE. Her dedication to advancing patient care and empowering fellow professionals has been remarkable. This session will be chaired by Dr. Abraham Joshua, Additional Professor in the Department of Physiotherapy, Kasturba Medical College, Mangalore, and will be moderated by Dr. Rachana, Assistant Professor at Srinivas University Institute of Physiotherapy. I now request Dr. Radhika Gopal, Associate Professor, to welcome Samana ma'am with a bouquet. To introduce Dr. Samana Syed, she is based in Mumbai and Dubai, is a distinguished physiotherapist with Masters in Cardiopulmonary Physiotherapy and certification as a cardiovascular and metabolic disease exercise therapist from Singapore. She is widely recognized as the first Indian international COVID rehab global educator and the first international advanced cardiopulmonary educator from India, having conducted over 300 workshops across more than 16 countries and trained over 30,000 students worldwide. She is the director and co-founder of U360 Healthcare and Academy and serves as a professor at National University of Medical Science, Spain and USA. As the founder of the international CPRS and CDRS courses, she has contributed to global healthcare through her expertise in pulmonary and diabetes rehabilitation. Alongside her clinical practice, she is certified in manual therapy for spine and periphery, dry needling, antenatal and postnatal physiotherapy, Neurodynamics and Kinesiotherapy with membership in the Indian Association of Physiotherapists. Dr. Syed's previous professional journey includes serving as head of the Department of General Physiotherapy and Pulmonary Rehabilitation at Krishna Hospital, Chief Physiotherapy Consultant and ICU in charge at Sunshine Hospital, Senior Consulting Physiotherapist, Apollo Clinic, Mumbai, Physiotherapist at Saifi Hospital, and Chief Physiotherapist for the Under-19 Women's Cricket Team. She has also contributed internationally as a head physio at the Clinic Multi-Speciality International Center, Mumbai, and Bujil Hospital of Advanced Sports Surgeries, Dubai, apart from serving as General Secretary of the Sports and Fitness Training Federation of India. A passionate educator and speaker, she has delivered international lectures, workshops, and camps across the Middle East, East Africa, Philippines, Bangladesh, and other countries, focusing on cardiopulmonary physiotherapy, pulmonary rehab, women's health, geriatric physiotherapy, spine health, sports injuries. She's also conducted health talks in Tanzania and Africa, addressing crucial topics. Her contributions extend to media through multiple health shows and interviews in Indian television, as well as international publications and articles, including Times of India. For her outstanding contribution, she's been honored with over 65 healthcare awards, including the Dr. Abdul Kalam Best Doctor Award, Inspiring Doctor of the Year, National Pandemic Warrior, Best Senior PT Clinician, Youth Icon in Physiotherapy, Eminent Women Physio, Outstanding Alumni, and Women Empowerment Award, among many others. With a global vision, academic leadership, and clinical expertise, Dr. Samana Syed continues to be an inspiring figure in advancing physiotherapy, women's health, and cardiopulmonary rehab. We are privileged to have her with us today. Over to you, Dr. Samana Syed.
Thank you. Am I audible? Yeah. Hello everyone, and before going ahead, before starting anything, I would like to thank all the dignitaries of Srinivas College for inviting me, especially Dr. Prem sir, Trishala ma'am, Ajay sir, and a wonderful team who is sitting over here, and amazing students who, even after dancing and singing so much yesterday, giving wonderful performances, actually came here and sat over here. So first, let's start with a huge applause for this conference, team, students, organizers. I can't hear it. Yes, yes, because that's for your effort of sitting here and for the effort of all of these who have actually put their hard work into this. So thank you for inviting me, and without taking any further time, I would like to go ahead. So I think I'll use this. Can I use this? Okay, just start, yeah. Okay, hello sir, hello ma'am. So before going ahead, let me tell you, this, I will just change it. So you know, my topic was actually different. It was COPD and advancements and everything. But you know, after talking to all the students over here and you know, listening to such amazing lectures since yesterday, I decided to change it. And I'll tell you the reason why. Sorry sir, yeah, I'll also tell you the reason why. Can you all tell me how many of you are students over here? Okay, okay. How many of you want to go into MSK and sports? Wonderful. Neuro? Okay, gynac, obstetric, very amazing field nowadays. Cardiopulmonary? See, as you go ahead, the number reduces. So that's why I decided our today's presentation will be this. Can you read that? No presentation. Why? Because I will be talking to you all. Because we all have been learning about a lot of things. But the problem with the current generation is they don't know what to do after learning that. Yes or no? You know, if I could see only 4 to 5 hands for cardiopulmonary, the reason is a lot of people don't even know that what will they do after this field. Agreed? Yes? So now, if I say that, you know, cardiopulmonary is not just for cardiopulmonary physiotherapists. Please let me repeat it. Cardiopulmonary is not just for cardiopulmonary physiotherapists. Will you believe me? Say no, it's okay. Because that's why I'm standing here. So, you know, the thing is, we hear a lot about advancements. You know, cardiopulmonary was actually a flourishing field. Even like 20 years back also, 15 years, I'm in this field for 16 years. 16 years back also, you know, when I started this, I was in a dilemma whether I could, you know, give something or not. And I love pulmonary rehab. And then COVID happened. I'm not saying it's a good thing, but then COVID changed the perception of pulmonary rehab. And now, have you heard about the incidences of heart attacks happening everywhere? Have you heard it or not? Everywhere there are cardiac conditions, everywhere there are youngsters, you know, they are dying because of cardiac arrest. So now I'll ask you, I saw a lot of people, you know, raising hand for MSK. If you get a patient who got a heart attack 1 year before and now coming to you for a knee treatment or a back patient, tell me, without knowing the cardiac rehab post MI phase or on which phase that patient is when he comes to you, how to know the heart rate, how to decide the intensity of that back pain who is coming into your MSK clinic, do you think will you justify your treatment? Tell me, am I right or wrong? Yes? So that is the reason it is important, and I won't say anything without any proofs. So can I have the attention of all the students over here, and even the professors, if they want to do it, they are welcome, but no hard rules for them. Can you all stand up? Come on, it's okay. After this you have a great lunchtime. You can eat as much as you want. So let's do something, you know, let's buck up for something. Yes, very good. Now, can you see this? You all know postural deformities? Yes? Okay? So let's do a quick activity. Fine? Let's go into each and every postural deformity and you will be answering my question. So whatever I'll ask you to do, you will be doing that. Agreed? Do I have everyone? I can't hear? Perfect. So first let's go to with a simple one. You know, rounded shoulder? You all are there in that already. It's the commonest thing. We all are always with our cell phones. So let's start with first one, what I'm saying. Let's go into rounded shoulder. Come on, all of you. I want all kyphoses over here. Go like this. Yes, I want everyone. Everyone. Okay. Little bit more forward head. Now, be in that position and breathe in and breathe out. Come on. Breathe in, breathe out. Breathe in, breathe out. Do you find it difficult? Yes? Come on, next. Let's go into scoliosis. Common. Yes or no? Very common. Functional scoliosis. Arey, half of the people are talking on phones like this nowadays. Yes or no? So come on, let's go into scoliosis. And now breathe in. Breathe in and breathe out. Is it easy or difficult? Come on, Bangalore! Right? Chalo, next. Let's go into tilt. Pelvic tilt, go into anterior pelvic tilt. All of you. Breathe in now. Come on, all of you, breathe in. Is it easy or difficult? Next, let's take lordosis, pregnancy posture. Okay? Lordosis. Come on, go into lordosis, all of you. Breathe in and breathe. Come on, guys. I can see only half lordosis. You all are standing, lordosis. And now breathe in and breathe out. Okay. Now tell me, let's cut with these four one. Did you feel any difficulty while breathing in these few postures? Right? Now tell me, if I say that you get the maximum number of patients with postural abnormality, let it be MSK, sports, neuro, whatever field you are choosing, right? Do you think that without adding the respiratory component in your ergonomics, postural training, core strengthening, are you doing justice with your patients? Also, let me add one thing. We all know stretches, pectoral stretches, we give for kyphosis, we give, stretches for your lats, for scoliosis and all that. But are you treating the rib? Are you treating the muscle over the rib, which is the deepest muscle, and contracting the ribs? And if you're not doing it, are you doing it right? Right? That's all I have to say. Sit down. So I just wanted to add that, you know, how important it is to know the cardiopulmonary aspect irrespective of your field. Why? Because it is not just, you know, when you get a disease, when you are a smoker or you get cardiac arrest, you don't have to wait for that. The world is advancing. People love holistic approach. You know, you have your heart and lungs cannot function well if you have any disease, and if you don't work on your heart and lungs, you cannot treat any disease. And you know, the biggest myth in Indian population and even in a lot of countries is what? They take cardiopulmonary as just cardiopulmonary. Do you know diabetes, lifestyle disorders? It is called as the epidemic of 2021. Every third person, fourth person is getting diabetes. It is a part of cardiopulmonary practice. So basically it is not about, you know, just learning a part, getting into a field. It is applying it. And the most important part is the problem where the system gets affected is because you don't know what you can exactly do with it. Ignore this part. I'll just show you something. You all know about, you all love sports, right? Yes? And I'm sure, you know, sports physio is trending. You know, people are paying so much to sports physios. Everyone wants to do that. Yes or no? But the problem is everyone wants to do that. Yes or no, sir? Everyone wants to do. So by the time you will be coming out of your final years, there will be more 10,000s of physios opting for the same field. And the saturation happens there. If you hit the target when the field is not exposed well, or you know, it is not, you know, you have not really, it's not very common. That is the time you make your name. And I am not showing this picture to you to show what is sports and what is this. I am showing this picture to show how important is respiratory muscle training in sports. Do you know if a person is running, they lose by just 0.1 second sometimes, or just even 1 second matters. That is how we train the athletes. Now imagine if your person is actually, if your athlete is losing a match and he tells you that I couldn't go further. It's not because of their muscle. It is because of their respiratory and cardiac fitness. And that is why the new trend says that if you add RMT, which is called as respiratory muscle training, in any sports activity, for a normal individual, let it be swimming, tennis, running, weightlifters, any, because we do that, then the performance increases much more than the person who is not doing the same activity without adding RMT. And trust me, respiratory muscle training is not deep breathing exercises and just, you know, working on spirometers. It is way beyond that. The way how you treat your biceps, triceps, the muscles of your legs, your back, that's how actually you train. Just like a gym activity, you train your intercostal muscles, you train your diaphragm muscles with equipments. A lot of equipments are trending with TheraBands, with dumbbells. There is a world out there to explore for you, and this is the right time, because now if you get into this field in the next 10 years, you will be standing over here and I will be sitting over there. But if you decide to do this after 10 years, then you will be again sitting in the crowd and, you know, looking up to people, wow, I should have actually done that. So, you know, that is why we say, don't go with the crowd. Unless you don't start thinking out of the box, you will stand nowhere. And the problem again lies is, we don't know. We don't know exactly what to do after we actually do cardiopulmonary, or suppose if you are interested in doing it. Now let me tell you, because since I am a global educator, I keep on visiting countries, and the demand of Indian, I'm talking about Indian cardiopulmonary physio is much higher than any other country, for reasons that still many countries have not introduced this course at a level, you know, where how we have it in India. And second thing, Indian physios rocks outside India. Do you know that? People love Indian physios. And you know, if being in UAE, if I have to go to an Indian and non-Indian physio, we have a global educator here. We have so many people over here. And being an Indian, I'm just focusing on Indian. Europeans are also very good, okay? But you do have good demand of Indian physios everywhere. So now you need to just break down. The thing is that most of the people don't know what they can do after pursuing this profession. and they always think I will get stuck in the hospital. Now tell me, how many of you don't want to do this because you don't want to be only in the hospital? When you're a student, this is what you think, na re yaar, I'll have to just work in the hospital and I really don't want to do this. That is where you need to understand what all actually you can do. So I have just enlisted some of the trending fields where actually cardiopulmonary physios have entered, and you know, they are doing amazingly well and they have made names for themselves. I have not enlisted any field which is not, you know, which is not new or which is very common. So, you know, of course, forget about the hospital part. You can have your own cardiac and pulmonary center. Now, cardiac is pretty expensive. You need awareness, you need attachments. Pulmonary rehab setup is a very, very less investing setup and a huge number of patients. Why? You know, you all stood up. You all did breathing. Yes or no? Yes or no? You all did breathing, no? In abnormal posture, right? You found it difficult. Now, if I tell you, you can add the things that you learn into your ergonomic practice, you can get attached to MNCs. If you work with the postural team, if you work with the sports team, you can add all these things into your sports and MSK. So, it's about creating patients. It is not about just waiting, sitting, letting the pulmonologist and cardiologist refer the patient to you. If I am running my center for 15 years for pulmonary rehab, and even COVID was not there, it is because I knew how to create patients. And that is why today I am standing and telling you this. Create your patients. So if you can see, it's not just cardiopulmonary, diabetes. So you have no idea the amount of diabetic patients you have. And you know what? Whichever field you are, after 5 years, every patient who will come to you, one amongst those patients will be, one amongst three will be a diabetic patient. And you cannot treat a diabetic patient like a normal patient. Do you know that? It's a myth. That is why diabetes rehab is trending. And if you don't know the effect of medicine on heart, sugar level, hypertension, you cannot treat even a basic musculoskeletal case. So you can actually open your own diabetes rehab center where you can add MSK plus diabetes plus respiratory. Then similarly, you have wellness centers. You know, wellness centers are trending so much. I mean, South India is all about wellness. We love coming here, you know, going for Ayurveda and everything. Now they are hiring physios for maintaining lifestyle disorders. And you won't believe it, physios are opening their own wellness centers and hiring others to be a part of it, which actually includes the lifestyle disorders management, which is a part of, again, cardiopulmonary. Second thing is exercise physiologist. Have you heard of exercise physiologist? There are few countries in Europe, US, Australia, where you can actually convert your degree, you can do some additional courses and start working with the main team of doctors, cardiologists, as an exercise physiologist by doing the masters in exercise physiologist. And it's double the pay that you are getting now. Then tele-rehabilitation, of course, we all know that, you know, if you cannot reach someone, don't sit at home, start doing tele-rehabilitation. And the best part of tele-rehabilitation is AI. You have got so many apps. Sir has spoken so much about AI yesterday, Vakar sir. There are so many things about AI that we don't know. Example, suppose I tell you, you can sit at home, you can open the app on phone, put it on your chest for 1 minute and you will get your ECG recording. That's all. You can just have an app, you can have a watch, you will know your entire heart rate, SpO2, your sleep state, your entire activity of cardiac functions. So this is where the world is going and where you have to go ahead. If you can't go to people, let people come to you with tele-rehabilitation. And trust me, physios, all of you, you cannot survive with just one source of income. The world is not like that, and don't wait to get married for other source of income. Right? You have to create your own two sources of income. Not just if you're an educator, get into clinical or tele-rehabilitation. If you're a clinician, get into other multiple fields. So this is how you create an opportunity and platform, not just for others, for your own self. Because you all must have heard, na, physio mein paisa nahi hai. Every time when we are students, we always, yes sir or not, we always hear this, arey yaar, there is no salary, there is no job. But still there are so many physios who are doing so well. How? Because they started thinking out of the box, and that is what is important. Then other than that, of course, I don't need to even tell the next one, content creation. A lot of you are doing that. But let me tell you, don't just be on Instagram. YouTube pays you better. And now TikTok is coming back to India. So, create educational contents. You actually get paid well. You get collaborations. And many brands do get, they approach you. And it is a source of parallel income for a lot of physios around. You can also write blogs. If you are students of 3rd year, 4th year, start writing blogs. You get paid for every word for international blogs. Do you know that? I started it when I was like 10 years back. I used to write blogs for my pocket money. So, wellness blogs actually pay you per word, and you can earn up to like 10,000, 20,000, per month just writing certain blogs. And now you have Chat GPT. So, blog writing is also not even difficult. Gemini, Chat GPT, world is in your plate now. You have to just use it. We used to sit in the library and do it. Then what do you have? Ergonomics and sports, as I spoke about it. So, it's not me. There are researchers that says that if you, just one research, because I promised you no PPT, I'll show you one research. That's all. And this is of 2020, which actually says that when they have given sports athletes RMT, respiratory muscle training, the performance was way better than to the population of athletes itself, whom they didn't give RMTs. So now you know that it is not just, when we talk, these are some equipments for you, like, we have a lot of respiratory muscle training equipments. You have testers which we use in sports rehabilitation. This is actually the only thing I want you all to take from here. I don't want you all to, take, oh, ma'am is promoting cardiopulmonary. Of course I am. Yes, I won't deny the fact, because I love my field and I have explored it, and I feel bad when I see that patient don't want to get into this field because opportunities are so much and they don't have staff. So fill in the gap where the staff is not there. Don't stand in the crowd and wait to get a job where already so many people are doing so well. So the only takeaway from here is, think out of the box, and every patient loves holistic treatment. If a patient with a back pain also comes to you, and if you work on the respiratory and cardiac fitness of that patient as well, then he will become your patient for life. Because everyone loves a doctor who listens to them. Yes or no? That is why everyone loves a doctor and a physio who gives them a holistic approach. And there is where your vital systems comes into picture. So whatever you are choosing in future, let it be neuro, let it be cardiac, let it be sports, gynae, trust me, you cannot do it without respiratory muscle training, which is not just breathing exercise. It's way beyond that. You cannot do it without asking the patient to work in a safe heart zone. You can prevent heart attacks as a physio also. Do you know that? You're seeing a lot of people are getting heart attacks nowadays. Do you know that? See, I'm standing here and I'm telling you as a physio that you can prevent heart attacks. Not by, you can't get into the medicine part, but by teaching and spreading the awareness to every healthy individual to work in a safe heart zone. And how do you do that? A very simple formula, a basic one. You have HR max, 220 minus age, get 85% of that. Now it's too much of detail. If you get any time, if you get an opportunity in future, we will definitely discuss in detail. But yes, if you are well versed with your cardiac and pulmonary part, you can spread the awareness to all the individuals to how to work in their safe heart zone as per their age and as per their underlying condition. And this can prevent so many heart attacks that is happening outside, in the country and outside the country. So that's all. I won't go much in detail. As I promised, it's not a lecture. It was just a discussion. It was just speaking, because I have been talking to a lot of students in the last 2 days. I am basically from Mangalore. 16 years back, I did it from Lakshmi College. And it's an immense pleasure for me to, stand here. I have been there. I know how I used to, run, find a way to just come, go out of the conference hall. So I don't even, I understand how it is to sit in the conference and listen whole day. But still you all came. It's my honor and pleasure. But if I am standing here, I have covered 17 countries in teaching. It is all because I just did this. That's all. I didn't do anything else. And this is what you have to do. So what is the takeaway from this today? Think, come on. I still can't hear. You have lunch now. What it is? That's all. Thank you so much.
Hello. Thank you, ma'am, for this interactive session. I'm sure all the students participated and enjoyed and learned that you have to think out of the box. Yes? So, thank you, ma'am. It was a very amazing session. Thank you. Now I open the floor to the audience, sir, if you want to talk something.
I think any questions from the audience section, if it is there, that will be great. I'm sorry that this is not my area of interest. I was just accidentally here. Can you please, if any questions are there, and then we'll sum it up with the process.
Hello, yeah. So, when we talk about, if you know that 10 years back, till 10 years back, cardiac arrest was the 40 plus age, 45 plus age only people were coming under the category to get cardiac arrest. Now it is 30 and above. Of course, because of the sedentary lifestyle and everything. So when we talk about safe heart zone, there is a lot of calculations that we do. But for a normal person, so as per our age, we have a limit to go beyond a certain heart rate. Okay, so to start with it, we have a huge calculation of target heart rate as per ACSM guidelines, that is American College Society of Medical Sciences. Now, if you don't know any of that, just follow this small formula, 220 minus age. So if someone's age is suppose 30 years, okay, because it's very much common now in young people. So your heart rate will be, HR max will be 190. Okay, as per the guidelines, you should not go beyond 85% of 190 heart rate. Calculate 85% of 190, it will be around 167 or something. So now, if a person of 30 years of treadmill is standing on a 30 years of age is standing on a treadmill, what he has to do is he should not just go beyond 160 degree of 160 heart rate of his. So that is why you calculate in a normal healthy individual. But if it is a patient, we have a stress test. We have cardiopulmonary exercise testing, which also tells you heart rate max. That from that we then calculate the Carnovan's formula, that is safe heart zone. So it is all a part of cardiac rehab that we have to do. Yes.
Nice. Ultra marathon runners are not dying. 50% of death happening in the early morning. That was
early morning. This is a very good question. So do you all know that we all have we have all a cycle of organs in our body. If you will go to Chinese therapy, acupuncture, acupressure, if anyone of you have done that. So in our body, we have like 2 to 3 hours of active and inactive period for all the organs. So if you know, sir, all the heart attacks usually happens between 3 a.m. to 4:30 around that. Do you know that? Early morning, that's what you asked, right? So most of the cases, this is what the question is? Yes, sir? Right? Yes. Okay. So even when I travel midnight, I have given CPR in flights as well around 3:15 a.m. So that is the thing, because that is the period when your body goes into deep sleep. If that is a period of more REM. So now when your body is into that period, your heart rate and your heart function entirely reduces. That is a cardinal cycle of your body.
You are talking about the Chinese...
that is what is applicable in the cardinal cycle is what applicable in our heart, when we manage the heart.
Organ clock theory.
Yes, so I'll tell you something. When I went to, when we treat Chinese patients and all, they actually tell us that we take only pulmonary rehabilitation between 5 to 7 a.m. in the morning. Because 5 to 7 a.m. is the time when your lung functions are maximum active. And this gives the reason of all the religious practice in India. We all want, everyone tells us to pray in morning. Pray, Surya Namaskar, Namaz, everything is in morning. Because they understood back in 1400, 1400 years ago, 3,000 years ago. We are not understanding it now. So that cardinal cycle, when the person goes into deep sleep, the period of which is 2 to 4 a.m. in the morning, and that is the reason sleep tests, sleep apnea tests are done at night, because that is the time when your heart rate and your respiratory rate is absolutely low. And if the person cannot cope up, so usually the person should choke up and get up. If they can't, they die. That is the reason a lot of people are not dying because of cardiac arrest. Sleep apnea is a very big condition nowadays. It's a long COVID complication. And a lot of people are not even aware of sleep apnea. They die in cardiac arrest and then postmortem says they had sleep apnea. So, I'll just tell you this. If any one of you is snoring a lot, have a habit of getting up, waking up with a choke at night, or have suddenly felt that, they are talking a lot at night, moving their arms a lot, please go for sleep test. It is rising in number and the cardiac arrests are rising because of that. So I hope, of course there is a lot ahead of this.
Great insight. Out of box questions, basically out of box question.
How to?
Out of box,
Achha,
thinking out of box question basically. There is a lot of discussion happening about something called heart age. Like a bone age, today there is something called as a heart age.
Yes.
Can you give some insight
Heart
on
age,
it?
right?
Heart age.
So actually I'll tell you something, there is nothing. Yeah, okay. So there is nothing called as such heart age for now. Heart age is a concept where earlier what used to happen after a certain point of time, your LVF, that is your ejection fraction and everything used to come back to normal. But now we have seen EF coming down after 30 years of age itself. So that is why the heart age it has reduced. We are getting pediatric cardiac arrest cases, cardiac arrest below 15 years of age as well. So basically, of course I can go a lot into pathology as well. It all depends on the underlying condition, your lifestyle, your comorbidity. So now that specific time period is not there. Okay, I'm stopping. Okay, that's it. So we can discuss it for the rest of the life. Whenever you want, I'm always there. Thank you so much.
Thank you very much, ma'am. It was really an engaging session. I now request the chairperson and moderator of this session to kindly present a token of appreciation to Dr. Samana Syed. I now request Dr. Madhuripu, Associate Professor at Institute of Physiotherapy, Srinivas University, to present mementos to the chairperson and moderator. Thank you all. Moving ahead, it is now my privilege to welcome our fifth speaker for today. We have with us Dr. Jibu George Varghese, Principal and Professor at the Sri Ramachandra Faculty of Sports and Exercise Sciences, Chennai, Tamil Nadu. He delivers physiotherapy with both heart and clinical precision, especially renowned for his intuitive teaching of manual therapy techniques. This session will be chaired by Dr. M.S. Satish, Chief Physiotherapist and Scientist, Cancer Institute, Chennai, and moderated by Dr. Muthupande Kumar, Lecturer, PT, NIE, PMD, CRC, Madurai. Dr. Jibu George Varghese will be now welcomed by Dr. Aishwarya Sonwane with a flower bouquet. Dr. Jibu, sir, will be delivering a talk on the Mulligan concept application to shoulder dysfunctions, the manual therapy approach. Let us all put our hands together to welcome Dr. Jibu George Varghese. I now invite Dr. M.S. Satish to take charge of the session. Over to you, sir.
Thank you, madam. So it gives me immense pleasure to introduce Professor Jibu George Varghese, a good friend of mine. He's a senior academician with over 20 years of experience in academics and clinical management of musculoskeletal dysfunction and sports injuries. He is an accredited instructor of our specialized in the Mulligan concept of manual therapy. He has conducted 51 national and 9 international workshops. He is recognized with several academic and clinical awards for his contribution to musculoskeletal rehabilitation and manual therapy. He has been associated with leading universities across India and currently serving as the professor and principal at the Sri Ramachandra Faculty of Sports and Exercise Sciences. Over to you, Dr. Jibu. Please come. Thank you.
Good afternoon, everyone. It's a pre-lunch session, so I request you to bear with me for 20 to 25 minutes. Yeah, thank you. So anyway, thank you, sir, for introducing me. Before I start, I would like to offer all my gratitude to the Almighty, who has been my strong support, and as a creator of the universe, He has been my guiding light throughout the last so many years of my career, and of course to various teachers over the period of years, and the number of patients that I have seen over the period of years, from whom I have learned a lot. Because most of the time to my students, I always tell them every patient is a chapter in a book, because you don't get to learn the same thing from a textbook. Yep. So what I have learned, what I am going to present here, is more of my experience from the various clinical insights that I have gained over the year from treating different clients. So the topic for today's presentation is application of the Mulligan concept of manual therapy in shoulder dysfunctions. So I wouldn't be limiting to Mulligan concept, but I would also be touching upon the other adjuncts, what we do basically. And this is basically where I hail from. I work at Sri Ramachandra Center for Sports Science, which is an integral part of the Sri Ramachandra Institute of Higher Education and Research at Chennai. And ours is a very unique center in the whole of the country, and in fact in Asia, where we have an integrated center for sports science along with sports medicine. So we are headed by our director, who is an arthroscopic surgeon, and we have a wonderful team of sports medicine specialists. Along with that, we also have the sports science team, and the sports science, we have the sports rehabilitation, of which the physiotherapists are a part, the sports physiotherapists. And then we also have a very well equipped gymnasium of international standards, and then we also have a cool down pool in our center, and state-of-the-art facility at the biomechanics lab, which is again updated recently, and we are also tied up with ICC for suspect balling action, and we do various researches there, starting from cricket, not just limited to cricket. We go with football, we go with hockey, and we also go with biomechanical analysis of rowing action. And then we also have an in-house rowing lake, and we have the Sri Ramachandra Water Sports Center, where we have water sports such as rowing, canoeing and kayaking. And then we also have the shooting range, and the recent gold medalist Ilavanil from the Asian Shooting Championships, she has been training at our center, and she has many times given her testimonials how sports science helps in her performance, especially a lot of gratitude to the sports physiotherapists. And that's our campus that you see on the third line. And towards the last, again, you also see the internationally accredited hockey turf. And that's our exercise physiology lab, again, state-of-the-art exercise physiology labs, We also have the treadmill lab as well as the cycle ergometer lab and a very wonderful sports psychology lab. And various courses we have there. We have the BSc Hons in Sports and Exercise Science. We also have the MSc in Sports and Exercise Psychology, which is a much sought after field today. And we also have our MPT in sports. And to the youngsters out there, I would just like to brief on what the profession is. Like, it's not that you don't know, but I would like to just emphasize on a few points. Like, basically, a physiotherapist is known to be a movement scientist, where you look at the movements. We had a wonderful presentation on during the PG paper presentations yesterday, where there was a talk on research on gait analysis and all. So that's a very interesting field. And we look at the movement science, the way a person moves. And like my professor used to tell me, when you watch a dance sequence in a movie, always try to look at the biomechanics of the dancers. Don't get interested into, don't get deviated into the other aspects. And then our physiotherapy as a profession is always interesting and exciting. You can always find something new there. It's like a treasure hunt. You are looking for the culprit. You are looking for solving crimes or solving issues. Who is the culprit there causing the dysfunction or disturbance to the client? So that's very interesting out there. And it's rewarding as well, not just on the monetary side, but also on the self-satisfaction side. And it's most humane. We spend a lot of time with the patients. The patients interact a lot with us, and they try to explain themselves to us, and we lend them hearing ear. We lend them our ears, and they start listening to us, and not just listening. And finally, we see that, somewhere they start developing a trust in us. And that's the most wonderful experience that I have been having, especially after treatment. The patient says later, when they develop other systemic issues, it might be even a gastritis, it might be abdominal pain, they call us and ask, what should I do? What do you think it could be? And I would say it is a really a gifted insight for me, because if I feel that is something that needs to be seen by some other speciality, I would definitely say, why don't you go and meet this doctor? And we see a lot of courtesies being exchanged there. The specialists talk to us and we talk back to them. But at the same time, for those of you who are not experienced or exposed to the field of visceral manipulation, I'm sure Weiss would definitely agree on that, on the field of visceral manipulation, where you have musculoskeletal manifestations of organ dysfunction. And treating the organs can help a lot in that respect. And I myself, I have had the privilege to treat a few of them and see the beautiful results coming out of those as well. But unfortunately, our public or the population is not very much knowledgeable about such an intervention that a therapist can do. But in different ways, by giving different exercises, the yoga asanas that some of us do apply on the patients, or some of the stretching exercises that we do, indirectly we are also stretching the visceral fascia, and that gives out good results. Yep. So, and attending to clients is always a learning experience, that as I said in the starting, and it's an ever-growing profession, and it covers every age and functional aspect of the human lifetime, like pediatrics, geriatrics, industrial health, sports injuries, etc. And my take on my interest in the field, or if a budding physio comes to me and asks me, sir, which field should I take? Which field has more scope? My answer is always, what is your field of interest? Which did fascinate you the most? Was it the musculoskeletal part? Was it the neurological part? Do you like to read a lot about the brain and the spinal cord? Or was it the gynecological part, which is, according to me, a gold mine? The gynecological part, isn't it? Now, for musculoskeletal patients, somebody should develop back pain, isn't it? Or somebody should meet with trauma, then they can be referred to a musculoskeletal physiotherapist after the orthopedic surgery management. But gynecology, it's a way of life, isn't it? It's a part and parcel of life, obstetrics and gynecology. So patients are guaranteed, isn't it? So that's a definite guarantee for the gynec physios there, whereas how many of our musculoskeletal physios come out there, it's not sufficient. We don't know. But we don't know what is the type of number of patients that we might come across. Yeah. And then a very important slide for any manual therapist or any physiotherapist before you attend to a client. You are bound to follow this. You need to know what are the clinical flags. You need to rule out the flags. You need to make sure. So one of my professors used to teach me from the US. He used to tell me, what is the first step you will do as a physiotherapist when a patient comes to you? Because today we have the National Commission coming up, and they are also giving us a lot of power nowadays. They are saying physios can go in for first contact practice. But then, like what those of you who have seen Batman, what is the dialogue in that? With a lot of power comes a lot of responsibilities. Excellent. So there's a lot of responsibility also along with power. So in order to fulfill the responsibility, you need to have sufficient knowledge. So when a patient comes directly to you, so far when we were not in first contact practice, when a doctor is referring a patient to me, the doctor writes the prescription, give IFT or give exercises or give low back pain exercises or this so and so stretching. So the good thing in that is whatever is the outcome of the treatment, good or even if it is a negative outcome, I don't have to be held responsible because it's the doctor who referred it to me. I gave what the doctor said. But when it comes to a first contact practice, when the patient comes to you directly, if the patient is coming with back pain, it's your responsibility to identify what is the source of pain. The source of pain can be a fatigue muscle. It can be an strained muscle. It can be a stiff intervertebral joint, facet joint, or it can be a kinetic chain which is disrupted. At the same time, it can also be an infective spondylitis. The patient has been having on and off fevers for which he has been just suppressing the fever with medications. He can also be having an infective spondylitis with a damage, infective damage or erosion to the posterior or the central restraint systems of the spine. And if you end up doing manual therapy for any such clients, it can prove detrimental or it can be causing a lot of damage there. So that's why first contact practice, it's mandatory that the council will definitely have to have some guidelines or a sort of an examination where the physios will have to clear the basic knowledge to go in for first contact practice. The red flags, it's there, you can read it by yourself. The red flags, orange flags, yellow flags, and the blue flags. And then coming to the area of the topic today, the shoulder. So third most common musculoskeletal complaints are presented to the physiotherapist from the shoulder region. And we do have some favorite diagnoses also, and such as adhesive capsulitis or frozen shoulder, sternoclavicular pain, rotator cuff injuries, bicipital tendinitis, acromioclavicular pain, supraspinatus tendinitis, and various other diagnoses. But before that, we need to look into the basics. Where is the building area of knowledge? Where do you have to acquire knowledge from? That's why we have a beautiful curriculum being designed, and we have a hierarchy in the curriculum as well, isn't it? We study anatomy and then physiology. We understand what is the base of the human body, and then from there we go into the biomechanics, the functional or the kinesiology. How does the body work? What are the components? What are the influence of the movements on these basic systems? How does movement? Now, you know what is mobility? We talk about mobility of joints. I'm sure Vice will be more interested about the motility of the organs. There's a lot of movement for every organ, and that's what visceral manipulation is all about. And when those motility of the organs are being affected, that can manifest as musculoskeletal dysfunction. Yes, if you look at the shoulder, we have, of course, we have the glenohumeral joint, sternoclavicular joint, the acromioclavicular joint, and we also have the functional joint, which is the scapula. Now, what other structure do you think is connected? We did speak about the scapula and we did speak about the clavicle. But next, if you look at the spine, now do you see a connection between C6, C7 and the shoulder? There is no direct connection between C6, C7 and the shoulder. One of the common postural changes that we see today, what is that? Common postural changes. the forwarded posture. So where does the forwarded posture start? How does a patient, have you seen any patient sitting like this? Are you sure? Watch me now. The biggest asset of a physiotherapist is his observational skills. Do you see any patient sitting like this, or is it like this? First one or second one? Second one. So what is the combination there? So nobody sits like this. Nobody wants to sit like this. What is the first thing you do? A person who is going in for a forward neck posture, you can see that he goes in for exaggerated thoracic kyphosis. And if you go in for exaggerated thoracic kyphosis, the orientation of the head over the spine has to change. Because if you go down there, you get to watch there. So what business do we have there? Nothing. So our business is there. That's the horizontal visual field. And then he corrects it up to there. So when he corrects it up to there, you have a forwarded posture. In a forwarded posture, what is the primary muscle which is responsible or which is put under strain or which leads to fatigue in a forwarded posture? Name the muscle. Forwarded posture. Sorry? It's okay. You can give a wrong answer. Maybe you can just close your face. You don't have to show yourself out. Just shout out the answer. Okay, which muscle is most active in a forwarded posture? Trapezius? Anything else? Anything else? Okay, in a forwarded posture, do we have flexion or extension of the cervical spine? Flexion or extension? Please check it properly. In a forwarded posture, we got extension of the upper cervical and flexion of the lower cervical. Forward translation of the segments of the middle and lower cervical. Clear? Now, which muscle is responsible for this? Bilateral contraction of the sternocleidomastoid. Bilateral contraction of the sternocleidomastoid. We have the attachments of the sternocleidomastoid. One attachment is anterior, the other attachment is posterior. Got it? So when it contracts, it pulls it down there. Bilateral. But if I ask you the unilateral action, I'm sure all of you will say that. Because that is one of the favorite answers which all our physiotherapists have. Isn't it? And you learned it. When did you learn it? In your exercise therapy, when you were practicing stretching for torticollis. Isn't it? So what's the action? Same side, flexion, and opposite side rotation. But try to think of the bilateral action also when they contract together. So that also has an impact. Similarly, you were talking about levator scapulae, and then there is also our trapezius, isn't it? So these are the invisible connections that we have from the scapulae or from the clavicle, from the humerus to the cervical spine. Does shoulder have a connection with the low back? Is there a connection between the shoulder and the low back? What's the, not the front row, from back. So what's the structure? What is one muscular structure? Now we have, well, I am working in a sports science center. We have athletes, we have rowers coming with low back pain. Got it? And we also have shooters who carry the heavy rifles coming with low back pain. We also have swimmers coming with low back pain. Now you should get the clue. So which muscle is called as the swimmer's muscle? Yes, so what's the relationship between the lumbar spine and the latissimus dorsi? Where is it originating from? From the iliac crest. Iliac crest, and it has attachments along the spinous process and transverse process of lumbar spine and the C7 to T7, I'm sorry, T7 to T12, isn't it? And all the way from there it connects to the inferior angle of the scapula, and then finally it goes up, yeah? So these are the different layers that you see here, and there you go. Can you see the latissimus dorsi here? So this is the latissimus dorsi we are looking at. Clear? So if an athlete who is a swimmer who uses a lot of upper extremity is coming to you, and then he says, I got pain in the low back. So what are the connections that we can look into? Or let's go to our favorite sport, national sport. Even national sport is hockey, but national sport of interest, cricket. So a fast bowler who does deceleration, we attribute it a lot to the, where do we attribute it a lot to? A fast bowler or a spin bowler getting injured. We are always after the rotator cuff, isn't it? So whether we like it or not, we want the rotator cuff to be injured in a shoulder case, especially in a bowler. So when you look into the depth, you can also see that when you start rotating it, so what is the action of latissimus dorsi? What is the action of latissimus dorsi? Depression of the shoulder, extension of the shoulder and medial rotation, isn't it? Shoulder girdle depression, isn't it? So in a bowling action, when you go all the way there, when they do it this repeatedly, they are repeatedly fatiguing also the latissimus dorsi. So what is one of the commonest lumbar injuries in fast bowlers? Stress fractures of the lumbar spine. Stress fractures of the lumbar spine. So are they addressing that during their strength and conditioning sessions? Are they addressing it during their physio sessions? That needs to be checked into. Clear? Now what is this muscle here? What is this muscle here? 1, 2, 3, 4, 5, 8. You have 8. The number 8 gives away the answer, isn't it? 8 fleshy digitations. So you can see that coming out from here, from the ribs, isn't it? Got it? You see that? So if you have a rib dysfunction, so how can you get a rib dysfunction? How can somebody get a rib dysfunction? It's not a direct injury always. Suppose you are weight bearing on the ribs. Do you weight bear on the ribs? Do our patients do weight bearing on the ribs? How do you weight bear on the ribs? Side lying. Side lying is weight bearing. And one particular day he happens to have a cough. He is having a cold. He is coughing and sneezing in side lying. So what is he doing? Expanding and shortening the rib cage, isn't it? On one side he is weight bearing, on the other side he is completely free to move. So can he cause a dysfunction at the costovertebral and costotransverse joints by restricting the mobility at one side and affect the symmetry of the movement? Is it possible? So you can always check for the symmetry of the rib movements as well. And you will be surprised to see in Mulligan concept we have intercostal MWMs. When you give a gentle glide to the rib and the pain just vanishes away. From a severe sharp shooting pain, patient says, now I am able to do it. But don't take your hand away, keep the hand there. So how long can I keep the hand there? So then we teach the patient the self-mobilization MWMs. We teach him how to hold the ribs, how to get into the intercostal space and then assist along with the breathing, self-assist along with the breathing. And then he feels much better later. Okay? And then the muscular rehabilitation part, we do it much later again. So that's the cardiopulmonary part that a sports physiotherapist can also do in this way. And then, due to lack of time, I'm not going to touch on all these points. We can describe a lot about all these muscles there. Anyway. Then we do have nerves as well. We have patients coming to us complaining with sharp shooting pain into the shoulder region and pain from the shoulder region into the arm. It can also be a Scalini syndrome. Clear? Please check up what is the Scalini syndrome. Now, assessment skills, quite important. According to me, I always believe, for me, treatment, once I have mastered the skill of how to treat, how to do the hands-on treatment, I'm already done. But the challenge always remains for me to assess the patient properly. How do we assess a client? So that's very important. I'll give you an ART acronym. I'll give you an easy way of how to do it. What is the commonest thing that you can look into? Because this is like you answered in the previous session. This is one of the commonest challenges that most of the budding or freshly passed out physios always face. How do I assess? Where do I reach to a conclusion? How do I know whether I have reached the correct conclusion? Believe me, after all these years, even I don't still have a 100% guarantee that I have reached the exact conclusion. You understand what I'm saying? Because every dysfunction may or may not have a sequel. When we say sequel, what does that mean? When we say sequel, you can have a primary dysfunction. That primary dysfunction can cause a secondary injury. a secondary dysfunction, and even maybe a tertiary dysfunction. So what are you going to treat first? That is always a dilemma for any experienced physio also. He is just going to try out all 2 or 3 and see which one works better. Do you understand? It's a story about which came first. Was it the hen or the egg? Nobody has the answer to that, isn't it? But it's similar right here as well. So your journey as a clinician, it always begins with integrity and dedication. So what is integrity? Basically, what is integrity? As a subordinate or as a junior, doing the right thing, are you hungry? You want to go first? Okay. So doing the right thing even when nobody is watching you, that is integrity and dedication. So when do you do something with integrity? When you have some good objective towards it, a good purpose towards it, you want a positive outcome from it. You get my point? You get the point? So nobody is watching you, but you still want to do the right thing, isn't it? So why is that? You have some good intention out of it. It can be beneficial to you, it can be beneficial en masse. That's a different thing. So from beginner to, so that's how you become a beginner, and from beginner, that's how your journey goes towards being an expert. And then learning a skill comes with practice and also practicing it in the right way. That's how we are in the Mulligan Concept Teachers Association, of which I am a part. We have bi-yearly meetings. Once in every 2 years, we have international meetings where we go attend the meetings and we start discussing our own techniques. And if any teacher has to introduce a new technique, we also do that as well. Clear? They teach us and we discuss the plus and minus of those techniques. Can that further be modified? And finally, that's what we present in our MCTA meetings. So we have an international group where we meet together, interact, decide, and all of them are of minimum 15 years of experience in the field already. Clear? So that's how we decide on those techniques and we deliver the techniques, or we teach the techniques to the budding physios out there or to the practicing clinicians. Clear? So when we teach something, we want to make sure that we are giving the right source of technique and the best source of technique. Keen observations, like I just mentioned, one of the biggest asset for a physiotherapist is going to be our power of observing. Now you watch a lady walk in a particular fashion. You can always guess, maybe she's got something to do with, she's got an imbalance between the hip abductors, isn't it? So that's possible. Now the question is, a second person who watches says, sir, maybe it's not the hip abductors, it can be the tightness of the quadratus lumborum. Or another person says, I don't think it's both, I think she has something to do with the SI joint is painful for her. So it can go on and on, the observation, but then you confirm it later with your interventional diagnosis. And then palpatory skills, very important, and that is also an asset of the physios today. Detailed and selective examination, and very important point, avoiding a bias. A patient comes limping to you, you immediately say, what do you are, let's say you are standing in a market, or all of you have gone for shopping and you are all physios. Suddenly your physio instincts start getting sharp and you start limping into you watch a person who's coming to you limping. And then one person says, I think he has problem with the ankle. Another person says, I think he has problem with the knee joint. Another person says, no, it can't be knee joint. I think in the stance phase, she is reducing the stance phase, so it has to be the SI joint. Another person says there's a hip pathology. And finally the patient comes to the group, approaches the group and asks, my sandal is broken, where is the nearest cobbler available? Do you get the point? So it's none of these diagnoses. It is the sandal which is broken. So we jump into conclusions. Let's not do that. And then rationalize your findings. Now how would you rationalize the findings? We have the kinesiology or the biomechanics, the critical movement analysis, identifying the pathomechanics. To identify the pathomechanics, you need to know the kinetic chain. That's very important. Both the skeletal as well as the muscular, and also the facial linings. Lateral thinking is very important. The various possibilities of the cause of the dysfunction. Integrating basics with clinical findings is very important. More exposure to similar case scenarios helps to recognize and realize the signs and symptoms and the findings of the assessment. This is one thing I would like to also request my senior colleagues here who are seated here. Many a times we give importance in research towards systemic review and to RCTs. But I feel in physiotherapy there is a lot of importance towards a case series or individual case findings, because no two patients are the same. That is what I always feel. And somehow we are following the larger, maybe it is some larger force which is pushing us towards doing only RCTs and systematic reviews and meta-analysis. But then case series and case studies have its own importance in physiotherapy. And coming to the shorter acronym that I was talking about is ART. Asymmetry, restriction of mobility and tissue texture abnormality. Asymmetry, most of the areas we see there are changes. There are, if you look at the patients, you look for asymmetrical changes. Most of the side, we have the right side and the left side, including the spine. You can see the spine bent towards the right side. Am I right? You can see the spine bent towards the right side or the left side, isn't it? So when you see that, what do you understand? What can you hypothesize? There is, when you palpate, use your palpatory skill, there is restriction of mobility. And when there is restriction of mobility, what is causing the restriction of mobility? Is it joint or is it the soft tissue? That comes with your tissue texture abnormality, which you learn through palpation. Sir, just 2 minutes. Just 2 minutes. I know you will agree. So, goal settings, I'm just running through fast. Goal settings, client education, symptom modification or symptom elimination. I don't say symptom elimination always, because sometimes, like chronic cases of adhesive capsulitis, you may have to work longer and you may have residual deficits. That is inevitable. Functional re-education, maintenance of functional progression, all these are important. Next, so that's Brian Mulligan there, and this is the group of worldwide instructors that we are across the world. And okay, let me skip this slide. And that's our international website, bmulligan.com, for anyone who wants to refer and refer to our courses, which will be enlisted right there. International courses will be enlisted there. And those of you who are doing projects or research including Mulligan topics, you can always take the reference list from there. We have the list of references being done on Mulligan concept in the website itself. So that's the basic principle. We'll skip all this. Various treatment techniques available for the shoulder. Okay, due to shortage of time, I'm just running through these. And the treatment strategies, scapular and cervical balance, including dynamic instability, should be addressed. Restore mobility, active and passive. Regain muscle activation and strength. Thoracic alignment, mobility and muscle status, rib dysfunction, functional training goals. Conclusion, integration of subject knowledge from your first year to the last year is very important. You can't deal it in parts. Further fine-tuning or refining the acquired knowledge through extensive clinical practice. Inquisitiveness, the desire to know more or the eagerness to learn more about the client is very essential. About the client's clinical condition, not the size of his purse or the car in which he is traveling or the lifestyle that he is living. It's about his clinical condition that I am talking about. The core values of professionalism is to be upheld. Those are the core values, and professional and career upliftment is guaranteed if you follow through these principles. I would like to thank the organizers for giving me this opportunity, and I apologize for exceeding the time, but I am a person who is used to taking 6 days continuous workshop, and you can't limit me to 30 minutes. I'm sorry. Thank you.
Dear Dr. Jubut, that was a wonderful talk. So I will, because of lack of time, we will take only one question. Okay, and our moderator, Dr. Muthupandi, will be.
So that was really a nice session from you after 2010, because I was your student at that time. I'm happy being here. Sir, one thing which I would like to ask is there any criteria to start the strengthening exercises? Or do we have any limitations like 24-hour clock? Immediately after manual therapy, we should not do this, or do we have no limitations in that?
Good question. I wish everybody listens to it properly. In Mulligan concept, we do not have any such limitations, because what we are doing in Mulligan concept is correcting the positional fault. With one touch of your hand, you get to see that the patient gets corrected, and then the patient is pain-free. So once the patient is pain-free, you can start exercises right away. But only thing is, in Mulligan concept, we have something called as the rule of 3. On day 1, the number of repetitions that we do is going to be limited, because we just want to see if there is any latent side effects of the manual therapy procedure which we have done. Like I said, I don't want the patient to do it excessively. If I use too much of force and tomorrow the patient comes and tell me, sir, after you did that, I felt very sore and throughout the night I was very much restless. Now, to those who have attended my workshop, I've already explained this, like especially when we deal with the cervical spine. Person comes with restricted mobility of the cervical spine. We don't mobilize or manipulate immediately. We do a dynamic cervical instability test. And if the dynamic instability test is cleared, that is when we mobilize the patient. If the patient does not clear the cervical dynamic instability test and you mobilize the patient very well, the patient is going to have a guaranteed improvement in range, and he is going to come back with severe pain on the next day. So that's very important. So we have to be very cautious in the term. We have to check the muscle status. What is the strength? What is the endurance level of the muscle? Because patients are bound to keep doing that, because that is my experience. When you mobilize the spine, patient regains his mobility, he is not going to stop. After you mobilize and get him back his range of motion, he is going to check at least for 15 to 20 times the same day itself, same time. And after he goes again, he will keep testing. So what happens is those muscles which he was not moving during the stiffness phase have gone in for inactivation or reduced power or strength or endurance. And that's going to be causing a lot of pain simply due to muscular fatigue. Not an injury there. There is no injury there, but it's simply due to muscular fatigue, and that can even affect his sleep. Thank you, sir.
Thank you. Thank you, Dr. Jibu.
Thank you very much.
Thank you, sir. It was really a wonderful session. I request our chairperson, Dr. M.S. Satish, and the moderator to kindly present a token of appreciation to Dr. Jibu George Varghese. I now request Dr. Prem Kumar, convener of Spark 25, to present mementos to the chairperson and moderator. Ladies and gentlemen, we now proceed for the sixth session of the day. It is my honor to introduce Dr. Priyanshu V. Rathod, Professor at the School of Physiotherapy, Dean of the Faculty of Medicine, Director of IQAC at RK University, Rajkot, Gujarat. Sir's academic leadership with forward-thinking innovation, championing applied research has made an impact in physiotherapy. This session will be chaired by Dr. Waqar M. Naqvi, International FAI MER Institute Fellow and Founder Director of AD Vivum Education and Research, Qatar, and moderated by Dr. Jibu George Varghese, Professor and Principal at Sri Ramachandra Faculty of Sports and Exercise Science, Chennai. Dr. Priyanshu Rathod will speak on Artificial Intelligence in Physiotherapy, Understanding the Need and Development Process. I now request Dr. Aishwarya Sonwane, co-convener of Spark 25, to welcome Priyanshu sir with a bouquet. Over to Dr. Vakar.
Yeah, no, but I have to introduce you. Very good afternoon, everyone. It's my immense pleasure to introduce and reintroduce Dr. Priyanshu Rathod, sir. One of my very close friend, my senior and one of my mentor. He is a professor at the School of Physiotherapy and Director of IQAC and Dean of Faculty of Medicine in RK University, India. More than 24 years of teaching, research and clinical experience, serving as NAC accreditor and establishing IQAC and Institutional Ethical Committee with publications over 75, 10 books. I'm just trying to crop. And many awards into his hats, and with a similar research interest on AI-enabled movement analysis and in healthcare sciences. It's our privilege to have you, sir, here. The stage is all yours. Thank you so much.
I think, thank you so much, Dr. Vakar, for introducing. Believe me, I will not take more than 20 minutes, okay? And I know it is very, I don't want to hold you back here for lunch. But whatever you learn in next 15 minutes will be lifelong learning. Once again, mind to market, we are not here to time pass. Here, the economy is a force why we are here, right? And that is what artificial intelligence are attracting us. Think tank, a lot of people are there here, and learning is opportunities. You can see the Srinivas College 30 years before I joined, August 1995, I was joined this institute, and almost now 30 years, and joined with so many other contributors. And what am I today? I am from west part of Gujarat, and I believe that more than you become a doctor or engineer, try to become a good human being. And happiness is one of the area I always preach in my talk, that if you're happy now, you can understand what I'm talking here. But if you're not happy now, then it will be difficult forever. So, and be responsible citizen, these three things where our university work on it. This is another mother nature, these three seasons we observe in our campus. And I always see that I am very much close with nature. A lot of things we learn, if you really find interest. It is a creator, innovator, and if you talk about intelligence, nature has everything, you know. So I think don't go out anywhere to learn the book, but just go to the mother nature, will teach you everything. Once again, the one of the best inventor or innovator, what I know, is Mahatma Gandhi. No doubt about the simple spinning wheel and given a job to thousands and thousands of people. I like the change is very important thing. We have been taught earlier about the four-leg walking aid, and we prescribe the four legs walking aid, and I always think, I tell that people that the reason behind the four leg was it should not fall down. It is not about having a stability, but if somebody is a person who is not able to put it hold straight, there is a four leg. So you have to think that why it has been developed. Otherwise, 20 rupees of bamboo is much more enough to walk, climb, everything, or spending some 350 rupees of walking aids. Let's come to the point, artificial intelligence. I don't want to talk much about, but I want to talk today about how to develop the predictor. Okay, so next 10 minutes, will try to close and understand that if you are interested, UG, PG or doctor or scholar, how to prepare one predictor, and it's much more easier with the same thing. I don't want to talk about, there are ample of opportunities for physios because we are close to the health, and we can develop such kind of predictor and we can put it in market. I have just one case study, AI in physiotherapy, just 5 minutes you spend, much more enough. Our clients ask us, will I recover? One stroke person will come to your clinic and say, and relatives will ask you how long it will take. And believe me that we also do not know how long it will take. But we always tell that wait and watch, let have some mobility, ability, but all these questions always comes to your mind. Here is one of the model, what I am demonstrating is a stroke recovery predictor. One of the very state-of-art model, and how this predictor has been formed, that journey I am going to share with here. So developing the model and testing model as well as validating the model. The 3 steps I am going to discuss here. Stroke participants were assessed for predictive factors. So before developing any model like weather model or any survival model or health predictive models, you need to identify the attributes which is responsible to impact that disease, disorder or situation. Here we have a stroke recovery. So we have a factor which is responsible to delay the recovery or make impact on the recovery of the person. This is a 21 factor with a deep dive research, review of literature, systematic review. We identified this 21 factor is responsible for influence the stroke recovery. And what you can see here, most of are commonly attributed here, 21 factors. What we did here, we use simple regression analysis, okay? And if you think about algorithm and machine learning and data science, nothing more than some simple mathematics and statistics. That is why the computer engineers goes well with it. I'll put it in a simple form, okay? Here there is a simple formula, y is equal to 7x plus 8. Simple formula. Attributes on Fugel-Meyer assessment score. Just you can understand that Y stands for dependent and 7 make it the mic. 7 is a regression coefficient, which is the weightage of each predictor. Okay, so this is a formula where yx 7 8 7 8 are the number, they get changed. 8 is a constant, ongoing medicine, rehabilitation, overall health. That is also impact on a recovery of the, that is constant. You can't control the medicine, overall health and the physiotherapy treatment. And plus and minus what you see, it is also the one of the operator. So watch this carefully, this formula, and based on this formula, we have developed the one predictor algorithm. So when we analyze the large number of people, now it is matter about when brain do not calculate those information in a second or minutes or month, machine can make a calculation. Number of data or 21 attributes been regressively analyzed for the Fugel-Meyer score. The score and those factors observe the constant, where we found the constant 62.561. Statistically, you get those number. Then type of stroke. Now, out of 21, one of the highest predictor we observe the type of stroke, which is a ischemic or infarct, which is a 14.740 at the level of significance 0.04. Second strongest predictor we identified, length of stay in hospital. The longer the stay in a hospital, poor the recovery. And that was a minus 2.721. So stay in hospital means days in hospital. And that was a highly significant. So out of 21, the strongest predictor we identified is a length of stay in hospital. After the stroke, 4 days, 5 days, 6 days, higher the days, lower the prognosis. And one of the post-stroke duration, longer the duration, poor the prognosis. So we have observed the very strong correlation where increase the days of and then lower the, but even it also 0.73. So what we did with this thing, we have used simple formula. Same formula, Y is a Fugel-Meyer motor assessment score. That is what we want to find out. We want to predict that after 3 months, 6 months, 1 year, patient comes to you with a stroke and he will ask that when I will recover or how long will it take to recover. You can give the answer based on a Fugel-Meyer motor assessment scale. And that is where this formula has been developed. So what you can see here on a 7x, the 7 is a number where 14.741, which has come from here, 14.714, which is a type of stroke. So if ischemic stroke, we keep the 1, infarct stroke, we can keep the 2. So hemorrhagic stroke and ischemic. Okay. Second thing about another predictor, which is a length of hospitalization in a days. So that is a minus, plus. So if you have a one ischemic stroke, which is having a more impact, you get lower the Fugel-Meyer score. So here that is why it is a plus. And when you go to the length of hospitalization, it is a minus. So you have an example, 5 days of hospitalization after the stroke, 5 into 2, 10, 10 minus in a Fugel-Meyer score, total score of Fugel-Meyer motor score. And third one, we have a post-stroke duration in hospitals. So more days somebody stay in hospital, which is also multiple into 0.111. So there is a distribution or there is a weightage of 3 attributes. And that attributes we place in this formula and constant 62 point, which is remain constant in context to we have a hospital, we have a post-stroke rehabilitation, medicine and health condition. That is a constant we observe. So what exactly comes out here? Once again, Y is a Fugel-Meyer motor assessment score, 7x, 14, either 1 or 2. 1 is the infarct and 2 is ischemic. Then minus 2.728 hospital stays in a day. So 1 day into 2, 3 days, 5 days, 10 days. Higher the days, you reduce the score. And last one is a post-stroke duration, is a 0.11. So again, after somebody comes up at 180 days, 300 days, increase the days, impact the stroke recovery. And last is a constant plus 62.561. Now, I just want young mind to understand that this is all about algorithm. Whatever, if you do the predicting the any kind of model in computer science and engineering, this is one simple example of model. This could be having a more than 1,000 predictor, maybe which cannot be calculated by the mind, but artificial intelligence can help to calculate those information in a faster way. Here I am showing you one simple picture and is as efficient as any machine learning what you can process. We have a 300 sample data, somebody may have 1,000 data. So predictability will be higher the number, better the predictability. Then what we did, we kept this formula in Google application. You can also Google about stroke recovery predictor, available in Google Play Store. When somebody put the details about name, gender, age, type of stroke, and Fugel-Meyer score, as well as the post-recovery days, as well as staying in hospital days, they get the Fugel-Meyer score. So by using this application, you can predict that this person or this patient is supposed to have a score of example 80 or 70. So seeing the score, you can identify that if your client having a higher the score or lower the score, you can understand that how he has recovered. So once again, this mobile application are providing you the information about what's supposed to be the current score based on the attributes you add here. So I wish that whenever you get time, please access this application, take one patient's data, put the 5 only attributes: name, age, gender, type of stroke, and days stayed in hospital, and last is a post-stroke duration. After putting the 6 values in a mobile application, you get the Fugel-Meyer score, and score you have to match with existing patient score and see that how patient has recovered. Even as per the post duration. Now, the second, we have a published the way specific people testing our protocol, testing our algorithm. So what we have done the sensitivity test. After announcing website, we have invited specific people to figure what is sensitivity of this algorithm. Are this formula or predictability, how accurate? How accuracy we have observed in a post-COVID when we had a vaccines. You know how somebody's vaccines like Covaxin was giving 73% of prevention from the COVID. Equally, any kind of algorithm will provide you how it is a sensitive accuracy of providing. So the formula what we have developed, we got the 69% of accuracy to predicting what is the probable score of Fugel-Meyer after XYZ days patients comes to you. Then after testing our algorithm is a 69% accurate, we have taken for the validation with the experts. So in a phase 3, we have asked certain expert to use this formula, as well as the patients to observe does this process of validation is accurate, and then where we found 70.42% of accuracy. What you can see here, the sensitivity, specificity, positive and negative predictability values are also one of the simple way any statistical fellow can provide you information. And regression analysis, I don't think is so difficult. Anybody can with SPSS or some simple software, then you can even get into your data. So what finally we observe that assessed by the investigator and assessed by the external validator, we found we can achieve at least 71% that this formula algorithm can predict the stroke recovery. And that is all about my interest to explore you that predictability models are not so difficult to prove. Still, the data accuracy can be proven with better accuracy if we have a larger number of data sample. So this is the 3 areas are impact, and this is the way the number of areas when you are practicing physiotherapy, you can identify and you can formulate the algorithm. This is a stroke recovery, and this is a very simple model I prefer that you practice and understand as a artificial intelligence. Now, if you have a larger number, more number of predictor, then you can have a better opportunity to develop such kind of. This is a project was funded by the government of Gujarat, I Create. Another last example about predicting this algorithm for prescribing walking aids. Like somebody not using the walker or walking sticks, you can identify that does that uncle or dada require to use the walking aids and which kind of walking aids based on the fall predictability. Now we have taken a large number of data, people's back like a gender, fear of fall, history of fall, an entire bug balance scale. We identified the 5 attributes are strongly impact on a fall predictability and prescribing appropriate walking aids. Age, fear of fall and standing unsupported. So bug balance score 9, which is a standing unsupported, having the highest predictability that the person having a chance to fall and turning 360 degree. This is based on a simple analysis of regression. We have a formulated, you can put this formula in any kind of application and you can get to know that what is a fall predictability, and even you can identify which kind of walking aids should be prescribed. And just to end up with that, because of that we have a 4-5 years of work. Just last year we got 1 CR fund from the DST for these 3 projects. because of we have a track of record, when we got opportunity that 1 CR just fund has given to predict the early health solution for prediction, prevention, rehabilitation of respiratory health to enhance the industrial worker. This project where those workers in a ceramic industry will take their PFT, X-ray, then working practice, number of attributes we put together, and will provide that those skilled worker as they grow older, their efficiency of work goes down. Skill improves, efficiency goes down. So that is where this we got fund for 38 lakhs rupees, just one predictor. And this has been proposed by the computer science and physiotherapy department. Second was challenge about the prescribing walking aids. That is also one of the work we have proposed to Department of Science and Technology, and they have approved. And this is the last one, which is very close to us, about yoga was being taken as a sports to the Olympics, but they have not accepted the yoga as a sports, considering the method of evaluating. So here we have proposed to DST about there is a technology-based evaluation of yoga poses, and they have granted this fund more than 1 CR, and they said they are open to expand fund if you go with it. I'll tell you that they have provided the entire data lab with just to prove that if you have a very strong method, technology-driven method to analyze the pose. And you'll surprised to know that the committee which represented the Olympics, they had given a 7 to 10 jury system. 7 juries are sitting on one place, and somebody is demonstrate the yoga, and they used to give a scoring. Olympic committee has rejected the proposal within a day, because that is the way the predictability or accuracy of yoga pose cannot be judged. Still yoga pose. And we believe that the technology which AI enable will help them to predict accurate pose. Like chakras and somebody is performing, we can go better with a picture and analysis. I think almost 20 minutes, and I don't want to go much of it. So there are a lot of partners are available. Don't worry about the fund. Fund is available with so many or government and non-government organizations. Just you need to apply. And as I correctly said, the AI is in the top, and Make in India, what you can see, the Trump uncle has done a tariff war. We can take mileage with our Indian product, Indian technology, which is highly in need. This all the funding agency has a common interest in a technology-derived innovation. We have a scientist D. I think Dr. Satish is here with us, and he's I know that what is a D, A, B, C, D, there is a level of efficiency of scientists, and those scientists approve the project, and I'm sure that Dr. Satish will be agree that the common focus are technology developed products for our Indian market. And in the last slide, when you talk about intellectual property rights, the novelty, application, and innovative steps, if you artificial intelligence algorithm is also considered as a innovative steps. So in case if you prepare, you can patent your algorithm also. Thank you so much.
Professor Priyanshu, thank you for the wonderful insights into integrating stroke, research in stroke with technology. Any questions from the audience?
When we can go for lunch, right?
Any questions? Okay, then probably the session chair has a question.
Whenever you think about any ideas, I just take 1 minute, 2 minutes. That is, we open the ideathon. And due respect to of chairperson, the 2 students identify the challenges. Ideathon, we have shared the email and Google form with all the participants, but 2 proposal, we'll just listen them, because identifying the problem in our practice is very important thing. I request one student just come on stage and pitch their idea.
Lenisha, she's from DPT, 5th year.
Yeah. Just appreciate her thought.
Good afternoon, everyone. Imagine an elderly woman recovering from the knee replacement. In the clinic, she follows her physiotherapist instruction, but when she's sent home, she finds difficult. How much she's supposed to bend her knees? Is her posture correct? But she needs guidance throughout her exercise. So my challenge is home exercise gap. So whenever the patients are left alone at home to do their exercise, some do the wrong postures, some skip steps, and some overdo movements. This leads to slower recovery, inconsistent outcomes, and in some cases even now pain or injuries. In case of elderly patients, there is lack of confidence in that case, so they'll stop exercising. What are the limitations or barriers? Most patients depends upon their memory, exercise sheets or YouTube videos. These can show exercises but not correct the mistakes. Elderly patients even struggle with the complicated devices. So the gap continues. Patients are alone with their exercises with no guarantee that they are doing them right. So when the patient don't recover properly, the consequences are bigger than just one case. It means more clinical visits, higher costs, longer absence from the work or school, and overall low quality of life. On the other hand, if this challenge could be addressed, patient would recover faster, therapist would have better outcome, and the healthcare system as a whole would benefit. That's why this challenge is important to bring into the spotlight today. Thank you.
Thank you so much. I just, once again, the objective, we have opened the ideathon by sharing the Google form with the participant. Which idea, means somebody can bring the idea which can taken into the artificial intelligence to solve. And there is two students who are shortlisted based on their participation. So one is Denisa, so please put your hands for her. Her challenge, what she observed that, and we are definitely agree that our patients, those who learn the exercise in our OPD, once they go home, they don't practice. Can the artificial intelligence or any kind of technology or device can solve this problem? Now it is definitely a challenge to be addressed, and we really appreciate her concern to be participate in this ideathon. Thank you so much, Beta. And I will take only last 1 minute, one more candidate we have here. I think if she is here with us, then we invite for a feature idea. One boy we have shortlisted. Please come fast, come fast. He is also having some, see, ideation is one of the most challenging tasks in our chat GPT generation because we stopped thinking critical. Let's see the what challenge he has observed.
Hello, good evening to everybody. So one of the major problems I think we face is that the patient forgets about the exercise and may not remember the correct methodology to perform it. So what is the solution to this, you may ask? So in quite a simple way, we should utilize open source AI to make an app which integrates the following. First is a personalized exercise plan, which can be uploaded directly to the app and can be adjusted according to the patient's needs. Next is tracking of the patient's progress. So in the AI program, you can input different parameters which can be measured to see the efficacy of the exercise. And then is daily reminders. Another problem that is faced is the patient may forget to perform the exercises at the set time. So the AI program can give daily reminders at set times to implement the work. The next problem is motivation. As you all know, a big problem many people have is they lack motivation to proceed with the given exercises. They may think it is not adequate or it may not provide the necessary benefits. This can again be altered with an AI modality to provide the patient with adequate motivation to perform the work. And finally is form correction. Another big problem patients face is they may not be performing the exercise in the correct form. We can utilize a camera or even their phone and implement AI to digitally analyze their form so they're performing this exercise or program with the most efficiency. That's all. Thank you.
Thank you so much. we appreciate. See, in his interest of equal with the earlier applicant about there is a technology is needed, and I want the young brains to think about how could be this artificial intelligence can help us to solve these challenges where patients can exercise correctly the way we have prescribed. Thank you so much. Over to the jury.
Sir, thank you so much for this wonderful talk. Indeed, AI is to augment our work, not to automate as of now. And yeah, data is more expensive than gold. And we really hope like people come into this ecosystem of scientific engagement, and every institute should build a research ecosystem. So just one question and a thought process I want to know, because you're also in entrepreneurship. We are working in entrepreneurship. What do you think, what is the main challenge for major institutions and the students to understand the concept of this digital health entrepreneurship and how they can be the part of this revolution?
Thank you. See, this is an ideathon. We observe the students of this generation having a better opportunity to learn from the digital sources. Only if they have a proper idea, they can take it, those ideas to the actual research. Most of research, I think yesterday one of the speaker has said about we compare our own weapons, MRT versus MFR, our practice we check and we don't get anything out. So digital health and the artificial intelligence is definitely we have to opt out, but you need a proper challenge you have to identify. This is a challenge of the community and this is a solution could be get out of this. So probably we all need to little bit diversify from a routine research practice to the innovation, because there is a definitely a silver line between the research and innovation where we can map the artificial intelligence and digital health. I hope it is fine.
Thank you so much to corroborate this summation into a wonderful way. Thank you so much.
Thank you everybody for patience.
Thank you all. I now request Dr. Vakar M. Nagvi and Dr. Jibu George to kindly present a token of appreciation to Dr. Priyanshu. I now request Dr. Prem Kumar, convener Spark 2025, to present mementos to the chairperson and moderator.
And everybody is leaving for lunch. Important information about the speaker. He is the greatest alumni of Srinivas. He done more than 25 years before physiotherapy here. He is having so many patents, and university is very proud of him. Thank you, sir.
Thank you all. Ladies and gentlemen, we will now be breaking for lunch. For our speakers and faculties, lunch is arranged at the ground floor, and for our students, the lunch is arranged at the basement. We kindly request all the participants to reassemble by 2 o'clock as the sessions will resume, followed by which the much anticipated quiz and engaging panel discussion, which will be concluded by the valedictory ceremony, will take place. Thank you.
Second session. So, Dr. Rakesh Krishna Kovile. So, he is an associate professor at Nitya Institute of Physiotherapy, Mangaluru, with nearly 13 years of teaching and research experience. And his expertise spans in neurosciences, pediatric neurology, sensory integration, and rehabilitation innovations. He is currently pursuing his PhD at Nitain University, Mangalore. He holds an MPT in Neurosciences, Pediatric Neurology from KMC Manipal University, 2012 distinction and university topper, and a BPT student from Sushruta Institute of Physical Medicine and Rehabilitation, Hyderabad, 2009, University first rank. And he is also a IBITA Bobat certified and a certified sensory integration therapist from University of Southern California, USA in 2016. Dr. Rakesh has secured major grants including BIRAC Big Grant for developing a smart device for diabetic polyneuropathy and a Nitte University intramural grant in 2024 for children with cerebral palsy. He has 22 registered copyrights, 88 research publications, 1 book, 3 monographs, and 1 book chapter to his credit. As a passionate academic, he has served as a resource person in over 65 national workshops and conferences and continues to mentor research in neurosciences and rehabilitation. His contributions have been recognized with several accolades, including the Young Achiever Award at the First World Congress of Physiotherapy, Hyderabad 2022, and the Best Teacher Award 2021 and 2023. He has also received distinctions for his research presentations, securing second place faculty category at ICPT Mumbai 2023 and first place faculty and PhD scholar category at INCPT All India Institute of Medical Sciences 2023. With further ado, let's welcome Dr. Rakesh Krishna Kovale to share his insights with us. Thank you.
First and foremost, I would like to thank Nandakumar sir for giving a brief introduction. If someone talks about you, you feel happy from inside, right? So thank you, sir. Thank you so much. And I would like to thank the entire team, the organizing team of Spark 25, Dean Dr. Trishala, the convener of this conference, and the entire faculties who are behind this particular event. And also the participants who are there here to listen to me. So today I am going to speak to you about my experience, my personal experience in pediatrics, exclusively in terms of early intervention. It's not a new term. Early intervention is not a new term. Pediatric physiotherapy is not a new term. Am I right? So you all might have heard about pediatric physiotherapy dealing something with children, right? And we deal mainly in terms of developing their milestones and making them more functional, right? Then what is there to talk something more behind this particular topic, right? The problem over here is we have around hundreds of approaches in our hands. And when we go to the war room, you know, war room means our OPD or NICU or PICU. We take one weapon and throw it on the babies, okay? And we will keep on searching whether this particular technique is beneficial to the baby or not. So we are experimenting, am I right? So we are experimenting on the children. On adults, if we do, it is well and good. But children, can we experiment? They doesn't know anything what you are doing. They expect that, they don't have any even expectations. They don't know who are you. They don't know where they are. Okay, they don't know why they are there. Okay, so in such a manner, when we are dealing with such people, I felt that it's more of emotional connection rather than oral communication. Okay, so I always depend on the connection between myself and the child rather than communicating with the child. Okay, so without any delay, we'll start with today's topic. So when ma'am asked me about what will be your title, I told that there is an opportunity for every physio to do an extraordinarily in the early period. When you talk early intervention, it is about birth to 5 years. So in that particular period, there is something called as window period. Okay, upon my keep on practicing, okay, I came to know that there is some period, if we concentrate on that particular aspect, the child can get a benefit in a double fold than what you are doing since birth. So what we require? Okay, do we require specializations to treat? No, it requires a golden heart, okay, to deal with the child. Okay, so with this note, we will start. First slide. This is the background which I kept. I don't know whether the last people can able to read what is there in the figure. Okay, but I'll tell you something. In early intervention, mainly in terms of early neonate, okay, the baby is just born, you went to NICU, okay? That time, do you think the baby is being diagnosed? The baby is kept. Baby doesn't even have the name. Baby of so and so will be there in front of you, lying down in incubator, okay, doesn't know why she is over there, and there is no formal diagnosis. There is a reference to you. Dear physiotherapist, kindly go through, okay, give your valuable opinion. There was no diagnosis given over there. So as a physio, what I should do over there? So that's the reason we should know some basic things when we enter into an ICU. So this starts before a formal diagnosis. Early intervention starts before a formal diagnosis. There is no diagnosis to the child, but you are supposed to give therapy to the child. Okay? I kept the second point. What we are focusing over there? There is no diagnosis. The child is lying in front of me. I am focusing on whether the child has movement-wise any abnormality. Okay? I am repeating. Movement-wise any abnormality. Whether the child has feeding-wise any abnormality, or whether the baby has breathing-wise any abnormality. These are the three things I am going to see when I enter into an ICU. I am repeating: movement, feeding, and then breathing. Right? Posture, part and parcel of movement. So therefore, we are supposed to see these three things. So doctor is expecting us, the pediatrician is expecting us to say in future whether the child will go for developmental delay. In future, whether this child will have any complications through lungs and heart. Hope you understood my point. So this is the main thing what a pediatrician is expecting from us, nothing else. Okay, you are not supposed to go there and make the baby walk on the day one, okay, as a neonate. No, they are just expecting us to give our opinion. Imagine you are writing on a bond paper your opinion with your sign. If anything goes wrong, you are the one who is responsible. If I take that responsibility, I will see the child properly. I will see the newborn neonate in a proper manner and check whether the baby can able to breathe, take feeding. Feeding means the neonate will eat biryani or what? The neonate will have only fluid. Okay, whether the baby can able to take the fluid food inside properly or not. Okay, through formula feeding. So we will check only these three things. Once these three things are justified, then the baby will be slowly given from the NICU to the ward. Once the baby is shifted to the ward, the baby is going to home. From the home, baby will be coming to your OPD. So your doctor is asking, from NICU, the path is till the home or the path is till the physiotherapy OPD. Okay, it is your duty to tell the pediatrician, dear ma'am or dear sir, once you discharge this baby, kindly ask them to meet us back after 3 months. That suggests that you understood that this baby might be having an issue in the future. She requires thorough physiotherapy. Will you agree with me? Yes or no? Right? On the day one, you are supposed to do this. Clear? Next slide. So this is the statistics, okay? In mainly doctors, physios, healthcare professionals doesn't like numericals. But if we doesn't care about this particular thing, we are not aware of how much essential our services are required to the society. We see almost 25 to 33,000 CP children. New CP children are born every year. Majority of them are premature. What is prematurity? The baby is born more than 15 days early than the due date. So prematurity is the first cause. Second cause is asphyxia. These are the two causes which leads to cerebral palsy. That means injury to the brain. Before 15 months, anything happens to the child brain, whether it is meningitis, encephalitis, infection or anything, if it damages to the brain, we say it as cerebral palsy. Okay? Before 15 months of age. After 15 months, the brain is matured. When brain is matured, you cannot call it as CP, you should call it as sequelae to encephalitis, sequelae to meningitis, sequelae to brain injury. You cannot call it as CP. Why? Because 15 months is the age where maturity of the brain finishes. Only brain I am talking, not the complete nervous system. Is it clear? Right? So, out of 25,000 to 33,000 children, what is the percentage of the children who receives physiotherapy? What is the percentage of the children who receives physiotherapy? Only 30 to 40. Out of that, 1 to 15 percentage are receiving advanced physiotherapy. In that, 1 to 4 percentage of children receiving technologically advanced physiotherapy. Imagine we standing over here only with 2 hands to support the baby. If we are not technically or technologically advanced, we cannot manage the baby completely. But in India, the scenario is out of 40,000, only 1 to 4 percentage is receiving that particular therapy. Don't you think we do have some responsibility to become ourselves much more equipped? Yes or no? We have to be equipped much more, and we need to be technologically moving forward so that in less span of time I can cover more children. Otherwise, it takes 1 hour for me to train one child. Okay, but if I am advanced and if I train my colleagues in an advanced manner, we can manage many people at the same time. We can help many families and we can be a ray of hope for them. Will you agree with me? Yes? Okay, next slide please. This is the path. So there is a course for everything. Okay, when I set this particular path, you have a baby in front of you, you are managing. So your responsibility is only the baby, their family, their future. Okay, right? The baby is just a month old or years old, but the only baby to the parents. That is their hope. So indirectly, you are targeting the quality of life of the entire family. I am repeating, you are targeting the quality of life of the entire family, not only the child alone. So baby, whether it may be months old, years old, whatever it may be, your therapy should focus even on the parents. So you need to educate the parents also. So the path of physiotherapy lies managing the children, educating the parents, improving the quality of life, and making the baby functional to live herself on her feet in the society. This should be your path. The students, when you come with your goals, you might be learning SMART goals, correct? So SMART goals and all, when you bring to your teachers, whether your SMART goal has any functional activity. Tell me one activity where with the child whom you are treating will be able to do by herself. When the baby takes first step, have you seen the mother's face anytime? You may not remember yours, okay? But you can ask your mother when you took your first step, what enjoyment your mother had. Don't you think every mother expects that? And when you say, when a child comes to you, this baby, very difficult to walk, but I will do my best to at least make her sit, you are a loser at that instant of time. That's your mistake. You should never say what the baby cannot do. It decreases the hope of the parents. Irrespective whether you do something or not, yes ma'am, we'll have a strong hope that she will become all right. She will do her activities by herself. Whether it may be after 10 years, no problem. But your talk should be not in a provocative manner, but in terms of a reinforcing type. Will you agree with me? Right? Because child may not communicate with you unless he grows more than 5 years. The communication is through mother. Okay, but connection is through your child. Right? Next. Next slide. So what is the primary link? What is the primary link from the child perspective towards the physiotherapy? Right? The primary link is the baby is born with the neurological injury. The baby has to progress to be independent. The link is functional, but we treat structurally. Hamstring is tight, lengthen the hamstring. TA is tight, lengthen the TA. Biceps is tight, lengthen the bicep. Baby doesn't want that. Baby wants to be independent in her functional activities. So activity should be your concern. Whether the baby is doing any one simple activity of holding a rattle in the hand. Is the baby giving away the rattle or not? That should be your first goal. Because baby starts giving up by which age? 6 months. Till then baby only grasps. Whether the baby started giving back? Yes, that's a good sign of decrease of spasticity. Right? Whether the baby is able to look to the sides? That's a first indication that baby is starting to roll. Correct? Whether the baby is trying to lift the head up and put weight on the hands? That's the first sign that baby is coming to crawling. So, as you have genetic markers, you have some physical markers. Remember always as a physio, there are 5 physical markers. Number 1, range. Number 2, tone. Number 3, strength. Number 4, reflex. And number 5, girth. These are the 5 physical markers. As a physiotherapist, we should always remember whether it is a pediatric to geriatric case. Next slide. Synaptogenesis. You might have heard about synapse, right? The connecting link between neurons. We are born with millions of neurons. We die with millions of neurons. We are born with millions of neurons. Out of that few are functional. We die with millions of neurons. Out of that many are functional. Correct? Huh? So neurons start functioning in a way that every day it will increase. The synapses will increase every day. But when we are born, when we are just born, remember our synapses are less because we don't know much activities. As we grow, our activity starts improving. When we do more and more new activities, more and more new things, more synapses will be formed. Don't you think child learns every activity from the day of birth? Yes, everything what the child does is learnt activity. It may be a skill or may not be a skill. Writing is a skill. Laughing is a skill. Laughing is a skill. No. Eating is a skill. Eating is not a skill. Eating with hands is a skill. Okay. Waving is not a skill. Putting the body stable to wave is a skill. Okay. So it depends on how you mold the baby to learn an activity and finally make it as a skill. So in your therapy room, okay, if you are a student in future or if you are future when you work, when a baby comes to you, okay, remember that how many activities have turned into skill. At least in 3 months, if one activity turned into skill, you are a successful therapist. Okay, 3 months, one activity as a skill. Okay, that too with proper motor control. That's a skill and that's your merit. No certificate is needed for that. Yes? Next. So these are the 2, I'm not going to read that, please don't worry. Okay, there are 2 flowcharts over there. One is by American Academy of Pediatrics. The another is by our Indian Academy of Pediatrics. Okay, they have told very clearly that when the baby is born, the baby has to approach the pediatrician at 3 months, 6 months, 9 months and 18 months. Okay, baby should approach the pediatrician. At the 18th month, what you are going to say, whether the baby is developing normally or not, okay, whether do you require any other therapy or not. Don't you think it is very much delayed? 18 months is the very much delayed age. By 18 months, one kid may run, one kid may climb the steps, but it is too much delayed. So then they started to tell that by 12 months. Then they started to tell that by 6 months. Then they started to tell that by 3 months. Can they tell by themselves? Who is the one who is responsible that? We. We have to tell whether the baby is able to produce the movement or not. When we tell that movements are abnormal, then the pediatrician will say whom to approach. Direct them towards the concerned person. That is the duty of the pediatrician when we say something in a written format. Okay, is it clear? Right, next. So there are so many developmental screening tools, but I didn't kept everything, I kept only 2. Baroda Developmental Screening Inventory and Trivandrum Developmental Screening Inventory. These are the 2 scales which are developed by Indians. Then we had one more developmental screening inventory given by ICMR, which is from birth to 6 years. Whereas the first two scales are invented only till few months, 24 months or 30 months. But baby is too young at that age. If you get a baby of 3 years old, you will say that you can't give therapy for that? No, you cannot say that. So therefore ICMR has requested to elaborate this particular thing till 6 years of life. Okay, so ICMR scale is for 6 years and they will say you whether the baby is developing normally or not. Difference between screening and assessment is, in screening you are going to get whether the baby is normal or abnormal. That's it. You are not going to get baby is abnormal where exactly. But when you deeply assess, you will come to know exactly at which level the baby is abnormal. Okay, I'm repeating, exactly at which level the baby is abnormal, you need to do thorough assessment. Screening can only tell you normal development or abnormal development. So any of these scales will only tell me the baby is abnormally developing. Okay, where exactly abnormality, we need to do thorough assessment, right? There is one more scale called INFANIP. Okay, there is one more scale called as INFANIP, Infant Neurological International Battery. This has a little bit more than screening. It's a screening tool, but it also says you whether the baby has one limb affected, one side affected, both limbs affected, or all 4 limbs affected. At least it gives us a better information than Baroda and Trivandrum. Okay, any people. So if we try to tell mother something beyond her routine life, she may do 1 day, 2 day, 3 day, 4th day.
So wonderful presentation. And last, that case scenario. We didn't expect that word you will give, that none other than my child. So this topic is refreshment for me also. One of my colleague did this early intervention concept, but not published. It's there in library only. But still, we remembers that what and all the things or difficulties behind this. We need to explain or educate the parents, pediatrician, and society background, yes. And our professionals also, physiotherapists also, we need to educate. This is the important one. So, sir, how you handle that situation, sir, that 100 days?
Mentally we became very weak, first thing.
You are the father also.
Yeah.
And how you handle that 100 days with your...
Maybe the profession gave me that hope to go into and go out of the box, and directly when we involve ourselves, then we can't blame anyone. We know where is the error. Okay, why they are developing, why they are not developing, especially when they are not increasing their weight. It may cost us more than 20k and 1+1 offer. So
it's my pleasure to welcome Dr. Kumaresan, a professor and HOD of St. John's Medical College, Bengaluru, and he is having an experience of 17 years. Previously, he worked as a professor and HOD at Savita College of Physiotherapy, where he guided many 157 postgraduate and undergraduate dissertations, and he has guided 6 PhD scholars, which is 2 ongoing at Savita Institute of Physiotherapy. And he have got 3 patents, and he have more than 200 publications. He is currently engaged in 19 active research projects with an established impact reflected by 285 citations, H index of 10 and I-10 index of 11. Internationally, he is a part-time research fellow at INTA, International University of Malaysia, also contributed as NABH coordinator, IQSC member, academic auditor, admission in charge at Savita Institute of Physiotherapy. He has catered over 200 patients daily. Dr. Kumaresan is honored with multiple awards, including the Best Teacher Award in 2018 and 2023, Professional Excellence Award, Outstanding Researcher of the Year, Best Academicians of the Year. And he has conducted many workshops delivering talks in artificial intelligence in physiotherapy, neuroplasticity, stroke dysphagia management, Parkinson's rehabilitation, and neurological approach. It's my privilege to welcome Dr. Kumaresan for his wonderful presentation. Welcome, sir.
Plasticity, how traditional neuroplasticity is developed during the neurorehabilitation. Apart from that, what is the modern technology which is used for improve the neuroplasticity in neurorehabilitation. First we will discuss about introduction. Neuroplasticity, the brains to reorganize itself by forming a new neural connections, forms the cornerstone of modern technologies. That means if you people are sitting here, see according to the environment, you know how you learned this from your college side, okay, from your schooling, you know this is the classroom, you are going to sit in front of the teacher, you have to listen. These are the things, new neural connection in your brain, it should be forming a new neural connection you have learned from your childhood. Okay, this is called as neuroplasticity. This neuroplasticity is happen in modern and technology, both. Technology has transformed this process, give rise what can be called as a digital brain, infusion of human neural adaptability and advanced digital tools that accelerate the rehabilitation outcomes. See, next. See, here the traditional rehabilitation is there and modern rehabilitation neuroplasticity is there. You know, traditional rehabilitation like how you people are giving a normal passive movement, stretching activity, manual therapy, key point stimulation, CAMT, many things are there for developing a neuroplasticity. Even in modern rehabilitation nowadays, virtual reality, augmented reality, exoskeleton and many things we can use, brain-computer interface. These are the things we about virtual reality and augmented reality. Synaptogenesis, the new formation of the synapses, okay, new connection is what very important as MRP says, okay. Interference also may be there, you have to counteract and compensate that particular interference, you have to ask the patient to do there, and capturing the cameras, with use of the camera you can sit in the center only, you can observe the patient practices, how they are practicing, you can easily identify. Okay, so in that removing the geographical barriers. Okay. Thank you for your attention. Thank you for the opportunity given the Srinivas management and Spark 2025 organizing committee members. Thank you once again.
So, good morning everyone, and it's my honor to actually introduce Dr. Prem Kumar sir, who is a great teacher and a great human being. So, Dr. Prem Kumar is a distinguished academician and researcher, currently serving as the head of the department and professor of the Institute of Physiotherapy, Srinivas University. With a passion for teaching and mentorship, he has played a pivotal role in advancing physiotherapy education and research. His research credentials are notable with 53 publications, including 18 Scopus indexed and 5 Web of Science indexed papers, along with an H index of 3. His academic contributions have been recognized with several prestigious, such as the Best Research Scholar Award 2023 as the Srinivas University Research Conclave, the Excellent Thesis Award at the same conclave, and the Best Innovative Research Award at the Ideas Summit Meet MS Ramaya College of Physiotherapy, Bengaluru in 2025. In addition to his academic accomplishments, Dr. Prem Kumar holds key leadership positions. He is the President of Physiotherapy Professional Confederation, Madurai, Tamil Nadu, and convener of the Indian Association of Physiotherapy, IAP Madurai branch, where he contributes significantly to strengthening physiotherapy practice and professional standards. He also serves as the editor of Pro Physio, a quarterly magazine published by the Confederation dedicated to promoting knowledge exchange and evidence-based practice. Dr. Prem Kumar is widely recognized for his expertise in research methodology and biostatics, and is a frequent speaker at national conferences and workshops. His contributions have guided emerging researchers and strengthened evidence-based practice in physiotherapy. So it's my honor to actually welcome sir over here, and his contributions are amazing. So I now hand over the stage to Dr. Prem Kumar to enlighten us with his expertise. Thank you.
Dr. Samana Said ma'am, and equal respect to you, because you are also a big contributor in cardiorespiratory rehabilitation and physiotherapy, and the moderator my colleague Dr. Krishma ma'am, and the participants gather here. Ponmadi ma'am, who came for her presentation from Sri Ramachandra University, and Kuldeep sir. I hope next 30 minutes we will have an interesting discussion on the title, Cardiac Rehabilitation. All of us, we know that because once physiotherapy started, cardiac rehabilitation is there in the field of treating cardiac diseases, particularly post-disease status. Once the disease came, the person is not knowing about his limitation before that. After that, they are struggling to find normal day-to-day activity related life, particularly ischemic heart disease. That is the activities psychologically also. Then I had a discussion with him. I told that, sir, it is not like. Studies are telling that, the evidence is telling that revascularization process or procedures, either it can be a PTCA, CAPG or medically managed. If neoangiogenesis and the circulation is increased after the intervention by the surgeon or anybody, people are having double the effect of heart. It is so nice. Sometimes we have to voluntarily go for surgery. After 60, 70 years, if you are having 40, 50% of block, we can go. How many of you know that many doctors, not only cardiac physicians, many doctors used to take statins in their night. The tablet taken for lipid lowering. I am not blabbering or lying. I talked with many doctors. As a precaution, they are taking statins. Because statin is having two important effects. One is it is lowering the lipid, and second one it is increasing the viability of the vessel wall. That has been proven. Imagine, preventive aspect. So in that sense, we should be very competent enough. We have to get referral. I am thinking I am a person can tell that because I worked as chief physiotherapy rehabilitation officer in a cardiac rehabilitation unit run by Aravind Eye Hospital. They actually jumped into this business also. I treated 180 patients in a year. It is not simple number. Because
for that enlightening session, now I open the stage for any queries or you have to interact with the speaker regarding this topic. First, I'll start with ma'am because ma'am wants to interact. After that, I'll give you the mic.
yes, ma'am.
Yes, so I was actually very excited for Sir's session. I told him yesterday. Before asking, I do have some questions.
Yes.
But before asking the question, I would like to really appreciate the way he has put so many things together. Tell me how many of you, that bell was for me. Okay. Tell me how
You check that.
if you have really listened, felt that, what if I start my cardiac department and run it in a center or a city where no one else is there? Will I mint money or not? Tell me how many of you thought so? Didn't you feel? Because actually that is what he mentioned, running in the crowd, being a part of the crowd will not fetch you anywhere. If you will, stand out, it will be troublesome for some time. That's what he meant. But after that only you will make that position. Maybe you will be the first one in your state or city to start with it. And I think that's how I can summarize Sir's lecture. Beautifully said, beautifully. Now there is just one problem, Sir, which we also, observe when we go to various cities is, because we all know that cardiopulmonary is divided into cardio and respiratory.
Yes.
And respiratory is a very low budgeted department.
Yes.
Now cardiac rehab is a high budgeted department. So, of course it is for me, for them also. What do you think can be a solution of that? Because you need to spend at least 15-20 lakhs for one equipments when it comes to that.
No, you told the answer in your question only. Apart from the budget, all factors are same.
Yes. Exactly.
Because the credibility of physiotherapist, referral from pulmonologist, everything is same.
Yes. So
my equipment is more and your equipment is incentive spirometry, you can do wonders. But the thing is, your question is very great question. Still it is very difficult, rather cardiac rehabilitation to execute pulmonary rehabilitation. Exactly. Because Indian people, they are thinking coughing and slight breathlessness is their character. Movies mein dekh sakte hain. Big lead roles people like that. They are not thinking that as a symptom. It is causing problem. And it is a very main symptom of COPD. If you're having 2 years of cough, continuous 2 months, you're having already COPD. Any interested physiotherapist, please do a survey like that. What is the respiratory status of COPD and how many people are having really pulmonary problem in India? ICMR may be giving the fund also. If any problem is there, means I am always there to help you, because we are not having the data. So in that sense, I took little more time for your answer. In that sense, pulmonary rehabilitation is double the more difficult, but you are doing a wonderful job in that.
So as he said, so I can, I can say that, sir, the more I think the young generation will start the awareness, we can actually reach the insurance company, the lack what sir mentioned. You can reach the government if you spread the awareness.
But go with your protocols. The government will not give like, sir, I am a cardiorespiratory physiotherapist. I am ready to serve cardiopulmonary rehabilitation.
True.
Go with your protocol.
You have.
Through your metal, they will give. It is not like they will not give. You will get in crores. I am seriously telling anybody, take video and keep a witness and ask me if you are not getting. You will get crores.
Welcoming all the audience. So now I am introducing Dr. Punmati ma'am. So ma'am is a very senior professional and have a rich experience of near about 25 years in this field of physiotherapy. So ma'am is an accomplished professional in the field of physiotherapy. She have completed her undergraduate in the year 2002 from Trinity Mission and Medical Foundation, Madurai. After that, ma'am have gone for master's program in obstetric and gynecology, and that ma'am have completed from SRM College of Physiotherapy, Chennai. See, presently the ma'am is pursuing PhD from Ramachandra Faculty of Physiotherapy, and the PhD ma'am have started from 2019. So ma'am career began from the 2002 onwards only, where ma'am established her own clinic as a physiotherapist which in a multi-speciality hospital in Birudunagar. In 2008, ma'am have shifted to academic, as because ma'am has got so much of academic interest, and ma'am have taken the role of assistant professor in SRM College of Physiotherapy, Chennai. So where ma'am was worked till 2018. 2019, ma'am joined Ramachandra, which is a very prestigious institute in Chennai, as an assistant professor. So ma'am has extensively contributed to the field as a resource person for more than 20 conferences and workshops, and as a guest speaker at 7th event. So, ma'am is a certified instructor of basic life support and advanced cardiac life support accredited by American Heart Associations, and has trained numerous students in these life-saving courses. So ma'am have many publications, more than 20.
Good morning all. How many are forced to come here? How many had volunteered to come here? I know, because women's health, I can see few male students. Are you okay to be here? Yes, okay, good. Nice to hear that. Because women's health should be better known to a male than a man. Okay, because you are the one who has to take care at times of need in a woman's life. So they should know slides of it. Next slide, please. So the pelvic floor dysfunction, we divide into hypertonus, hypotonus. It will move down from the place. That will be caused when the pelvic floor muscle get very relaxed. Okay, so that we term as a prolapse. And
it's 100%, you can't finish in half an hour, but you tried the best, and the crowd, according to the crowd, the way you changed the way taking the class, and the topic, the beyond traditional Kegels, 100% man, when somebody comes with the pelvic floor, first we'll tell about Kegels only. So like it's the pelvic floor dysfunction comes, it's not only here, like it affects your breathing. The way you conduct, it was very great, ma'am. So thank you so much. like when the pelvic floor dysfunction comes. So it's not only the pelvic floor, you have to talk about the trunk, the breathing pattern, the way the lady is breathing, everything. And the point is very correct, ma'am. The people know this type of dysfunctions, the people who are taking care or we are dealing as very less, ma'am, very less. The population who cares about this is very less. Like the students also, maybe you are not aware of things. If you talk to your parents, your mother, no, maybe you'll understand what all the problems comes in this. Thank you so much, ma'am. Yeah.
Good afternoon, everyone. And it is I'm honored and privileged to introduce the speaker of today's session, Dr. Charisma De Silva. Dr. Charisma De Silva is a distinguished physiotherapy professional with strong academic and clinical background. She completed her BPT from RGHS and earned her MPT in cardiorespiratory physiotherapy from prestigious MAHE. She is currently pursuing her PhD from NITE University. With over 15 years of professional experience, Dr. Charisma currently serves as the principal and senior clinical physiotherapist at the Father Muller College of Physiotherapy. Her area of specialization include onco rehabilitation, critical care physiotherapy, and research in respiratory and oncological condition. She is widely recognized for her research contribution and has several credible publications to her name. She is actively involved in numerous academic and professional bodies. Notably, she is an academic council member of RGHS, the district coordinator of IAP Women's Cell in Mangalore, and an active member of both Multinational Association of Supportive Care in Cancer and International Society of Oral Oncology. She has been a proactive participant in various national and international conferences, workshops and webinars.
If you here, are you all tired, hungry? Looks like that, right? Yeah, it's not a time to listen, but let me make it as quick as possible. And today's topic is all about early mobilization in ICU. Okay? So how many of you all have been to ICU? All of you have seen an ICU? Great. Okay. So what is the concept of early mobilization in ICU? Do you all agree with mobilizing early? Do you all practice early mobilization? Your respiratory rate is low. Both the things should not be given. It is red. And
Kumar, Professor and Head of the Department, Srinivas University Institute of Physiotherapy, and moderated by Dr. Glenisha Ansita de Souza, Assistant Professor at Srinivas University Institute of Physiotherapy. I now request Dr. Vijay Kumar to kindly welcome ma'am with a bouquet.
Hello. A heavy good afternoon to all, because if stomach is full and you are heavy, please listen ma'am's points. She is a wonderful teacher as well as a researcher. You will get many things to get it. Dr. Sujeta Kumari and our esteemed speaker for this session. She is a professor and the director of research and development in Srinivas University, Karnataka, India. She holds a PhD degree in biochemistry from Mysore University, along with Diploma Nutrition from IGNO and PG Diploma in Bioethics from Enapoya University. With over 40 years of teaching and 34 years of research experience, She has nurtured and mentored numerous undergraduate, postgraduate, and doctoral students. Her contribution to academics and research have made her a respected figure in the scientific and medical community. Her research interests are diverse and pioneering, covering areas such as radioproductive bioactive compounds, cancer biology, cytogenetics, cell biology, nutrigenomics, lipodomics, molecular genetics, natural compounds, radiation-induced cytotoxicity and genotoxicity, and memory studies. She has also undergone advanced training at Wake Forest University, USA in fatty acid analysis and proteomics, and has completed specialized training in ISO 15189 2012 Medical Laboratory Quality System. A prolific researcher, Dr. Sucheta, has authored over 600 publications, and her scholarly impact is reflected in an H index of 55 plus, I-10 index of 247, and more than 13,500 citations. She has successfully led 30 plus national and international funded projects, including from NIH, ICMR, BRNS, DRDO, VGST, ICAR, CPCRI, and Indo-Japan collaborations. Under her mentorship, more than 28 PhD scholars have completed their research. Her outstanding contributions have been recognized with numerous prestigious awards, such as the Dr. P.P. Jacob Award for the Best Scientific Paper 2018, Best Researcher Awards, Women Researcher Award, and Lifetime Achievement Award twice, among others. Dr. Sucheta is also a life member of several professional societies and continues to maintain active researcher profiles with Scopex and Web of Science, further strengthening her global presence in the field of scientific research. Without further ado, let's welcome the respected Dr. Sucheta Kumari N. Ma'am to share her insight with us. Please, ma'am, it is yours.
Thank you, thank you. Good afternoon. Good afternoon to all my dear students and delegates. It is my privilege and honor that the committee, the international conference organizer, given me a chance to present in front of you. So it's a nice time to spare some after the food. All of you are sitting here and thinking how to spend good time. This is about the food. See, all of you are eating food just to either fill the stomach, or you may feel weak to energize your body. My suggestion, this good food is the most forgotten medicine in our life. If you go back centuries, actually 75% of the disease we can control by managing with the food. So food is so important, and it can help you. It is like, you can't remove. So food, see, here is a very eminent scientist, father of Western medicine. Must be everybody, Hippocrates is father of Western medicine. He was keep on finding medicine and finally what he understood, let food be the medicine and let medicine be the food. Means food you take so much, but see that all the requirement for the body should present. See, our body is like a car and the driver is our soul. So driver to function, you have to, the car required energetic diesel or petrol or any fuel, and then all the movement you required oils. Like that, this car also require all the nutrients to function each and every part of the body. So physiotherapists are giving exercise and all whatever thing to strengthen and movement of each part of the body. But every molecule of the body regenerate. It has got a lifespan. For example, all of you know the RBC lifespan is 120 days. Means this is not Xeroxing. You have synthesized one cell. All the nutrients are very important. That is fatty acids important, protein important, micronutrient like vitamins, minerals, water, energetic nutrients, carbohydrate, fiber, everything is equal. It has got a major role in the body. So you don't think once you grown up, once you become adult, that is the end of your growth. Every day, every one or the other molecule undergo renovation, renewal of the cells. So basic, complete balanced nutrient is very, very important. So can food be the medicine? Food as medicine. See, maybe the emerging concept. So physiotherapists, if you go to foreign countries, they do first they take the knowledge about the patient. What is his pattern of food, what type of days eating, how much you eat, what they clarify. There is some, in addition to the therapy, modern therapy, you have to balance his nutrition so that it will go simultaneously the improvement. So, however, the role of diet and food in disease prevention and management compared to conventional medicine has been questioned. Medical doctors and yet remain efficient in patient management. So, most of the patients, 40 years my experience in hospitals and in the medical college, most of the knowledge is lacking is in the diet management. So the food is the most forgotten medicine. So food is medicine. We have to, whatever the medication, it is only controlling the proliferation. But whether you do surgery, whether you are a diabetic, whether you are a hepatic problem, renal problem, everything, once you suppress with the medicine, further all it is controlled by the diet. So diet is very, very important. Food and balance. We have to balance the diet. How much you do. In the olden days, we take lot of carbohydrates. Why we take carbohydrate? It's a wrong concept. We are addicted to eat carbohydrate, means cereal products. See, we are grown or evaluated from an ape. Ape was living in the tree, eating nuts. But when we came to the land, we become very lazy and we started to eat the grains. So all these cereals are nice, sweet products. We love it. We all addicted to various types of sweets, ice cream, chocolates. It's addict. Alcohol is not addict. Like that, alcohol addict or smoking addict or so many other things addict. Eating sweet also, one of the biggest addiction in our life. Because that is very, very dangerous. It increases the inflammation and leads to all the metabolic syndromes like diabetic, PCOD, atherosclerosis, gout. All that is because of the sweet. So, like the ape, it was eating nuts. We should improve our diet with the proper lipids or the oils. What was in the nuts? It contained lot of unsaturated fatty acids like omega-3, which helps to prevent the inflammations. But what we eat is all fried items which contain omega-6, which enhance the inflammation, enhance. So whatever that treatment you do, unless you are prevent the diet modification, inflammation is not under control and your treatment, whatever rehabilitation will not come under control. It just shows the suppression. So 75% you have to give the concept of diet. So what is nutrient? All of you know the nutrients, but we are not focusing on that. See, dietary fiber which is present in the plant products. the plant cell wall that are made up of cellulose, which are not able to digest in the intestine, which is called dietary fiber. These dietary fiber act as a scaffold for the growth of the probiotics. Maybe all of you heard about probiotic. Probiotic is very, very important in the gut to improve the short chain fatty acid like butyric acid, propionic acid, which connect all the gut-brain axis or gut-skin axis or any part of the body. It is the anti-inflammatory role. So it prevents cancer production, diabetic production, everything it controls. How many of you are giving importance to dietary fiber? How many of us are increasing the scaffold for the growth of the probiotic? Very, very, very important. So here afterwards you have to increase the intake of vegetables which improve the dietary fiber. That's very important. And vegetables contain green vegetable, yellow. It has got very prominent importance. If it is the purple color, xanthine, these containing very, very xanthine, which is an antioxidant, carotene, yellow fruits and antioxidant. So all these colored food is very, very important. It has got specific part for to prevent the free radical produced in our gut and by metabolism. So take lot of vegetables with the different colors, vegetables and fruits. Then come to take nowadays ghee has prominent role. Take ghee which contains short chain fatty acids. Take coconut products, coconut oil and product which contain medium chain fatty acids. You understood? And then you take less about meat, fish and other things, and carbohydrate cut down to less than 40% in the diet, so that we will improve from all the types of diseases. See, malnutrition, any one nutrient is absent. Recently I came to know hypothyroidism, very common factor. But nobody bother. Hypothyroidism means immediately T3 they give, thyroid hormone. But there are two micronutrients, 3, iron, iodine, selenium is the major micronutrient which affect on the less T3 formation, hypothyroidism. So please concentrate on your diet, modify your diet, come up, otherwise thyroid will be a permanent disease. So this part we have to reduce. So the malnutrition is very, very problematic, develop the inflammations. So if you see here, healing through the nutrition, essential diet tips, what is required? Improved sleep, you see the improvement of the sleep, and see the stronger of immune system, better digestion, reduced depression and anxiety, increased the self-esteem, improved and more balanced diet. So nowadays depression is a common factor. Depression is one of the reasons due to the faulty food. We should not take a food which is not able to digest, not is important to the body, which leads to toxins produced and leads to depression. So eating nutritious food is very, very important. You see why diet and nutrition matter during physical rehabilitation. So very, very important for the physical exercise. So protein, see muscle wasting is very common in the old age, senior citizens. So how do you manage to give them proteins? Because protein contain 20 amino acids, 10 are essential which are not synthesized in the body. We have to supply through the diet. So the protein diet for a vegetarian, mixed diet is important. For a non-vegetarian, 1 glass of milk and 1 egg complete the protein requirement every day. So this concept we have to keep in mind. Anti-inflammatory role. See, always give the importance to turmeric, ginger, berries, leafy green vegetables or fish oil. Very, very important. This, you have to make a habit of taking all these requirement in your diet. So even your old age or your parents or anybody suffering from the disease, see that this type of food is mixed in the diet, which reduces the inflammation. Hydration. See, for everyone I'll tell you, you have to take 2 to 3 liters of water. Water, not water alone, or buttermilk, or tea, coffee, or fruit juices, whatever, around 3 liters. Detoxify the body, controls the body temperature, controls the pH of the blood, control the nutrient circulation. Everything is because of the water. And aged people above 50, it's very important. Every urination, when you pass urine, come and take half glass of water. This is magically you have to follow the rules. So that helps. And as you age, your memory for thirst will decrease. So without forgetting, keep taking the water. That helps to maintain the whole body function. Micronutrients. I told you micronutrients means which are required less than 100 milligram per day. That is all. Vitamins, all 15 vitamins, and the minerals other than calcium, phosphorus, magnesium, sodium, potassium, chloride, all that other minerals, iron, very, very important. If you screen all of you, 90% people have vitamin and iron deficiency. It is the major cause for all the disease. And second one is vitamin D. All of you make effort, all your physiotherapy patients, ask them to sit in the sunlight at least half an hour, where it produces all the important receptors by the help of vitamin D activation. Make them to sit. Definitely they will come up. All immunity will increase. And complex carbohydrate. Don't take the sugar, white sugar, white jaggery and all. Take complex, that is all the millets. Millets is a complex carbohydrate. Improve the carbohydrate by taking the complex form. Tips to minimize the impact of nutritional rehabilitation. Don't skip the meals. Don't allow your patient to skip. There is a habit. They don't take breakfast or the lunch or that. For the patient, plan ahead their meal, include variety of food, listen to your body, monitor progress. So you means your soul. It should listen to all the parts of the body and thank each and every part of the body every day, morning and evening. This body is working for you. Body is working for you. It's very, very important. Every organ, you must have seen in yoga, see your toe, but they are not told from the toe till the head. Keep on thanking each part of the body. It will be very happy and happily working for you. It is very, very important. We have to show gratitude for every part of the body and everybody who works for the food, who are preparing food, who are supplying, who are supporting for us. Everyone we are working for the food and butter. So please thank each and everybody's contribution. It is also one part of the life to improve your life. How does nutrition relief and rehabilitation support? Recovery is not just a physical, it's a mental and emotional. When you recover from the disease, mentally you are happy and physically you are happy. So that happiness makes each and every part of the cell feel happy and you become more healthy mentally and physically. That is very, very important. And mood regulation and cognitive clarity will be there. Omega-3, as I told you, it is very, very important anti-inflammatory role. This is a short notes on support to recovery, that while diet and nutrition provide internal strength, access to professional care is just a vital. You see in Kolkata they have done this type of work. They have found this is the food manipulation is very, very important for the diet management. pain management. These are things. When paired with personalized nutritional rehabilitation, such as professional care offers a full circle solution for healing. So any disease, not physiotherapy manipulation or any disease healing, diet you give maximum importance. 75% of the control is by diet management. Summing up, healing is not a passive process, it's deeply active and intentional. Your body is not just a bouncing back, it is building, releasing and regaining the strength. So don't think just having some rehabilitation, body become bouncing back, become normal. The normal diet, along with that, it will be more strengthened. And the role of diet and nutrition in that journey is far more powerful than most people realize. So diet, all of you have to give importance to the diet. Diet is the most important forgotten medicine. So prioritize a healthy nutrition diet, embrace nutrition relief and rehabilitation, and surrounded yourself with the right professional guidance, because real recovery starts with the inside, and it starts with what you eat. So whatever you do, that is because of the eating habits. So what is the best nutrition? Carbohydrate, I told you all these parts. And this also I explained you, I can share the slides. What is the good protein support, omega-3, vitamin D, omega-3 is fish liver oil is the best source. It is available even in the market. These are the healthy food we have to take. And what's the best healing food is very, very important. And this is the nutrition, physiotherapy, physical therapy and rehabilitation nutrition goes side by side. Synergetic effect of nutrition and physical therapy provides insight into the effect of physical therapy. So these are various your physiotherapeutic activities. So all that is you have to plan, because all these conferences to identify the weakness in the therapy, which we call research. So for every patient, every person, you can make a chart, subject of the physical therapy. You evaluate nutritional deficiencies there, muscle strength problem is there, or physical therapy is required. Then you plan and see that how best you can improve their therapy. Say final, last, you may think, what is this? Sattvic food, Rajas and Tamas. If you see, all of you listen this part, very, very important. If you take Sattvic food, you will be, see here, that is without much non-vegetarian, and there is no onion and garlic. But these people, those who are Sattvic, promotes love, awareness, joy and intelligence. Sattvic food. But when you go to the Rajas food, there you add little coffee, tea, carbonated beverages, frozen food, salty food, onion, garlic. Rajas diet has a stimulating effect on the mind and body. When you go to Tamas food, Tamasic diet has a dulling effect on the mind. Those are getting more angry, they are all eating a lot of non-vegetarian, and they will develop these type of habits. So one who eats one time yogi, thus all the sannyasis used to eat only once in a day, they live for 150 years. When you eat 2, 100. When you eat 3, 70. When you eat more, no more. So conclusion, eat to live, but do not live to eat. The food we eat decides our physical and mental status. We are what we eat. Your food shall be your medicine. Thank you very much.
Thank you, ma'am. Thank you, ma'am. It was really a wonderful and an elaborative session. Audience, now the session is open. Does anybody want to ask any questions? I know it's post lunch, but I think you all can start being a little excited now. Does anybody have any questions? Okay, ma'am, I have a question for you. In one of your slides, you mentioned that it's not about rebouncing, it's all about rebuilding. As physiotherapists, we often at times in very different times. It can be before food, it can be after food, without eating food. But most often the patients don't understand the importance of food. Similarly, even physios sometimes are not aware about how food is pivotal in their post-recovery. Once you exercise for the post-recovery, food becomes a very prime importance. So could you just elaborate on that a little bit?
Yes, this is very nice question. How we rehabilitate with the food? See, whatever the patient's disease, first you have to see what is his status, whether he is a diabetic, hypertension, or any other metabolic syndrome, whether he is under medication, all that history you take, properly monitor his blood for hemoglobin level and all other requirements. Then according to his disease, you plan according to the patient's feeling. Feeling you have to respect, because religious, some people will say we are vegetarian, some are non-vegetarian. Even vegetarian, they don't take certain food. Non-vegetarian also, they don't certain food. Give respect to the patient, first thing. Second, you give to the finance condition. Don't ask patient every day eat one apple, one glass of milk, one milk. That is not possible. You have to once again consider financial state and see that where you are staying, what is available nearby, how comfort is to take that prescribed food. So physically, mentally, we should help him to feel happy and adjust your diet plan. That's very, very important. Second, then you plan according to the need. You have to convince him. You have to spend some time. See, for this, if there is a injury or after surgery or there is tearing or anything, what is necessary? This food if you take daily, this will help. So for iron supplementation, vitamin C supplementation required. If one person is anemic, that does not mean only iron. Iron is important, B12 important, folic acid important, vitamins. So it is a multitask. So that thinking you have to develop and make him to understand how best you have to eat and divide all the pattern of diet.
Thank you, ma'am. That was really a nice answer. I think I'll pass the mic to the chairperson.
Ma'am, it is like you told that very important, the food and nutrition along with the exercise, because we will be telling exercise is very important. The thing is that now the new generations are behind intermittent fasting. 16 hours, 12 hours, but I am not a believer in that. I am not accepting that.
It is very correct.
What's
Intermittent fasting, I'll tell you. Fasting is very important to give rest to the intestine. Every part of you require rest. What do you mean by rest? You think just sleeping is rest. Okay, your soul get rest, not to think or anything. But what about your car? Car has so many parts, it also requires rest. You eat sufficiently and sleep, all the parts of the body start to metabolize. So it requires some rest to rebuild all the enzymes, all the digestive juice to produce, everything it has to require some time. You are not giving time, you are simply eating. For that, at least minimum 8 to 12 hours of rest is required. That is why you have to give rest. Take food before 7 and take after morning 8 o'clock. At least 8 to 10 hours rest is required for each organ to get a chance to reproduce the requirements. So that is why rest is very important for the intestine. So rest is just like you are taking rest to the soul to sleep. You have to give rest to each organ so that the organ lifespan will increase. It is like a water pump. You know, one pump is running for 24 hours. It will live for 1 year. Like that, your kidney is running 24 hours. Instead of 60 years, it will die by 40 years. So simple.
Yes, ma'am. Thank you very much. Actually, ma'am is doing a very expanding research in a very deeper aspect of all our biochemical system. You could have understand that the research areas is doing and the citations and all the publications. So it is the time we have to give her a very grand applause, because we have to replicate her in the point of research aspect, because she is the role model what to do that. So thank you very much for your wonderful session, ma'am. Thanks.
Thank you so much, ma'am, for the inspiring session. I request the chairperson, Dr. M. Prem Kumar, to kindly present a token of appreciation to Dr. Suchetra Kumari. I also invite Dr. Vijay Kumar, Professor, Institute of Physiotherapy, Srinivas University, to present the memento to the chairperson and moderator. I kindly request participants from Pondicherry College to kindly report to the front desk immediately. If not, you will be disqualified.
Extra certificates, Ladies and gentlemen, may I please have your attention, please? We are at a very exciting phase of this conference. It's time now for one of the most exciting segments, the quiz session, which is curated by Dr. Shyam Krishnan, Assistant Professor, Selection Grade, Department of Physiotherapy, Kasturba Medical College, Mangalore. This session promises to challenge your knowledge, spark fun competition, and keep you on your toes. To tell briefly about Dr. Shyam Krishnan, he is an Assistant Professor, Selection Grade in the Department of Physiotherapy, KMC, Mangalore. He has completed his post-graduation in physiotherapy in community-based rehabilitation and occupational health from Manipal University in the year 2007. He has an experience as an academician, clinician, as well as researcher, which is spanning for 17 years. He has over 40 national and international publications, of which 35 are Scopus Index. He has published, patent, and has 3 copyrights to his name. He is currently pursuing his PhD from Manipal Academy of Higher Education in a collaborative project with IIT Goa and NITK Surathkal. His areas of interest lies at biophysics, biomechanics, exercise physiology, ergonomics and occupational health, as well as application of robotics and machine learning in rehabilitation. Let us please give a round of applause to Sir, everyone. Come on, get your energies high. I think we need a bigger clap. Louder, everyone. Yes. Shyam sir, over to you.
Good afternoon. I want all the participants to basically submit your mobile phones, any digital device which you have at the front desk here before you come onto the stage. Any phones, any headphones, any smartwatches you have with you, kindly submit it to the front desk before you come onto the arena. See, I am going to basically run a format of quiz which is called as an infinite bounce. It is not like the regular quiz which you would have seen, or some of you might have actually seen. Here every team has an opportunity to answer all the questions. So it is not that some team got an easy question, we didn't get an easy question. That kind of points do not arise. Everybody has equal opportunity for all questions. And there are 4 rounds because there are 4 teams. And then finally there will be a bonus round, which is something like a jackpot, where whoever answers can score maximum. At the beginning of each round, I'll tell you the way the scoring happens. So, there are plus marks as well as minus marks. So I'll basically, when I start with the quiz, I'll basically tell the rules of each round. Where are the people?
I please request the participants to take your places.
See, for your convenience, let the teams be A,
we have
B, C,
the
and
first
D.
participant from Alwas College of Physiotherapy. Please take your seats.
Team number 1.
Please give them a round of applause, everyone. The second team is from KG College of Physiotherapy. Let's give them a round of applause. Next. The next team for quiz is from St. John's, Bangalore. Please give them a round of applause, everyone. The next team, the last team for the quiz is Institute of Physiotherapy, Srinivas University. Please give them a round of applause, everyone. Over to you, Shyam sir.
So, I have basically devised 5 rounds. I told you every team has an equal opportunity to answer a question. So, the rule is that if you answer a question, there are 2 ways you can answer. Every question you can write down the answer and show it to me. If you show me the right answer, you have 10 marks. Or you have an option. If nobody is answering, you have an option to basically announce the answer. If you say it, you get 20 marks. If you don't, you get minus 10. So you have a chance of scoring negatives also. At the end, the scores can be minus numbers. It's okay? Is it fine? If the answers can basically, I think I will have to come down basic for the sake of seeing your answers. So, that's okay, no problem. So we'll basically start with to get an introduction to how the quiz is going to be. There is a mix of easy as well as tough questions. Okay? So the kind of questions that will come, the first question will basically make you understand. So this is the question. So the first segment is called as nature. So I'll start with the question. See, there is a specific structure which is marked. Move the board away, Please move the board away a little bit this side. Move the board that side. See, the portion that is marked on the mountain is named after a New Zealander who is born in 1919. The thing is that this natural formation is destroyed forever in an earthquake which happened in 2015. And it's a big deal because, it makes summiting that mountain much easier with that particular structure gone. You have to name the structure that I am talking about, which is marked on that picture. If you know the answer, write it down and show me. Or if nobody answers, you can announce it and get 20 marks full. See that there is a structure which is there. You can see that, before and after. You can see something big is gone in the second picture. Okay, say for example where it is marked number 3, something is gone. So that structure is named after somebody who was born in New Zealand in 1919, and it was destroyed in an earthquake in 2015. So you have to basically tell what that structure is. And after whom it is named, what is that structure called as? You have to basically tell. So I'll start with teammate. Do you have an answer? Do you have an answer? If you basically announce an answer wrong, you get minus 10. So 2 ways you can score. Either by telling wrong answers or, okay, so nothing. Do you have an answer? Do you have an answer? No. Do you have an answer? No. Do you have an answer? Are you sure? You have no answer. So none of the teams get any mark for this. So it is basically like, after the first question it is 0 marks. See, this is basically named after this man on the left. Do you know who that is? That is Edmund Hillary and Tenzing Norgay. It's named after Hillary, and that formation is called as Hillary Step. Hillary Step is the final obstacle towards the summit of Mount Everest. And since 2015, after an earthquake, it has been lost. So, I think the next question will be easier for you guys. See, audience, I don't think time will be there. Yeah, I'll pass on the question to the audience if you from now onwards. So this basically shows, a land between 2 continents. It's a 60-mile wide area which is filled with swamps, which is filled with mountains, rainforests, etc. It basically comes, the term for that particular piece of land comes from the native people's word for a river in the region. So this particular piece of land is very famous, or this particular connection is very famous. So I want you to name that particular piece of land, or real estate, or land, what is there. If anyways, the question is, I will start from here and rotate. So team B has an answer. Either you can write down or you can announce. That's your choice. Any answers? Team C? No. Do you have an answer? No, you can't ask me any doubts at all. After this, I will clear it. After the program. No. Rules is basically you can write and show me if it is wrong, no negative marks. If you announce it and show it wrong, then there is a negative marking. If you write and show me right, then you have 10, otherwise nothing you lose. Absolutely no. See, this place has been in news very recently. Can anybody in the audience identify? Oh, sorry, you have one more team. You have any answer? No. Anybody in the audience has an answer for this? Anybody in the audience has an answer? See, do you remember about a month back, people were sent back from US shackled in airplane, who basically took an illegal route to reach North America, that is United States of America. This place is called Darien Gap, and it is the gap between North America and South America, which is actually extremely difficult to navigate. So Darien Gap is the area which was shown in the picture, and it is basically infamous for human trafficking, and it has been recently in news because of the US policy of deportation, how people reach US. This is one of the major routes they take when they cross from South America to North America. So that the area was basically Darien Gap. We'll go to the third question. Unfortunately, nobody has scored yet. So next question basically. So this is basically a map, but what is of interest is not actually the map itself. See, there is a line which is there on the map. You can see there's a line which is vertically bisecting the map into 2 regions, and it is basically named after a person called as Alfred Russel Wallace. Okay, I want you to basically tell me, what does the Wallace line do? What does the Wallace line do? That is the question. So, it comes to team C. Do you have the answer? Nah. See, Alfred Russel Wallace, I'll give a brief history of Alfred Russel Wallace later after I answer this question. Any idea? Do you have an answer? Do you have an answer? Yeah. I'll basically give 10 marks to team A. Somebody has scored at last. Let's see. The time is up. The time is up. Anybody knows? Say Alfred Russell Wallace was the first victim of publish and perish culture. I'll tell you why. Because he simultaneously developed the theory of evolution by natural selection along with Charles Darwin. Charles Darwin was the first to publish it, so we know the theory of evolution in the name of Charles Darwin. But Wallace was as eminent a scientist who had studied the theory of evolution by natural selection. And this Wallace line basically is the line which separates the Australian fauna from the Asian fauna. That's the reason you don't see kangaroos and other things, because the region where the line is drawn are very deep sea trenches through which animals cannot pass from one part of the continent to the other. So, the significance is basically it divides the difference in fauna. That means the kind of animals like kangaroos and, platypus and all those things we see in Australia and we don't see in Indonesia or the nearby regions because of this Wallace line being there, the imaginary line being there. So now we come to the final question of round one. See, it never snows in South India. Though, there are places, people say there are, in Arak Valley and all, there are places where it snows in South India, but it has never. But in the year 1815, there is a record of snowfall having happened in Chennai because of a volcanic eruption. Now, the question arises how volcanic eruptions can cause snowfall. Basically, it plummeted ashes into the atmosphere in such a way that the sun was blocked, thereby dropping the temperature to a very great deal for months together. In July it happened, in December it snowed. So in about 6 months' time, the average sunfall which was happening on the earth was reduced, and as a result, the temperatures dropped to -3 in Chennai and there was a snowfall. Now this is basically considered to be a super colossal volcanic eruption, okay, one of its kind, the only one of its kind. What was this eruption called? It's very easy. If you name the volcanic eruption, you get the answer, that's it. That is the event which caused snowfall in Chennai, or Madras as it was called that time. You can write it down. Every team has an opportunity to write it down. This question goes to them. So you can either announce the answer or write it down. You can choose what to do. Any idea? Answers? Answer? Do you have an answer with you? I'll see this. Do you have any answer? Yeah, show me. No, it is not. You are very close, but it's not. Anybody knows the answer? There is an 1880s, the eruption was in 1887. Mount Krakatoa was in 1887, which was again a colossal eruption, not a super colossal one. But this is something else. What is the mountain? Any idea? This is basically the largest recorded volcanic eruption in the history of mankind, that means. Okay, it's called as like the eruption of Mount Tambora, which happened in July 10th, 1815. And this was responsible for the plummeting of temperatures. It is a supercolossal. Supercolossal eruptions are the ones which eject ashes to a height greater than 65 kilometers into the atmosphere. So, as a result, there was a global cooling down, and that is what led to the snowfall. And that brings us to the end of round one. There is nothing much to announce in form of scores. So, we have team A with 10 marks. Team B is yet to open their account. So is team C and team D. So, this brings an end to the first round of the quiz. Okay. So, we'll go to the second round now. The second round is basically science and technology. So, the questions are again, this is going to be very simple. Only thing is you just need to have some kind of lateral thinking. So, I'll start from this side now. Okay. So, you have a chance to basically score 20. Fine. I'll start with the first question. See, it is about a psychoactive substance which is called as 1,3,7-trimethylxanthine. It is psychoactive and it causes a eugeroic, ergogenic as well as nootropic effect. Okay. Now eugeroic means basically it essentially causes wakefulness. Ergogenic means it increases your work capacity, and nootropic means it basically increases your cognition. So it's a substance which is abused or it is used by a lot of people, okay, and it is essentially it is 137 trimethyl xanthine. So you basically write down the name of this substance, or you can announce the name of the substance. Please, you can 1 second. Okay, one. Then, do you have the answer? No. Huh? I'll give 10 marks to team D. Nah. Anybody in the audience? It is caffeine. The sinister drug is basically what you get in a shot of coffee. It's caffeine. Basically, 137 trimethyl xanthine is actually caffeine. Okay, it's not. It's not crystal meth. So we'll go to the next question. So this is basically, this is the image of a quasar. Okay, a quasar is basically a quasi-stellar object, which is basically the nucleus of a galaxy. Now this particular image has a name. It has a particular name, and it proves one of the postulates of classical physics. Now if you want further clue, this basically proves the presence of something which is called as gravitational lensing. Gravitational lensing is nothing but, space can act like a lens because of gravity. It will bend space in such a way that it will act like a lens. So this particular structure is a classic example of gravitational lensing. You have to name this structure. The name is very popular. See, and one more thing I'll tell you. You can see there's a central dot with 4 dots on the sides. It is actually all are the image of the same object. They are not distinct objects. When we look at it, it looks like this. But in reality, there is only one object, okay, which is lensed because of gravitational lensing, and you're observing it like this. Can you name the object? It's a celestial object. Can you name it? You are the next team. You have an answer? Yeah, sorry. No, man. You have an answer? No. Anybody has an answer? It is named after somebody. The person who postulated gravitational lensing. It's named after Einstein. Okay, this is basically called as an Einstein cross. It's called as an Einstein cross. Okay, an Einstein cross is a classical example of how space gets wrapped because of gravity. So, that's the answer. So, I'll go to the next question. The next question is for you, right? See, this is basically an object which was sent by India. This is the first solar exploration probe which has been sent by India. It is sitting at a distance of 1.5 million kilometers. It's called as Aditya L1. The question is, what is this L standing for? What does this L1 mean? In Aditya L1, what does L1 stand for? Very quietly discuss. Stands for the no. Anybody? See, anyways, done? No, right? It's okay. Anybody in the audience? What does Aditya L1 stand for? You want want to say it loud? No, it basically means L1 basically is that particular point at 1.5 million kilometers. It is called as Lagrange point. Lagrange point is the point between Earth and the Sun, where the gravitation of both the heavenly bodies is going to balance out the satellite without needing extra thrust. So that's why it's called as Lagrange point. It is stationed at a Lagrange point which is called as Lagrange point 1. So this is our solar probe. So you are expected to know what it is. So this is basically Aditya L1, which we had sent like 2 years back. The question next one is for you. For you? For you. This is for third question, fourth question, right? So this is Lagrange point. This is the scientific notation of the Lagrange point, where it is located, where Aditya L1 is located at this point of time. See this. Zolexma is basically is actually a gene therapy drug, the first approved gene therapy drug for a disease. Now, it might look very random to you, but this has a very big significance in Indian history. So, or the current history of India. So, I want you to basically identify the disease for which this drug is. I want you to identify the disease for which this drug is. Any idea? See, only 30, this is just 30 seconds actually. Do you have an answer? Do you have an answer? See, because anybody has an answer? Write it down. If you tell me, I will reduce your marks. No. No. Dude, if you give me 2 answers, I'll reduce marks. -10, -10 I'll take. Both are wrong. Nah. I'll give it to the audience. No, it's not for dengue. Okay, I'll basically, so nobody's answering. Do you have an answer, ma'am? Sorry? It is for spinal muscular atrophy. Why it became a news is because of this baby. She, the price of one vial of medicine is 16 crore. It is considered to be the most expensive medicine at this point of time. And she is the first recipient of this medicine in India. And it was crowd-funded. And that's the reason, it had come to news. So it is not like something which is a pharmacology secret or something. It is actually a popular issue for that matter. Fine. So that brings us end to round 2. Unfortunately, nobody has scored anything, I guess, in round 2. So, now we'll go to basically like a round where you could probably score. Okay. So let's see whether we can or not. So again, I'll start from this side. So, see, basically, I have given the names of various kinds of trauma. Okay, barotrauma, atlectotrauma, volutrauma, and chemotrauma. Okay, biotrauma. I want you to tell these traumas lead to what specific condition. It's quite direct. The answer has to be what condition does it basically lead to. If you know the answer, write it down. There is a hell lot of clue in the diagram itself. I mean, the names are there anyways. See, it doesn't cause 3 conditions, only 1 condition it causes. Yeah, you have only 1 chance. Okay? Yeah. Only once you can show me a written answer. No. Nah. Here's the answer. Sorry, no. No. Anybody in the audience? Sorry? No, not athlete axis. See, just think of it. There is an alveoli and you are talking about barotrauma. Baro means a trauma because of pressure. Volume trauma, a trauma because of volume. Now, when does volume and pressure go out of your own control and it's driven to somebody else? When you are ventilated. Okay? So this is basically the primary causative factor for ventilator associated lung injury. Valley. Got it? Otherwise, a precursor for ventilator associated pneumonia. VAP. Okay, so that's what this was. Okay. So, fine. You are the second question. So I'll go to the second question now. See, this is a very common phenomenon which you would see. It is there from Norkins, not my own question. Okay. So, basically the picture shows a ballet dancer in a step which is called as a pirouette. They'll have their hands wide apart, and when they bring it close, they spin faster. You have to tell me what physical law they are following, and you have to tell me what is that I and W there. What is L, I and W there? You can see that L, I and W. What are they? Done now? 30 seconds are done? Show me. Nah. Right, no problem. Anything? Nah. It's not.
Momentum and moment inertia.
No, the law is not complete. So anybody in the audience know the answer? Anybody in the audience know? Why do we spin faster when you come, or when you are rotating something in your hand? As you basically bring it closer, it rotates faster. Why does it happen? Because of? It's not because of inertia. See, it is basically a basic postulate of physics which is called as law of conservation of angular momentum. Okay, angular momentum is basically moment of inertia into angular velocity. Like for linear acceleration, momentum is mass into velocity. The equivalent of mass in rotatory motion is moment of inertia, which is mass into the distance at which the mass is located squared, mr square. And angular velocity is basically the speed of rotation. Okay, so this is basically see, when you basically bringing your hand closer, you are reducing the moment of inertia because your mass distribution comes closer. So the only way momentum can be conserved is by spinning faster. So that's the reason that happens. Oh, gone. So, so angular momentum and angular velocity. Okay, that is what it is. Fine. We'll go to the next question. Next question goes to you, isn't it? See, there is a paradox involved here. The paradox is that, see, obviously we have learned that hamstrings and quadriceps are antagonists to each other. That means the only way they can contract together is when one goes for an eccentric contraction, the other goes for a concentric contraction. But in activities like squats, or when you are getting up from a sitting position, okay, there is a phase when both the quadriceps and the hamstring go for concentric contraction. That means, which is paradoxical, which should ideally not be happening. What is that paradox called as? You know the name of the paradox? Any idea? Oh my God. So, anybody from the audience? The name of the paradox? It's Lombard's paradox. It's Lombard's paradox. Okay, that is where, it happens when you are ascending from a sitting position or a squat. Both quads and hams undergo a concentric contraction. So that is Lombard's paradox. Okay. Now, this particular molecule, see, it is, some of you, I'll make a very vague claim that some of you are very familiar with the similar molecule actually. Okay. This molecule has a Sanskrit name. The name of this molecule is basically rooted in Sanskrit. And it is basically believed to be released when you are exercising or when you are basically getting a modality like TENS. I want you to name the molecule. There are two molecules of same kind. One of them has a Sanskrit name attached to it. Name the molecule, and it is very similar to a molecule which many people here might be familiar with. Anybody knows the name of I want you to name the molecule. Any idea? No. I see, endorphin, enkephalin, it looks like Sanskrit to you. Huh? Anything? Come on, dude. Endorphinum, what is it actually like in Sanskrit? Okay, see, it basically stems from the word for happiness in Sanskrit, anandam. It's called as anandamide. Now, why this matters is because I really know that you recognize the molecule on the left. Tetrahydroxycannabinol. The one which is there in your joint. So, it is an endocannabinoid actually. One of the cannabinoid molecules which is produced by the body. Okay? And that is responsible for the sense of elation, the sense of happiness you get when you exercise, if you do actually, or when a TENS is applied. It is there for pain relief. It can basically increase the feeling of well-being. It's called as anandamide, and it is basically one of the endocannabinoids which is present in the body. So that was the end to that particular round. So this is which brings us to the last round before the bonus round. There is not much of scoring to say, anyways. So I'll go to the questions. I'll start from here. See, this is a martial art which is called as Thangta. I basically want you to see, there are martial arts which are originated in Kerala, which is Kalaripai. There are arts from Thailand, Muay Thai, Wushu from China, Karate from Japan, like that. From where has this martial art originated from? This is a very famous martial art. You need to look at the person, the people, everything is a clue for you. You basically tell from where it has originated. Thirty seconds. Oh yeah, sure. No, that's me. Okay. Any answer? Man, what is yours? Indonesia, Thailand, Korea, Shanghai. That is Chinese, and yours is Indonesia. See, you cannot recognize a fellow Indian actually. It is from Manipur. Okay, just because. See, this is so racist. It is basically from Manipur. The martial art is called as Thangta. It is from Manipur. Okay, it is the state martial art of Manipur. There are multiple martial arts in India. This and Kalaripai are the most recognized ones. I'll go to the next team, the next question. See, these are called as the vultures of Jungle Book. Okay, their names are Bussy, Flap, Ziggy and Dizzy. In the cartoon, that is the English version, note that Jungle Jungle Baat Chali Hai, but in the English cartoon, they had a thick Liverpool accent. I want you to tell me after whom they are fashioned. These vultures basically represent real people. Whom are they fashioned upon? You can look at the hairstyle and all those things. I'll come and see. You know, vultures, you see. You are good enough to announce it loud? Do you have the confidence? Wait. Do you have the confidence of doing it? I want to hear somebody's voice actually, that's why. Do you know the answer? No, wait. Let me just see everybody. Do you have... Okay, anybody has answer here? Do you want to announce it?
The Beatles.
Absolutely, the Beatles. They are fashioned after the Beatles. So they are basically fashioned after George, Ringo, Paul and... John, Ringo, Paul and George. That is in that order. Okay, they are fashioned upon the Beatles. That's why the thick Liverpool accent the vultures had. Okay. So, 20 marks for team D. Sorry, team A. Team A gets 20 marks. I'll go to the next question. Who is the next question for? For you, right? For them. So the first award ceremony was held simultaneously in 2 locations on 4th May 1959. You know, I basically want you to recognize this award. The first award ceremony was basically held in Beverly Hills as well as in New York. What is this awards called this? You are done? Show me. Write down. Do you want help? No. See, team A, B and D get 10 points each. What is the answer? It's the Grammys. There is a gramophone there, so it is basically the Grammys. Okay? It's the Grammys which was shown. One more question, right? To you. Last question is there. See, Robert Allen Zimmerman had won a Nobel Prize for Literature in the year 2016. Okay? But he created a controversy because he didn't respond to it. The Nobel Prize in Literature was awarded to Robert Allen Zimmerman. Okay? And there was a controversy because he didn't respond to the call and people assumed that he rejected it. Now I want you to tell me what is Robert Allen Zimmerman known as popularly? See, the Grammys was for literature, as the Nobel Prize was for literature. Answer? Sure? Okay. The other answer. Anybody in the audience? Anybody in the audience? Yeah? Any idea who this is? This is Bob Dylan. Okay, he was awarded the Nobel and he didn't respond. And people thought that he has actually rejected the award, but he hasn't, he has accepted it. Okay, it's basically American musician Bob Dylan for his contribution to poetry through his music. That's why he had won the Nobel Prize for Literature. So, I think that is the end of all the regular rounds. Now there is actually a bonus round. I'll basically come to that. See, in this round, I'll give you one clue after the other. There are 4 clues actually. Okay, it's open to everybody. There are 4 clues. If you guess the answer from the first clue, okay, you get 100 points. But if you basically like, making a mistake, you lose 100 points too. That means a plus 100 or a minus 100. Okay. In the second clue, if you guess, you basically get like 75 points. Okay. If you miss 75, you lose. If you get 75. Okay. Third clue 50, fourth clue 25. Okay, that is how it is. Okay. See, you can write down the answer if you get the answers correctly. I'll come and see at any question, if any team has got the answer right, I'll give you the marks for that. But like, if the answer is wrong, I'll reduce your mark also. Okay. So, I'll start. So, you try to basically guess the answer. Okay. And if from the first clue you get it, you get 100 marks directly. Ready? This is your first clue. You don't have to announce it, you just have to write it down. I'll go to the next clue. This is the second clue. See, if you're wrong, you are losing, like, are you sure? You want to show it to me? Huh? Next one you'll wait for? If you want, you can show me. You'll be there on the scoreboard, but in minus, like, I'll go to the next clue. Discuss within yourself, don't announce it. You write it down and show it to me if it is right, if you get the answer. See, you have 3 clues now. All are related. Okay? You have to guess the answer, that's it actually. It can be a person, place, thing, something it is. These are 3 clues which you had. Any idea? You got an answer now? Okay, I'll go to the last clue. This is the last clue. Anybody has got any connections? Write it down and show it to me, that's it. Anybody wants to take risk? At this point, if you give me a wrong answer, you lose 25 marks, that's it. Huh? This is the last round, next round. Last question, yeah. Anyways, time is done, I guess. See, इसके बाद कोई क्वेश्चन नहीं है, बस हो गया. Are you sure you are going to show me the answer? First team to basically score minus actually. Minus 25. Wait. Anybody in the audience can guess? I'll tell you. I'll tell the people actually. I'll tell the people. This is Gandhi. This is Idi Amin. This is Queen Elizabeth. And this is Truman Capote. Any idea what is that connects every one of them? No, now I'll go to the actual answer slide. That is Ben Kingsley, who played Gandhi. Forrest Whitaker, who played Idi Amin. Helen Mirren, who played the Queen. And last is basically Philip Seymour Hoffman, who played Truman Capote. They all won Oscars for portraying these roles. So the connecting thread between them is essentially like, you know, the people who have portrayed these people in movies have all won Oscars. So, you know, that is a connecting thread. So that was the bonus round. So, you know, anybody else said the answer no, right? Nah. No way. It's okay, no problem. How much you got? Oh, -5. If it was 0, at least -25 would have been there. So, you know, this brings an end to the quiz. There is no more questions to ask. I'm really thankful for the opportunity which has been given to me. I hope you all enjoyed it. I enjoyed. So, you know, hopefully it was good. So, thank you all for listening patiently.
Thank you, sir. It was really brainstorming and definitely enjoyable session. I'm sure everybody thoroughly enjoyed it. How did we? So the winner of the quiz is Group A. Where's Group A? That is Alvas, right? Alvas College of Physiotherapy. Huge congratulations to each one of you. Okay. Participants? Thank you, participants. Your certificates will be given to you all shortly. Thank you so much. I now request Dr. Prem Kumar, convener of Spark 2025, to present the memento as a token of appreciation to Dr. Shyam Krishnan. Thank you. Ladies and gentlemen, it is now our pleasure to introduce the final segment of the conference prior to the valedictory, that is the panel discussion. The esteemed panel will delve into the topic of the role of physiotherapists in multidisciplinary care in oncology and palliative care. Our discussion will explore the latest developments, challenges and opportunities in this crucial area of physiotherapy practice. Please join me in welcoming our distinguished panelist, Dr. M. Prem Kumar, Associate Professor, Institute of Physiotherapy, Srinivas University, Mangalore; Dr. Kuldeep, Assistant Professor, Department of Physiotherapy, Kasturba Medical College, Mahe, Mangalore; Dr. Pavitra, Assistant Professor, JSS College of Physiotherapy, Mysuru; Dr. Aishwarya Nitin Sonwane, Assistant Professor, Institute of Physiotherapy, Srinivas University, Mangalore. This panel will be chaired by Dr. M.S. Satish, Chief Physiotherapist and Scientist, Department of Physiotherapy, Dr. S.K. Campus Cancer Institute, Adyar, Chennai, Tamil Nadu. This discussion will be followed by Q&A session, giving you the opportunity to directly engage with our panelists. Without further ado, let us now begin. Dear delegates, may I please have your attention? I request everyone to maintain a little bit of silence with some patience. Thank you. May I please request one representative from the Alva's quiz competition to please come to the MC desk. One representative, thank you.
Hello. Sir, respected, not this. Respected Chairperson, sir, because of time constraint, initially we planned for 40 minutes. So one chairperson, one panelist could not come today. She's having some official work. So we will try to finish within 25 minutes. So I just request you kindly help us. Thank you.
Without further ado, I request Dr. Satish to please start the session. Thank you.
Yeah, good evening, one and all. So, topic. Okay. This panel discussion is on cancer rehabilitation, the advanced techniques and concepts. And I would request the first speaker, Dr. Kuldeep. Dr. Kuldeep to present his presentation. So timing is for 7 minutes, sir.
Good afternoon to everybody. So today I am going to speak plus discuss on the known thing only. So I'll move from the known thing to the known thing only. So basically the topic what I am want to address today is the clinical significance of considering the sagittal angle. Basically what we routinely used to take those angle to measure the head and posture angle. So whether do we measure those angle, it is really important in clinical decision making for patients with head and neck cancer. So first a brief intro I will give it to the head and neck cancers. The head and neck cancers, the prevalence is more throughout the India, and it is a heterogeneous. The cancer of the lung, the tongue, cancer of floor of mouth, then buccal mucosa, the pharynx. So all of those are heterogeneous. The different areas may get involved, and most of the cancers are basically the squamous cell carcinoma. And the spread of this cancer is very aggressive. So basically in clinical practice you can see that the cancer spread used to occur in a very shorter period of time, from 6 to 9 months even. And mostly the time when the patients will get diagnosed with this cancer, they will have very minimal symptoms. Something's unhealed wound, something will be there, or some pain or difficulty in swallowing and all. But following the diagnosis and the treatment, the real pictures of the after effect of this cancer will come. Basically with the treatment, like basically the surgery and the radiotherapy are the main line of treatment, and those treatment itself will cause maximum morbidity to the patients. So because of those treatment, after effect and ill effect, the patients will present with dry mouth, fatigue, pain, sarcopenia, even their mental functions will also get affected. So from physical therapy point of view, what we have to address both the physical and the mental health of those individuals or the sufferer. So most common presentation, usually they will have difficulty in opening mouth and shoulder and neck dysfunctions. So, next slide. So, in general, the conventionally the physical therapy assisting for managing the shoulder and the neck problem, then locked jaw functions, swallowing and communications, lymphedema, pain management, and even for prevention of secondary complications like fibrosis and all. So, there is very limited literature in this field from physiotherapy part. So, most of the literatures are of cross-sectional design where they have identified the problem and they have checked the correlations only. But very few literatures are there which have addressed regarding what is the clinical practice guidelines or whether there is any definite protocol for managing those patients with multitudes of problems. So one literature, I have got it from Asian Pacific Journal of Cancer Prevention, where they have seen the clinical practice adopted by the physiotherapist in Saudi. So where they have assessed near about 200 physiotherapists from different centers, from secondary health centers to tertiary health centers, and they have found it out that the method of assessment and the treatment what the physiotherapists are providing to the patients with head and neck cancers, and most of the response were basically on functional assessment or based on the symptoms management. Patient with locked jaw will be managed for locked jaw only, patient with head and neck shoulder will be managed for head and neck issues only. So none of the physiotherapists have even reported regarding what is there any defined plan or course of treatments. So in our routine practice, basically for normative populations, what we used to do postural assessment. Routinely the postural assessment will be done on direct observation and the plumb line, but we'll never take into a definite considerations how the severity of those postures are there. And those basically the sagittal angle such like sagittal head tilt, then craniovertebral angle and forward shoulder angle. So those angle will define more biomechanical concept. Basically, when you talk about the head tilt angle, they will tell about the head orientation on the cervical spine. So either head is oriented in flex position or extension position. So indirectly it will talk about the upper cervical. So craniovertebral angle will tell about the forward head angle. So those forward head angle, there are number of literatures are there basically with postural evaluations and all, but none of the literatures are there on patients with head and neck cancer. Thirdly is the forward shoulder angle. So that will tell about a protected shoulder, where the shoulder will produce the changes even in the scapula by making the scapula abducted and the winging. So all those postural angles, so any changes in this postural angle will definitely affect the flexion moment of the cervical spine. And those flexion movement of the cervical spine will basically affect because of the changes in the land tension relationship. And those land tension relationship, when we will go for more definite, basically the flexor muscles, deep neck flexors, the longest colli muscles, they will be elongated. Though they will be elongated, they will become weakened. They will become weak in their strength. Whereas the other muscles like sternocleidomastoid, mastoid, then scleny muscles and the capital extensors, they will be shortened and they will become tight. So those changes will even produce secondary changes on the shoulder and even the thoracic spine. So that will affect the line of gravity. So usually the line of gravity should pass to the anterior to the thoracic spine. So, but because of the all changes in the any of the angulations in any of those three angles will change the angulation at the thoracic spine. So those changes in the angle will definitely not only affect the craniocervical, but it will also affect the cervico-shoulder associations, or even we can say is craniocervical mandibular system. So which will indirectly affect the respiratory part. So in patient with head and neck cancer, we can see the patient who have a locked jaw issues, they will also have the breathing issues and plus other functional issues. So this sagittal health angle, forward head posture and forward shoulder itself, so the orientations of the line of gravity will get changed, and because of those change in the line of gravity, the entire upper quadrant of the body will get affected. So indirectly those angle alteration not only affect the regional part of the issues, but also it will affect the respiratory, and indirectly it can have an effect on the fatigue and the severity of the conditions. So in our routine clinical practice, whenever we are treating any patients with head and neck cancer, we are treating each part or each problem separately. So if we will incorporate the measuring those angle as a assessment method instead of measuring directly the range of motion or strength, then definitely we will give an clear pictures of the biomechanical changes, and that biomechanical changes will help us to define a protocol based treatment or a clearer concept. So it requires careful evaluations and thorough planning for getting those remedial measures. So to further explore these biomechanical factors, what we need is, we need to have more research on these areas, basically how the severity of forward head or sagittal part will affect the other regional symptoms or the part of the patients. Thank you.
Thanks, Dr. Kuldeep. We'll take the questions at the end, okay? So it is sort of the next speaker, Madam Dr. Pavitra.
A very good evening to all. Today in the topic of pediatric oncology, I'm going to share my experiences and the few guidelines of the pediatric oncology rehabilitation. So starting with the burdens of disease, India, it is coming under where the low middle income countries, and it is a developing country where we are going to have the researchers and we are going to have the guidelines which we have taken from the World Health Organization. So in India, where leukemia is the most incidence and the mortality rate is higher, where our rehabilitation part in the leukemia is going to be very minimal, and we are going to treat for the conditions of the kids who have sarcomia, and the amputation post-surgical managements only we are going to have. Coming to the distribution of pediatric cancer types, it is accounting for 27% about leukemia, and brain tumors it is accounting for 23%, where our management in the physiotherapy rehabilitation we are going to give for 23% of the neuro rehabilitation and your soft tissue sarcomas. So what are all the reasons that the pediatric rehabilitation would be given? The reference are where the child have gone for a surgical correction or amputation, peripheral neuropathy, altered mobilities, weakness, deconditioning, where what is meant by deconditioning is where the child with any of the cancer types, they will going to have 1 to 1.5% of deconditioning in the muscular system. That is accounting for 10 to 15% of muscle weakness per week. It is because of the post-bedridden complication where after the child receiving the chemotherapy or any surgical therapy, the bed rest complications that it leads to the pain and the muscular dysfunctions. So in spite of having the reasons of rehabilitation, what are all the reasons that the child is not receiving a proper rehabilitations are? It is because of the inadequate funding, because the time where the child crosses the chemotherapy and the surgical therapy and the the psychological and the emotional status of the child and parents, that it is going to lead a rehabilitation phase towards an end. And lack of availability of the research or the spaces, lack of rehabilitation professionals, and few other administrations in the child with the cancer. So where we have very minimal centers that exclusively for a pediatric rehabilitation, and patients referred to the rehabilitation for program is not for the oncology specified, where in our country it is a low middle income country, where after the chemotherapy or after the surgical correction only they are going to come, and there is no proper rehabilitation references, and lack of evidence for the support, and a small pediatric oncology population. So coming to the assessment, in the assessment, so where we are going to form the ICF format assessment, where it is going to tell about the body structure, function, and activities and participation, where the child with oncology, they have the problem of deconditioning and limited in the participation. Documentation regarding the concentric factors. So what are all the contextual factors that is going to contribute in our rehabilitation is your personal factors, environmental factor, where personal factors, age, gender, the reliance, motivation, confidence of the child, goal, and adherence, where what type of, it is based on the type of the oncology that the child is undergoing through and the method of treatment what the child is undergoing through. Coming to the environmental support, where family, social, and school support, it is not going to help only in the child and the physically, but it is also gives a psychological support for the child, in whether the child is going to be an inpatient or an outpatient, and the cancer center research how effectively the child is receiving the holistic approach. So coming to the assessment, so what are all the assessment we are going to take is the neurological assessment. Neurological assessment, it is based on the development, like your whether the child have achieved the milestone or age appropriate, the domains of development, whether the child have achieved communication, feeding, oral motor, participation, dependent of living, that is basically your quality of life. So what are the guidelines we have? The guidelines, the guidelines we have are condition specified. The condition specified guidelines we have acute lymphoblastic leukemia, central nervous system tumors, Hawkins lymphoma, and bone cancer guidelines we have. And impact specification, the impairment specifications are fatigue, neuroconductivity functions, chronic pain, long-term follow-ups, and adolescence, and additional rehabilitation recommendations. So the management of the pediatric oncology is going to have with the efforts. So what are all the efforts that what the management we are doing is, first one is your fitness or fatigue. Next comes your functioning, family, friends, fun, and your future. So these are the basic terms or the concepts we are going to work. Fitness, it includes the endurance, energy, agility, balance training, coordination training. 2 minutes, ma'am. 2 minutes. And function. So coming to the family involvement, friends, so where in pediatric setup at the age where the child has to have the peer group involvement and development is not only with the family, where here we have the challenge with the immune suppression system in the oncology. And fun, Fun is also an important part and it is coming under the ICF component. So coming to the future shaping. So future shaping, it is a neuroprogressive condition where you're going to set a realistic goal that is going to achieve according to the child's ability, identify the child's need, and your rehabilitation is going towards your reaching the goal. Guide the child or educate the child and advocate how you can simplify the rehabilitation according to the child. So coming to the conclusion, so where the child will be experiencing number of issues, don't think about the ocean, just think about the drop of water that is going to make the change. That is your ability of the child or the forcing of the child, what the child have to achieve. There your strengthening a child or a teen to fight against the cancer with a smile on the face and hope on their hearts. So coming to the conclusion, each and every child who is fighting against the cancer is a hero, and our role is to identify the child's ability and boost up the child's ability and not overstraining the child. Thank you. And I thank the organizers for giving me this opportunity. And thank you, sir.
Thanks, Dr. Pavitra. Now on to the next speaker, Dr. Aishwarya.
What? I'll just check. It works. You will see. Good afternoon all. So I'll keep it short. My topic for this panel is rehabilitation in and out of community for geriatric cancer patients. So why geriatric population? Firstly, they are the growing population and the incidence of cancer among them is higher. Secondly, they have a dual challenges. Firstly, aging, where they are already deteriorating into the systems, plus they are caught with the cancer. So it is necessary to highlight this. And thirdly, when we give a rehab, it improves their function, independence, dignity, as well as quality of life. So rehabilitation, when we talk about in-community rehabilitation, it is a indoor or a community-based where we give home-based physiotherapy, caregiver education and support, whereas community health workers that contribute for the cancer rehabilitation, tele-rehabilitation, digital platforms where they don't have to actually involve into the rehab, but tele-rehabilitation will be given. Then community centers with different wellness centers where they can go and rehabilitate for the cancer survivors. Main benefits of this is accessibility, cost effectiveness, social integration and continuity of the care. Next is when we talk about the community out program for the cancer rehab, we have basic, that is hospital-based multidisciplinary teams, inpatient or daycare centers, cancer rehab clinics, palliative care and geriatric oncology rehab, which is a proctored or the protocol-based rehabilitation given for the cancer. And the benefits of this is specialized expertise care will be given, access to the technologies and incentive monitoring will be there for them. So in spite of all this, they will experience lot of issues based on psychological aspect where they suffer from the depression, anxiety and less quality of life. So this one evidence that I have quoted, they say that when we incorporate the exercises for them, they tend to reduce the symptoms of depression and anxiety, whereas they improve the quality of life. But as a physiotherapist, we face lot of challenges when we are talking about exercises and making them do the exercises for the cancer survivors. Next evidence is about the tele-rehab. it has a controversy. It is a 50-50%. They have welcomed, the cancer survivors welcome the tele-rehab because it is in their comfort zone, they can sit and take a rehab. Whereas the improvement that was seen was not that much into the tele-rehab, whereas they preferred more for the inpatient or the individualized treatment where they go to the therapist, take a counseling and perform the exercises for the treatment. And the third and last was reasons for non-participation into the cancer rehab. So most of the patients, they prefer not to take any public support or public involvement into the cancer rehab. They told our family and friends are enough for us to take the rehabilitation or give us support. From your side, we don't want it. That's how the reaction towards the cancer rehab, the cancer survivors showed, especially the geriatric population. But in spite of this, whether we are giving a individualized care or a community-based care, when we focus on to the community-centered rehab, that time we have to focus actually how they perceive the cancer and how we have to focus on the rehab for them, especially when they perceive it in a negative manner. Thank you. That's it for me.
Thanks, Dr. Aishwarya.
So thank you for the introduction. Actually, I will take 2 minutes because it should not be abruptly finished. Their valedictory function going to start. Go with my slides. Actually, cancer is a very challenging condition to treat, particularly in a rehabilitative aspect. And in that, cardiac cancers are again very huge task for physiotherapists to do our role. I am asking all the audience, go to next slide. The cardiac cancers, the prevalence is rare. Primary and secondary, it is almost secondary, and benign and metastatic, it is metastatic. I am asking one question because all you attended the quiz, why it is rare, cardiac cancers? Cardiac muscle, cardiac, that organ, the cancer related to cardiac is very rare. Okay, I will tell the answer. The first organ matured in the fetus, it's cardiac, and it is having a half-life period for long, and the mitotic changes happens. It's not happening like in any other cells like in heart. So that, sir, I will discuss with you. Yes.
So cardiac muscles are technically fixed post-mitotic cells. So
Yes.
once they develop, they don't undergo mitosis anymore.
Yes.
And
So
that
it
is one
will
of the
not
reasons.
go for mitosis. Okay, once it's developed. So it is having a strongest resistance against cancer. Next slide. So I am going to quote 3 studies. Next slide. One is about prevalence and what are the kinds of cancer. Second one, slide next. The exercise induced protective effect on anthracycline damage. And one more thing, one more slide. Protective effect of exercise on molecularly targeted therapy damage. Okay, the final point is, I have gave my topic like that, whether in reality we need cardiac rehabilitation for cardiac cancer or it is overhyped. The answer is, it is indeed need based on 2 physiological changes, the studies done on animals, that gives you that the biochemical changes happens at cell level and mitochondria. The exercise is giving you the resistance in 2 aspects to improve the calcium channel activity, and it is helping to resist against the cancer cells. So exercise is helping any kind of cancer, including cardiac cancer. So in that sense, in reality, this is a need and it is not overhyped. We don't know, after some time, people will come for cardiac cancer rehabilitation also towards you. Thanking you. We are going to, my session is finished. Thanks.
Thank you. So as we are about to start the validatory function, I don't think we have time to take the questions. So it was a nice interaction and panel discussion. Thanks.
Actually, on behalf of sir, I am giving a concluding message. Because of technical reasons and timing, we are abruptly stopping this. But cancer is the main mode of way for the challenge of physiotherapists, because So many people don't know you are having cancer rehabilitation MPT courses also, MPT in cancer rehabilitation. But I don't know what they are really reading there. Okay, so it should be evolved and it will be the challenge coming years. In that sense, we kept this panel. We will once again come and with a great experience of Dr. Satish. He is working in Adaya Cancer Institute more than 25 years. He is having so many case experiences. So we will come again for the panel presentation in the next conference to conclude this. Thank you very much.
I now request the chairperson, Dr. M.S. Satish, to present the mementos and certificates to our distinguished panelists. Go, go, go. Dr. Prem Kumar, Dr. Kuldeep, Dr. Bavitra, and Dr. Aishwarya Sonwani. I now request Dr. Kamala Kannan. I now request Dr. Kamala Kannan, Associate Professor, Institute of Physiotherapy, Srinivas University, to kindly present a memento to our chairperson, Dr. M.S. Satish, in appreciation of his leadership during the panel discussion. Dear delegates, may I please have your attention? Ladies and gentlemen, we will now begin with the valedictory function very shortly. So I request everyone to be kindly to be seated quietly. Thank you. May I have student volunteers boys to please come to the MC desk quickly. Student volunteers boys.
Sir, here only, no?
ಆಯ್ತು
Good evening, everybody. Are you all excited to know the winners of all the competitions that were held in the 2 days? Yes or no? There should be a little louder excitement because it's at the end now. Yes or no? Okay.